Hello.
Good morning, everyone, and a very warm welcome to day 2 of BDCON 2026. We are your hosts for today. I am Dr. Anurag Banerjee.
I am Dr. Ronita Mukherjee.
We hope you are refreshed and ready for a full day of science, discussion, and exchange. The program today takes us across diabetes, obesity, perioperative endocrinology, complications, and metabolic disorders. So, to begin today's session, I would like to invite our very own Dr. Tarknath Chattopadhyay sir to please come on stage and start the day with your encouraging words.
Good morning, everyone. Good morning to everyone, and a very warm welcome to day 2 of the 11th annual Bengal Diabetes Conference, BDCON 2026. It's wonderful to see this hall filling up with so many familiar faces and many new ones too. Yesterday, we opened the proceedings with our pre-conference obesity assessment workshop, where we had outstanding session on anthropometry, body composition, sleep apnea assessment, led by the experts from Kolkata, Bardhaman, Durgapur, and as far as Prayagraj. The discussion carried on well into the dinner, and I want to thank every speaker, delegates, chairpersons, who made that evening intellectually rich and warmly collegial. Today is, without exaggeration, the heart of this conference. Over the next several hours, we have 12 scientific sessions lined up, covering everything from diabetic foot care, perioperative endocrinology, to the latest GLP-1 receptor agonist, metabolic disorders, and endocrinology in pregnancy. We will hear from faculty traveling to us from Kolkata, Delhi, Mumbai, Bhubaneswar, Patna, Jamshedpur, Delhi, alongside our own experts from Durgapur. Do stay tuned through the morning for our Bengal Diabetes guest lecture by Dr. Manoj Chadda and the plenary session by Dr. Raman Puri. The day will culminate this evening in our formal inaugural ceremony, in which His Holiness Divyanandaji Maharaj will be present. And it will be followed by the prestigious Dr. APJ Abdul Kalam oration, a session I know many of you are looking forward to. But before any of that, before the slides, the debates, the case discussion, we begin, as any conference on diabetes and metabolic health disease should be, by looking inward. We spent these 3 days talking about insulin, glycemic targets, cardiovascular risk factors, and the newer molecules reshaping our practice, and rightly so. This is where the science is moving the fastest. But we sometimes forget that some of the oldest, simplest tool we have, movement, breath, lifestyle, which is remain foundational to everything else we do. And also in our day-to-day practice as a physician, the medical legal problems and all the other litigations we deal in a day-to-day manner. So it's my privilege, therefore, to open the day 2 by inviting a session that grounds us before we go on to the science ahead. It will be a session comprised of 2 talks by 2 relevant speakers, a yoga and lifestyle modification and medical ethics session. So, as we prepare for a full and intellectually demanding day ahead, I invite you all to take these next few minutes not as a formality, but as a genuine reset for your body, for your breath, and or for your focus. Thank you, and once again, welcome to day 2 of BDCON 2026.
Thank you so much, sir, for your cheering up moment. Now we start our day to an important subject that sits at the heart of responsible clinical research, medical ethics in clinical trials. I would like to call Dr. Deepak S. Bhattacharya on the stage for moderating the next session.
Good morning, dear colleagues. Welcome to this session. And first of all, I am deeply grateful to the Bengal Diabetic Foundation for giving me this opportunity to moderate this session. So, coming to our session, so first topic is most important aspect of evidence-based medicine, that is clinical trials. So for this session, to chair this session, I invite, may I call upon the stage Dr. Rakesh Kumar. We all know him. He is a renowned diabetologist practicing in Durgapur. Over to you, sir.
Thank you, Bate, for nice introduction. We all know that in today's scenario, we must be adhering to the evidence-based medicine, and also from the medical council, we need to do a session on the medical ethics to get the credit hours. To speak on this, we are having Dr. Arindam there between us. So, Dr. Arindam, please come on dais and start your session. Thank you.
Good morning, everyone. Thank you to the organizing committee to get me chance to deliver the pitch on medical ethics in clinical trial. This is a very, very important topic, and in nowadays, because laws are very important for all every doctor who are in practicing and who are engaged in different part of the treatment care. Now, what is ethics? Ethics means what is right and wrong. A study of a base of principle decline right and wrong, the analysis of the progress by which we decide what is right and what is wrong. Next is medical ethics, a field of applied ethics, the study of moral values and judgment as they apply in medicine. As a scholar's discipline, medical ethics encompasses its practical application in clinical setting as well as work in the history, philosophy, theology, sociology, and anthropology. Medical ethics has long history, starting from 2700 BC, that is the first in Egypt. In Hindu physician Buddha's oath, that is 15th century of BC. This is the whole history of the medical ethics. Next, what are the ethical principles? First, principle of non-beneficence. Second, principle of beneficence. Third, principle of autonomy. Fourth, veracity. Fifth, confidentiality or fidelity. And last is the social responsibility and justice. Let's talk one by one. First, non-maleficence. This is the required that the procedure does not harm the patient involved or other in society. That is, first is the concern about the first, do not harm the patient or the volunteer, do not harm. Second, sanity of the life, be aware the doctrine of double effect. That means where the treatment intended to good, but ultimately it causes harm. Principle of beneficiaries, that is the required that the procedure to provide with the intended to doing good for the patient involved. Demand that the healthcare provider develop and maintain the skill, knowledge, continue update, thinking, consider individual circumstances as well as patient and service for the net benefit. Patient welfare is the first consideration. All healthcare providers must after the importance of the patient health to do the most good for the patient in every situation. What is good for the patient may not be good for the, what is the good for one patient may not good for the another. So such situations should be considered individual. Autonomy. What is people who have right to control what happened in their body. So the principle simple means it is the informed, competent adult patient can refuse or accept treatment, drug, surgery according to their wishes. Very important. People who have right to control what happens in their bodies because they are free and rational. The decision must be respected to everyone, even those decisions are not the best interest of the patient. Veracity, that is truth telling and obligation to full and honest disclosure. Confidentiality, based on the loyalty and trust, maintain the confidentiality of the all personal, medical and treatment information. Information to be revealed with the consent and for the benefit of the patient. And last, the except when it is ethically or legally required, and disclosure should not be beyond what is required. Justice. It is the complex ethical principle with meaning the range of the fair treatment individual to the equitable allocation of the healthcare dollars and resources. Justice is concerned with the equitable distribution of the benefit and burdens to individual of social institution and how this right of various individuals are realized. Allocation, scarce medical resources, be able to justify your action in every medical situation. World Medical Association Declaration of Helsinki, Ethical Principle for Medical Research Involving Human Participants. First adopted by 18th WMA General Assembly, Helsinki, Finland, June 1964, and the last amendment was done October 2024. Preamble of this declaration are the World Health Medical Association, WMA, has developed the Declaration of Helsinki as a statement of ethical principle for medical research involving human participants, including research using identifiable human material and data. The declaration is intended to be read as a whole, and each of the constituent paragraphs should be applied with consideration of all other relevant paragraphs. While the declaration is adopted by a physician, the WMA holds that these principles should be upheld by all individual teams and organizations involved in medical research, as these principles are fundamental to respect and the protection of the research participant, including both patient and healthy volunteers. General principle first, declaration of the Geneva of WMA binds the physician with the word. The health of my patient will be my first consideration. This is the duty of the physician to promote and safeguard the health, well-being, and right to the patient, including those who are involved in medical research. These physician knowledge and consciousness are dedicated to fulfillment of his duty. Medical progress in best of research and ultimately must include study involving human subject. Primary response to medical research involving human subject is to understand the cause, development, and the effect of the disease and improve the preventive diagnostic therapeutics intervention. Even the best proven intervention must be evaluated continuously to the research of safety, effectiveness, efficacy, accessibility, and quality. Medical research is subject to ethical standards to promote and ensure respect to all human subjects and protect them health and rights. It is the duty of the physician who are involved in medical research to protect the life, health, dignity, integrity, right to self-determination, privacy, and confidentiality of the personal information on research subject. The responsibility for the protection of the research subject must be always rest on the physician and other healthcare professional, and never with the research subject, even though they are given consent. Physician must consider the ethical, legal, regulatory norms and standards for research involving human subjects in their own country, as well as the applicable in international norms and standards. No nation and international ethics or legal or regulatory requirements should be reduced, eliminate, or any protection of the research subject set forth on this decision. Next, informed consent. We all know the informed consent. Usually, the informed consent consists of the following subheadings: patient information sheet, nature and the purpose of the study, duration of the participant with the number of participants, procedure to be followed, investigation if any, possible risks and discomfort, benefit of the participant, community, medical profession, policy and compensation, medical treatment for injury or risk, alternative treatment if available, step taken for confidentiality, no less or benefit and no loss of benefit on withdrawal, benefit sharing in event and commercialization, contract details of principal investigator, PI, that is local PI or co-PI in multicentric study, contact details of the chairman of IEC for applying against violation and right, voluntary participation, if the test for genetic and HIV counseling for consent for testing must be given prior guidelines, storage period of the biological sample and data, copy to the participant. Scientific requirement and research protocol. Medical research involving human subject must conform of the general acceptance of scientific principle on the based through the scientific knowledge, literature, other relevant sources of information, and adequate laboratory and appropriate animal experimentation. Protocol should include information regarding funding and sponsor, institutional affiliation, potential conflict of interest, incentive to the subject, and information regarding provision for the treating and compensating subject who are harmed as a consequence of the participation in clinical trial. Protocol must be describe appropriate arrangement for post-trial provision. Research Ethics Committee. Committee must be transparent in function, independent to the researcher, sponsor, and other under influence, duly qualified, take into consideration the law and regulation of the country. Research Ethics Committee must have the right to monitor ongoing studies. The researchers must provide monitoring information to the committee, especially inform about the serious adverse event. No amendment of the protocol may be made without consideration and approval of the committee. After the end of the study, researcher must submit a final report to the committee containing the summary of the study finding and the conclusion. This committee consists usually 7 to 9 members, 1 chairperson, 1 and 2 basic medical scientists, 1 and 2 clinicians from various institutes, 1 legal expert or retired judge, 1 social scientist, 1 philosopher, 1 layman person from the community, member secretary. Duration of the members is usually 2 to 3 years. Component of medical ethics, that is physician-patient relationship, physician-physician relationship with physician and healthcare system, relationship with physician and society. Ethical issues various research setting, epidemiological study, drug trials, vaccine trial, medical device and diagnostic device, tissue and organ transplantation. Next, the drug trial. Drug Controller General of India, that is the taken of the permission, approval of the IC, all guideline principles, irrespective of the place of discovery of the drug, risks, benefits should be favorable. It should be restricted at per international standard RCT, should be carried out in equipped center, preferably clinical pharmacologist involved, use of placebo drug or slum surgery, self-limited disease where there is no proven prophylactic, diagnostic or therapeutic method exists. In drug trial phase 1, change of the protocol, approval of the IC must, standard, start from the lowest dose, subpopulation, duration between two trials of the same volunteer, 3-month minimum cap between these trials, compensation is given for the sponsor and insurance. Phase 2, the dose used in lesser than the highest dose used in phase 1. Phase 3 trial must be through Indian patient. No open, non-comparative trial are unethical. Does not require approval for phase 4 trial. Now, multicentric trial, acceptance of the protocol of any center, approval of the IEC, meeting at initial and intermediate stage, central monitoring committee, training is very important, uniformity for procedure, data entry in case of record, ethics and good clinical practice. Monitoring and reporting of the adverse reaction or event. Unexpected adverse event or adverse drug reaction or any small adverse effect, that is investigator to response to the sponsorer within 24 hours, investigator to the ethical committee within 7 days, death information must be given within 24 hours, and then evaluate and discuss medical management of adverse event and financial plan for retrieval of injury. Ethical issue in modern healthcare. Ethical in modern healthcare and research, value conflict arise. Often there appear to be no clear consciousness as the right thing to do. These conflict present problem require moral decision and necessity to choice between two or more alternatives. Examples. Should a parent have right to refuse immunization for his or her child? Does public safety supersede an individual right? Questions are, should children of serious birth defect be kept alive? Should a woman be allowed an abortion of any reason? Should terrorists to be tortured to gain information, possibly saving hundreds of lives? Who should get the organ for transplantation? Another question, research continue for stem cell research cloning, genome project result, and fertility research. Should organ for transplantation is able to purchased? Should people suffer from any genetic disease where future misery is predicted be allowed to have a children? should individual be allowed to use scare healthcare resources when death is inevitable? Tries in disaster management. Thank you.
Thank you, Arindam, for a fantastic session. So, any question from the audience? Well, in that case, Arindam, what are the research settings where we can request for the exemptions from the IEC?
Research setting exemption for the IC. If any secondary data analysis, there is a chance of exemption of the IC, but it is not usually done today. We encourage every research should go through the IC protocol, but it may happen when we do and work with secondary data analysis, maybe.
And one more very practical consideration is, question is, we as a clinician receive multiple real world experience study protocol from different pharma companies. So basically it's a multi-center trial. So do we need ethical approval from all the study site?
No.
Or
Only one side, only.
Only one side. So latest guideline for the IC.
Only one center should be.
Or any local permission is required? Or?
Local permission may be legal. That is separate issue. For any law and order problem, that is separate issue. And any using of secondary data, that is a local issue. But ethical committee will give the permission for the research. Other permission for the continuum of the research for local permission.
Thank you.
Okay, I have one question, sir. I want to know your insights about this. Is it ethical to conduct a trial in low economy region if final approved drug or therapy intervention is too costly for them?
Some and cancer drug trial is now, that is the mainly for the which has huge cost, but trial phase, that is the occur in who are not get the drug by purchasing. So maybe because the chance of the survival of that patient is very low. So may we get a chance, it is my opinion, but ethically it should not be done.
Thank you. Sir, again I have one question that what are, for our audience, just tell what are some of the extra concerns we have to consider when conducting a trial in vulnerable population like children or patients with mental illness?
Informed consent is very important here. For children, that is the consent of the mother and father, and both is very important. And in mental health problem, that is the researchers should keep in mind that if the mental state of the patient is not enough to give the consent, then the caregiver will give the consent.
Thank you, sir. Thank you, our speakers, for their brilliant insights. So now coming to our second topic, that is the most important aspect in diabetes management, that is the lifestyle modification. And for this session, may I call upon the chairperson, Dr. Neeraj Kumar Kalotia, for chairing this session. And we all know him. He is a renowned diabetologist and internal medicine specialist. Over to you, sir.
Hello. Good morning. So the history of Bharat is deeply intertwined with the yoga, as Patanjali Sutra says that yogas with Nitya Nirodha means yoga is the cessation of the fluctuations of the mind. So let me invite Dr. Joyita Mitro Madam, who is a renowned physiotherapist and yoga guru, to take us through yoga and lifestyle modifications. Madam, please.
Hello. योगस्तः कुरु कर्माणि संग त्यक्त्वा धनंजय सिद्ध सिद्धो समो भूत्वा समत्तम yoga uchyate. This is a verse from Bhagavad Gita that means establish in yoga, perform your duties with equanimity, abandoning attachment to success or failure. Such evenness of mind is called yoga. Good morning, all the respected dignitaries present here. I am Joyita Mitro, the founder and CEO of Relief Durgapur Physiotherapy and Yoga Therapy Clinic. For the past 28 years, I have been practicing both yoga therapy and physiotherapy, integrating these two disciplines to provide holistic, patient-centered care. Over the course of my professional journey, I have had the privilege of treating more than 1 lakh patients with a wide range of musculoskeletal conditions as well as lifestyle-related health challenges. I am also a gold medalist in yoga therapy. My clinical experience has strengthened my conviction that an integrated approach combining physiotherapy and yoga therapy with evidence-informed yoga can significantly enhance patient outcomes. I believe that appropriate movement, therapeutic exercise, breathing practice, and individualized yoga intervention can play a valuable supportive role in the management of chronic lifestyle disorders, including diabetes. It is my privilege to be here today to share my experience with yoga therapy in diabetes mellitus. When we discuss diabetes today, we often think about medication, diet, exercise, and monitoring blood glucose. While all of these are indispensable, there is another dimension of care that addresses the individual as a whole, not only the disease, but the person living with the disease. That is where yoga therapy finds its role. Today, I would like to discuss how an individualized evidence-informed yogic approach can complement modern medical management to improve not only glycemic control, but also mobility, pain, stress, sleep, and overall quality of life. Before discussing yoga therapy, it is important that we first understand what yoga actually is. Rishi Patanjali defines yoga as yogash chitta vritti nirodha. Yoga is the cessation of the fluctuation of the mind. This definition immediately tells us that yoga is much more than stretching or flexibility. In clinical practice, yoga is multidimensional discipline involving the body, breath, mind, behavior, awareness, and ultimately lifestyle. When we begin viewing yoga through this lens, it becomes much easier to understand why it has therapeutic relevance in chronic disease such as diabetes. Many people ask me why I often say yoga instead of yoga. The original Sanskrit word is yog, derived from the root yuj, meaning to unite, to join, and to integrate. In many Indian languages, such as Hindi and Bengali, we naturally pronounce it as yog. The English word yoga is simply a transliterated version that became popular internationally. Both are understood, but I personally prefer using the traditional pronunciation whenever possible. Yoga has evolved over thousands of years. Different ancient texts classify yoga differently, and numerous traditions have emerged throughout history. Rather than attempting to cover every school, I want to clarify the framework from which my therapeutic practice comes. The therapeutic principles presented today primarily draw upon Hatha Yoga while incorporating the broader mental discipline described in Raj Yoga. This distinction is important because therapeutic application depends upon systematic principle rather than isolated posture. Every therapeutic system has foundation. My own practice is based upon the classical principle of Kathia Baba tradition of Hatha Yoga, following the teaching of Swami Shantadas Ji, Swami Ramdas Ji, and Swami Dhananjay Das Ji Kathia Baba. I would also like to make one important distinction. Traditional Hatha Yoga differs considerably from what many people recognize today as commercial studio yoga. In therapy, the objective is never performing advanced posture. The objective is improving function, restoring balance, and promoting health in an individual manner. Diabetes is not caused by one single factor. It is the result of an interaction between genetics, obesity, physical inactivity, stress, inadequate sleep, unhealthy nutrition, aging, and environmental influences. Because so many factors contribute to diabetes, management must also be multidimensional. No single intervention can address every contributing factor. This is precisely why integrated approaches become valuable. People often ask, can yoga cure diabetes? The answer is straightforward. Yoga is not a replacement for medical treatment. However, it can address several contributors that conventional medicine alone cannot completely modify. As a preventive tool, yoga promotes physical activity, healthier routines, stress reduction, improved sleep, and weight management. As a therapeutic intervention, it helps improve mobility, flexibility, balance, breathing efficiency, relaxation, and quality of life. When these improvements occur consistently, patients are often better able to adhere to their overall diabetes management plan. Sorry.
Madam, ex- excuse me, this side, ma'am. You also told that you have a yoga student with you today to demonstrate some of the yogas.
Yeah.
So if we can invite her,
First we playing.
because with the
simply
paucity of
as
time,
such.
I think we can show some yoga poses also for the audience. Everyone is like so not awakened. Let them awaken with some yoga poses.
But first I. Why is yoga therapy? Firstly, I tell what is, why is yoga therapy? Then I go for. This is probably, but why is yoga therapy? This is probably the most important message of today's session. Yoga therapy is not simply teaching a list of postures. Instead, it follows a structured clinical process: assessment, individualization, prescription, monitoring, modification, progression. As healthcare professional, we don't ask which yoga pose is good for diabetes. Instead, we ask which yogic practice is appropriate for the practical patient. Every patient differs in age, pain, mobility, cardiovascular status, comorbidities, motivation, and treatment goals. There, the prescription must also be different. This is the essence of yoga therapy. If अगर मैं नहीं बोलूँगी कि योगा थेरेपी क्या है, तो दिखाने से तो जस्ट योगा ही हो रहा है ना? हाँ, thank you so much. Now, we move to the practical component of today's workshop. Rather than simply listing yogic practice, I would like to demonstrate how they are selected and integrated according to individual clinical needs. Before we begin, I would like to emphasize that the sequence demonstrated now is a generalized chart for demonstration purpose in actual yoga therapy. There is no rigid protocol. Every practice is individualized based on the patient's medical condition, functional capacity, comorbidities, limitation, and therapeutic goal. For each practice, I will briefly explain why it is selected, its therapeutic objective, important precaution, possible modification, and practical clinical application. Now, I would like to invite Indrani to come on stage to demonstrate yoga posture. That is your. We shall begin with Ashan component. To make today's demonstration includes Tadasana. But first you yoga chart. Now we see Tadasana. This asana improves posture, balance, and body awareness. Next, Ardha Upavishta Vibhaktasana. Next, Paschimottanasana. Relax. Next, Janushirasana. These two asanas improve circulation. But I don't prescribe these two asanas to low back pain complaint. Rather, contraindication for low back pain. Next, Ardha Chandrasana. Extension spine. Next, Bhujanga Asana. Relax. Next, Salvasana. These asanas strengthen back muscle, spinal mobility, stimulate abdominal organs. Next, Shayan Nataraj Asana. Change your side. These asanas improve flexibility, stretches the trunk and lower limbs. Relax. Once the body has been prepared through asana, we proceed to mudra. Mudras involve a brief phase of breath retention, kumbhaka, between inhalation and exhalation. This can produce transient cardiovascular changes by increasing intrathoracic pressure and influencing venous return, blood pressure and heart rate. Therefore, such mudras should be avoided or appropriately modified in patients with significant cardiovascular disease unless specifically assessed and supervised. Today I shall demonstrate two representative mudras. First, Yoga Mudra. Exhale, lower your body. Control your breath for 3 to 5 seconds. Then inhale and up. You can repeat it 10 to 20 times. Next, Udyan Bandho Mudra. Breathe in, breathe out. Squeeze your abdomen towards back. Breathe hold for 3 to 5 seconds. Then inhale, up. Repeat for 10 to 20 times. Thank you. Finally, we move to pranayam. Remember to repeat 10 times. Today's demonstration includes Chandrima pranayam. Breathe in, breathe out, and breathe in, and breathe out. Relax. Shantanu pranayam. Pranayam is deep breathing exercise, improve oxygenation and relaxation. Next, Shinghokoti Pranayam. Next, Nirmal Pranayam. I think you can understand when she take, when she inhale and exhale. Relax. These breathing exercises help to reduce stress and anxiety, improve mental calmness, balance the nervous system. Thank you. As you can appreciate, these are not isolated practice or fixed exercise routine. Each patient's yoga therapy program is individually designed by selecting the most appropriate combination of asana, mudra, pranayam, according to their clinical presentation, functional limitation, and therapeutic goal. Let me now illustrate this individualized approach through a few representative clinical cases. First case, "65 years old gentleman with type 2 diabetes mellitus, hypertension, bilateral hip pain, and approximately 50% coronary artery blockage. His baseline HbA1c was 7.8. After a comprehensive assessment, an individualized yoga therapy program was integrated with his ongoing medical management. His program included Ardha Upavishta Vibhaktasana, Paschimotthasana, Ardha Chandrasana, Chandrima Pranayam, Shupta Sagar Pranayam, Shantanu Pranayam, and Shinghokoti Pranayam that you were already seen before, na? After 6 months, his HbA1c improved with 7.8 from 7.8 to 6.1. He also reported significant improvement in hip pain, functional mobility, and overall well-being. This case demonstrates how individualized yoga therapy, when integrated with standard medical care, may improve functional capacity while supporting better metabolic control. Now, second case, a 56 years old woman with knee osteoarthritis and elevated fasting plasma glucose. Here, the primary therapeutic objective were not only glycemic control, but also reduction of pain and improvement of knee function. Her individualized program consisted of Ardha Upavishta Vibhaktasana, Paschimotthasana, Ardha Chandrasana, Janushirasana, Chandrima Pranayam, Ardha Paltola Naukasana, and Nirmal Pranayam. This Ardha Paltola Naukasana was not included in my yoga chart, generalized yoga chart. I ask Indrani, please demonstrate Ardha Paltola Naukasana. Change your side. Within 2 months, her fasting plasma glucose reduced from 172 to 113, accompanied by noticeable improvement in knee pain and functional mobility. Relax. Next, Nirmal Pranayam. Within 2 months, her fasting glucose. This case highlights how addressing musculoskeletal limitation may improve overall activity levels and facilitate better long-term metabolic management. Next case, a 35 years old woman with postpartum diabetes mellitus, a strong maternal history of diabetes, and cervical spondylosis. She initially presented with fasting plasma glucose exceeding 270, along with persistent neck pain. Following detailed assessment and individualized yoga therapy program was introduced alongside lifestyle modification and regular medical follow-up. Her program included Ardho Gorokhasana, Janushirasana, Ardho Bhujangasana, Ardho Salvasana, Uddiyana Bandha Mudra, Monojit Pranayam and Monnari Pranayam. These two pranayam also not included before. So please demonstrate Indrani. Monojit Pranayam. These two pranayam only because of her neck pain. After 6 months, her HbA1c remained stable 6.1 with satisfactory fasting and post-parental glucose level, along with sustained improvement in cervical symptoms. This case emphasized that successful yoga therapy is not a short-term intervention, but a long-term, individualized lifestyle practice integrated with conventional medical management. Each and every patient's yoga chart I have to keep changing based on their progression and requirement. If there is one message I would like everyone to remember today, it is this: yoga therapy is complementary, not alternative. Successful yoga therapy begins with assessment, not assumptions. Individualization is more important than selecting impressive postures. Its benefits extend well beyond blood sugar control, influencing pain, mobility, sleep, stress, function, and overall quality of life. And finally, the greatest outcome occurs when physician, physiotherapist, yoga therapist, dietitian, and patients work together as one multidisciplinary team. Thank you, Indrani. I would like to conclude with another beautiful verse from Bhagavad Gita. Buddhi yukta jahatiha ubhe sukrita dushkrite tasmad yoga yavujjasta yogaha karmasu kaushalam. Therefore, devote yourself to yoga, for yoga is excellence in action. Thank you all for kind attention.
Thank you, madam. I would like to request everyone to kindly stand up at the end of this yoga session and give a big round of applause to Joyita madam and Indrani for their excellent demonstration and talk. Thank you.
Any question from the audience?
Madam, one question I have. What are the precautions should be taken in arthritis patient while doing these asanas?
Many kind of arthritis I deal, but knee osteoarthritis I have already mentioned. But agar lumbar pain, that also I mentioned, which yoga I can give or not. Neck pain, that also I demonstrate. But if any arthritis patient, then first हमरा देखबो, मतलब हम देखेंगे कि उनका क्या क्या प्रॉब्लम है और वो जॉइंट्स को हम कैसे पहले स्टेबल कर पाते हैं, उसके बाद उसके साथ साथ मॉडिफिकेशन के थ्रू हम रेगुलर बेसिस एक्सरसाइज देना शुरू करेंगे.
Okay, and after how much time a patient can do these asanas after having meal? After having meal, after how much time patient can do these asanas?
जितना दिन हो सके वो कर सकते हैं. जितना दिन हो सके वो कर सकते हैं, लेकिन कम से कम 2 to 3 मंथ्स और अलग अलग सा एक्सरसाइज का चार्ट हमको मॉडिफिकेशन करके देना पड़ता है, उसके बाद ही उसको इम्प्रूवमेंट होता है और उसके बाद वो जितना दिन कर सकते हैं.
Thank you, ma'am.
थैंक यू सो मच.
Thank you, our brilliant two speakers and chairpersons for sharing your insights. And here I conclude my talk, conclude this session, and over the organizer for subsequent sessions.
Thank you for this wonderful session. Now I will request all the moderator, chairpersons, speakers for a joint photo. Dr. Arindam Dey, sir, please. No, podium. Indra, chole esho. Please come to the sides dais for felicitation. Dr. Rajiv Kumar, sir, please felicitate the moderator and the chairpersons.
Thank you, sir. We now enter session 1, scores and more, a session that reminds us that careful assessment is often the first step towards better decision making. Clinical scoring systems simplify complex decisions, enhance consistency, and strengthen evidence-based medicine. With this, I would like to invite Dr. Krishnendu Dey, sir, to moderate this session and introduce us to our chairperson and speakers.
Good morning, all the delegates and faculty. In our next session, we are going to discuss two topics on diabetes. One is relatively old, that is diabetes and diabetic foot ulcer. Another is relatively new, that is sarcopenia and diabetes, both equally important. For this session, we are going to invite our chairpersons on this podium, Dr. Krishnendu Goswami sir, Dr. Manas Ranjan Mahapatra sir, and Dr. Snehangshu Mon. So please come and be seated on the chairs, and we are going to announce that unfortunately Dr. Jyotirmoy Pal sir has not arrived today, so we are going to skip the tuberculosis in diabetes session. I am now asking our chairperson sir to please introduce our first speaker, Dr. Devaditya Das from Gorakhpur, for his speech on diabetic foot ulcer classification and severity staging. To the chairperson sir. Please invite Dr. Devaditya Das. Dr. Das. He is Assistant Professor of Endocrinology from AIIMS Gorakhpur. Kindly come to the stage and please. Take your honor.
Hello.
Sir.
Good morning, everyone. The present discussion is on diabetic foot ulcers, classification, and the severity staging. It is one of the most challenging topic. I would like to invite Dr. Devaditya Das, endocrinologist from AIIMS, Gorakhpur.
Very good morning, everyone. Thank you, Chairperson, sir. And thank you to Dr. Tarok and Dr. Shubham for giving me this opportunity to speak in front of you. Today morning, the topic that I'll discuss is about diabetic foot ulcers, how to classify them and stage them, and also a little bit about how to classify or stage Charcot neuroosteoarthropathy. So before we begin, may I have a show of hands? How many of us are using any kind of classification or staging system when a patient of DFU comes to our OPD or in clinical practice? Can I have a show of hands, please? Okay, so I can see two hands. So I can safely conclude that most of us are not using them. Well, today I would tell you why you should use them and which one to use. I won't go into too much details on what the classifications are. You can easily check them out on your mobile phone apps, and there are tools also which you can calculate. But which classification system to use, what the essence of the classification systems are. So let us start. Why does classification matter? First of all, the scope and impact of foot disease. As you know, foot complications are one of the most common problems that we encounter in diabetic patients. So, regarding the global disability standpoint, it is a huge burden. There is amputation risk, and the cost is almost comparable to any cancer. Secondly, 4 essential purposes of classification should be there that we need to serve. First, to guide treatment. Secondly, to clear to do clear multidisciplinary communication, for audit and benchmarking, and for predicting outcomes. So, IWGDF, or the International Working Group of Diabetes Federations, Diabetic Foot Ulcers 2023 guidelines, and we'll discuss that, and the ideal system, how the evaluating systems compare with each other for regarding speed, reproducibility, and predictive power. We'll discuss the strengths and limitations, and we have a review of validated system. Now, what a classification system must do and why there is no gold standard. So, if we are classifying a diabetic foot ulcer, ideally it has to be able to capture these 4 variables at least. It should have a variable or parameter for the depth of the ulcer, whether ischemia is present or not, whether infection is present or not, and how much area it is covering. Secondly, it has to be simple. It has to be objective so that there is low inter-observer variability. Accuracy should be validated. However, the unfortunate reality is that no single system achieves all 4. So there are a lot of different systems like the Megit Wagner, then the UTWCS or University of Texas classification, the IDSA, IWGDF infection classification, Sidman classification, etc. So let us see how these classifications pair with each other. First of all, we start off with the Megit-Wagner classification, which is the classic classification first developed by Megit in 1976, further modified by Wagner in 1981, and it basically is a classic depth-based classification. So it classifies lesions from 0 to 5, 0 being foot at risk or pre or post-ulcerative lesion, skin where skin is intact, up to grade 5 where there is gangrene of the entire foot and that requires major amputation. This very early classification has certain strengths, that it is simple, it is recognizable, and there is a logical treatment gradient, as you can see. However, there are weaknesses. So ischemia invisible until gangrene sets in. That is one point. Secondly, infection captured only at grade 3, while infection may occur at earlier grades also. Ulcer area, no mention of ulcer area, how much area is involved, and reproducibility is moderate. So, people have modified this classification, and then we get the second classification, which is University of Texas classification, which adds infection and ischemia. Now, this classification has 2 axes. On one side, there is grade of depth. Grade 0, superficial pre or post-operative ulcer site, which is healed, skin is intact. Grade 1, superficial involvement. Grade 2, up to tendon and capsule, and grade 3 till bone or joint. And on the other hand, other axis, we get certain comorbid milieu as the stages. So stage A does not have any infection or ischemia. Stage B is infected but non-ischemic. Stage C is ischemic but non-infected, and stage D is both infected and ischemic. So as you can see, the qualifier variables are multimodal, and you can get a combination of outcomes from this classification. So you can classify wounds better. So there is, of course, a conceptual advancement in this classification. Perfusion assessment is introduced, and however, there are certain limitations that it does not capture capture the ulcer area or components of neuropathy. So let us see how we can improve our classification going forward. So coming to the third one, again, this is called the PEDIS classification, or PEDIS for perfusion, extent, depth, infection, and sensation. These 5 points. I won't go into the details, but you can see how the perfusion, extent, depth, infection, all these are graded. The primary purpose of this was research standardization, and ordinary grading has been followed in each domain. However, there are certain critical adjuncts, like regarding the perfusion, one of the processes of one of the procedures that can help us determine the perfusion status is ABI, of course, ankle brachial pressure index. However, there are certain critical adjuncts like toe pressure or transcutaneous PO2 measurement, which can bypass the problems that we face if the arteries are calcified. So it fixes essential descriptive variables. However, there is a limitation that there is no single summary score for bedside use, and the infection grading has been adopted by Wi-Fi. So it is a workable classification system with high sensitivity, but still lags behind other things like other systems like diaphora or Wi-Fi. Another classification system, grade 1 to grade 4, this is the IDSA or IWGDF classification system, Infectious Disease Society and IWGDF combination system. So this is mainly useful to characterize the infection or the severity of the infection that the patient has, from grade 1, which is uninfected wound, to grade 4, which is severe with systemic signs of SIRS, etc. So if the major problem that the ulcer has is it's the infection, then I think this is a better classification that can be used. Then another classification, this is called a SINBAD classification, which is stands for site, ischemia, neuropathy, bacterial infection, A for area, and depth. And it has a binary scoring system, 0 or 1, depending on which part is involved, and that will give you a score from 0 to 6. A score of more than 3 is there is a high chance of ulcer. So lastly, I think so lastly, there is another classification which is called the Wi-Fi classification. Wi-Fi stands for wound, ischemia, and foot infection. So there is also a grading of 0 to 3 in this different 3 domains, and thereby we get a final score, and we can determine how much the severity of the ulcer is. So for this one, this is basically useful to assess the perfusion problem that is there, the ischemic component of the diabetic foot ulcer, and whether if we do a revascularization procedure, how much benefit we are to expect from it. So this is regarding the perfusion aspect. This is a very useful classification, the Wi-Fi classification. So it has a very good comparative performance. As you can see, the AUC or area under curve is quite good, and it can also give you an idea how much revascularization benefit you can get by doing some procedure. So if we compare all these 5-6 systems, except for these 5-6 systems, there are around, I think, 20 more classification systems, but these 5-6 you should know, and you should know where to use which one. If we compare head to head, it shows that more or less all the classification systems have a good diagnostic accuracy, and they have certain limitations as well. However, if we are prudent enough, we can actually use classification system as per their prescribed usage. So, for example, if we want to audit or if we want to communicate the extent of the ulcer to your colleague, use SINBAD classification. That is the best and simple thing. So, if I want to characterize the infection part, the infected ulcer, use the IDSA, Infectious Disease Society, or the IWGDF classification. That would be the best. If you're concerned about the PID risk and you want to know how much revascularization benefit you can take out of it, then use the Wi-Fi system. That would be best. And if you want a very simple thing, the most simple would be the Majid-Wagner classification. However, even the UTWCS would be beneficial. So if I talk about classifications, I think this 5-6 classifications like IDSA, SINBAD, UTWCS, University of Texas, Majid-Wagner, and Wi-Fi, maybe diaphora, I won't discuss about that, but this 5-6 system would be enough to classify your diabetic foot ulcer. Now, after you have classified diabetic foot ulcer, the next question obviously comes, what about Charcot-Neuro-Osteoarthropathy? A lot of times, the patient may present to you with Charcot-Neuro-Osteoarthropathy. A lot of times, there can be both an ulcer and a Charcot-Neuro-Osteoarthropathy. So for that, you need a classification or staging system for it also. So before I begin with this, I'll just briefly discuss the pathophysiology of CNO. Truly speaking, we do not yet know how CNO or Charcot occurs. However, there are certain hypotheses like neurotraumatic hypothesis, neurovascular hypothesis, molecular inflammatory loop, etc. Ultimately, what happens? Patient will present to you with hot, red, swollen leg, and there is a chance that it might be misdiagnosed and it has infection or some other problems, osteomyelitis, etc. So you have to be very suspicious of this condition called Charcot-Neuro-Osteoarthropathy, because diagnosis is very crucial at early stage. However, it is often missed, and then at a later stage we find out. So now, if you suspect Charcot, you have, or if you diagnose the patient as having Charcot, you have to classify it or stage it. So one of the foundational staging system was given by Eichenholz, which is a radiographic pathological staging system, so to say. So the stage 1 would be, if you do an X-ray, you will see fragmentation, development, a hot erythematous swollen leg or feet rather. Then in the second stage, the activity or the redness or the high temperature may be reduced, and if you do an X-ray, you will see that some of the bones have coalesced together. So this is the stage of coalescence. Lastly, there is consolidation and some reconstruction. These things are there in stage 3. So this is how the radiological classification of Eichenholz actually stages Charcot-Neuro-Osteoarthropathy. And Shibata actually introduced a crucial amendment to this classification by introducing the prodromal stage. What is the prodromal stage? You are suspecting a patient has Charcot, the feet is red, hot, swollen. You are still not sure. You do an X-ray. In the X-ray, you find that there is no abnormality. So by the older Eichenholz classification, there is no Charcot-Neuro-Osteoarthropathy. However, Shibata is saying at that point, you go for an MRI. MRI may help you find certain subclinical findings like bone marrow edema, etc. And if that is there, then you say that the patient has stage 0 Charcot-Neuro-Osteoarthropathy. And this is the stage where the intervention actually helps you the most in recovering regarding the foot. So that was about Eichenholz classification, the pathobiological classification or pathobioradiological classification, if you will. Then comes a geographical or anatomical classification called the Sanders and Frickberg classification. Both of the scientists mapped Charcot destruction in 1991 and found 5 anatomical distinct patterns. Pattern 1 being the forefoot, pattern 2 tarsometatarsal or Lisfranc joint, pattern 3 naviculo-cuneiform talonavicular and calcaneo-cuboid joint, pattern 4 ankle and subtalar joint, and pattern 5 the calcaneus. So previously it was a biological pathological classification. Now it is a geographical classification of Charcot-Neuro-Osteoarthropathy. Similarly, just another classification which is quite commonly used, the Brodsky's classification or Brodsky-Roos anatomic classification. Here also it is a geographical classification. I won't go into the details of this classification. You can read at your own leisure time. But which one to use when, we will discuss. Again, these two are not that much in vogue. However, the Sean and Sella and Barrett classification, which refines the mid-foot region, is another geographic or anatomic classification. So till now, for Charcot, we have a pathophysiological or pathobiological classification and one geographic classification. And in the MRI era, there is a new classification which is not used that much, the Chanteloup and Grusna's 2x2 classification, as you can see, where you actually employ MRI to find out whether there are subclinical findings like bone marrow edema, etc., which will qualify it as stage 0 CNO. So, 2 types of classification for CNO, and regarding judging activity, if the CNO is active or it is quiescent, for that you need to do a temperature assessment and incorporate that also on your classification system for CNO. If you do these three, I think you will have a very good idea how much the CNO has progressed. Now there are some new classifications that are coming up or has come up in the last few years. One of the predictive classification is there, and then also there is a thing called Balgrid's score. I won't go into details, but these are the new things that has been used in research. So coming to the end of this presentation, some integrated takeaways, how to classify, which one to use. Firstly, you have to classify. For DFU, you might use SynBath first, that is for audit and communication mainly, Wi-Fi for certain equipped settings, for infection, again IDSA or IWGDF, and if the problem is ischemia or PAD, Wi-Fi only. There are certain universal grammar for the ulcer like the depth, the perfusion numbers, the amount of infection, both grade and area. So you have to document all these access explicitly, regardless of what classification you are using. Remember all this few grammar points. And regarding Charcot, activity always trumps anatomy in Charcot. You have to see what stage the Charcot is in. You might combine that with a geographical classification, but the stage always remains important. Always remember the classification is dynamic. Classifications help to triage and communicate. So, two axes. One is for Charcot. If you suspect Charcot, immediate action, classify the Charcot neuropathy, the activity stage and the anatomic stage. Also, if there is an ulcer, you classify it presentation by using these 4-5 classification systems that we have, and combine, we can take a decision what to do and what not to do, and what outcome we expect. So with that, I would end my presentation, and at the end, I would like to take this slide back here. With that, I would like to end the presentation and welcome you all to the beautiful city of Gorakhpur, where you can enjoy a lot at different places. And if you do agree or to visit or come, please do visit my institute, AIMS Gorakhpur, which is the crown prince of the crown jewel of the city. So thank you. Thanks a lot.
Thank you, Dr. Devaditya, for this speech. Now please come and join us and have your seat. We are now going to request our next speaker, Dr. Rajdeep Basu, for his speech on sarcopenia assessment and management. He is a senior resident, Department of Endocrinology at NRS Medical College and Hospital, Kolkata. He is now going to throw some light on sarcopenia assessment and management, which is a very current and evolving topic on diabetes nowadays, particularly with these GLP-1 analogs and all these new modalities of treatment. So over to you, Dr. Rajdeep.
Good morning to all. My sincere respect to the Honorable Chairperson and heartfelt gratitude to the organizing committee for giving me this opportunity to share this dais. So, when we have moved from a disease-centric control of blood glucose to a more disease-specific approach that address organ involvement in diabetes management, probably muscle becomes a less important organ to be monitored routinely in clinical practice. So, before going to sarcopenia, we have to differentiate it from the other geriatric syndromes that share similar clinical features like frailty and cachexia. The cachexia is defined as severe inflammatory weight loss associated with systemic inflammation like cancer, AIDS, or frailty is a state of declined function of multiple organ, not only muscle. Muscle is a component, but other systems are also involved due to aging. So, what is sarcopenia? The term is coined in 1988 from a Greek word sarx, that means flesh, and penia means loss. In 2016, WHO designed it as a disease and described as a age-related muscle loss. So, how fast the muscle loss? So, beyond 70 years, the loss is 15% per decade, but in between 40 to 70 years, the loss is around 8% per decade. And the European Working Group guideline defines is a muscle disease rather than a genetic problem. So, among the etiologies, apart from aging, so we can see many systemic diseases, physical inactivity, sedentary behavior, malnutrition, both over and undernutrition, all are the etiologies of sarcopenia. If we see the Indian epidemiology, the prevalence is around 11 to 17%, and more common in rural population, and also higher prevalence has been seen in women than men. Obviously, the females are more affected than the males, as found in various Indian study. And also, geographical variations are notable, preferentially reflecting the dietary pattern, lifestyle factors, and genetic influences. Now, question will arise: why we are discussing a muscle condition in the diabetes forum? So this survey result from the NHNES from 1999 to 2018. The uppermost blue line shows the prevalence of sarcopenia in population with diabetes much higher than the non-diabetic counterpart. So how the both are related? So on the other one hand, the low insulin, the diabetic nephropathy, congestive heart failure, liver fibrosis, ectopic fat disposition, and alteration of the growth hormone and gonadal hormone causes muscle loss. And due to the muscle loss, there is low utilization of the glucose. There may be insulin resistance and also alteration in the myokines, like increased myostatin causes insulin resistance. Also, in decrease in interleukin 6, irisin, and FGF21, they increase the appetite and decrease the insulin sensitivity. So I'm delighted to share some of our institutional data. So this is the prevalence of sarcopenia in type 1 diabetes. It was 30%, almost 3 times higher than the control population. And also, this article has been accepted, but in process of publication. So in this, we estimate the prevalence of sarcopenia in type 2 diabetes, where they were also had the clinically significant liver fibrosis, and the prevalence became the 33%, and the severe sarcopenia was 7%. So not only the disease process of diabetes, but also the modern therapy with incretin mimetic causes a decrease in lean mass, as marked within this red box. The tirzepatide and subcutaneous semaglutide are most notorious among all available options. So coming to the assessment of sarcopenia, there are major 3 components: the muscle mass, strength, and physical performance. So from a community screening, we can use a simple measuring tape to get the cuff circumference, or we use the SARC-F screening questionnaire, which composed of strength, assistance in walking, rise from the chair, climb stairs, and history of falls. So we mostly in our region, we use the Asian Working Group criteria. So after comparing this cutoff for cuff circumference and SARC-F questionnaire, so we should move to the for assessing the muscle strength and to assess the physical performance. If anyone is affected, then we can stamp it as a possible sarcopenia, and we should progress further with other diagnostic modalities. So DEXA scan is the gold standard, and we can get the result as appendicular lean mass by height square directly from the machine. Apart from DEXA, we also use the CT and MRI. Most common region screen is the third lumbar spine. Also, we can assess the mid-thigh region and the psoas muscle. And another advantage of this modality is that along with the muscle mass, we can also assess the fat infiltration within the muscle. So if these modalities are not available, so we can use the multi-frequency bioelectrical impedance analysis. Both the machines are available in our institute. So here, this result we get the individual like segmental lean mass. So to get the appendicular lean mass, we have to add the values of in all 4 limbs, and then we have to adjust it by dividing with height square. Also, we use ultrasound, though it is not included in the guideline, but it is a separate advantage. Like we can measure the penetration angle. It is a very good marker of the muscle architecture. It's the angle between the fascial layer and the aponeurosis. Also, with the help of the sonoelastography, we can measure the muscle stiffness and contrast enhanced assessment of microvascularity. Creatine dilution test is another test only available in the research purpose. So here we give the deuterium level creatinine, and we have to measure the urine both labeled and unlabeled creatine and creatinine, and it is very well correlated with MRI based assessment of muscle mass. For assessment of muscle power, so we can use the hand grip dynamometer. It has a good correlation with the isometric force in the forearms. But if the forearms is affected by any musculoskeletal or neurological cause, if we cannot use the hand grip dynamometer, so we have to look for other modalities. I'm coming to that. And also there remains a question that whether it reflects the muscle strength of the lower body. So instead of that, we can use the isokinetic testing, which is a measure of the strength of knee and the hamstring muscle. And the advantage is the accurate, safe, and repeatable. But major disadvantage is the limited availability and the high cost. If all the instruments are highly cost, more or less, but if nothing is available in our setup, still we can assess the muscle power. So we can simply ask the patient to hold a 1 kg weight overhand with outstretched arm for 30 seconds. And also in the lower body, we can use 1 repetition maximum of knee extension. In it, weight-free movement is documented first, then the weight is increased by 1 kg in each session to the maximum capacity of the individual. For assessment performance, we have chair stand test. We have gait speed 6-meter walk and time up and go test. And this short physical performance battery is a more objective way to measure the performance. It composed of basically three tests: the balance test, gait speed, and the chair stand test, and they divided into point score according to the time spent on these activities. So again, if we look the Asian group criteria, so first we have to determine that whether the low muscle mass is present or not. So if the low muscle mass is present along with either low muscle strength or a low physical performance, then we can say it is a sarcopenia. And if all 3 components are affected, then it becomes severe sarcopenia. So as we have already discussed that the geography, demography, lifestyle, and genetic influence muscle mass and activity, we South Asians need a separate working guideline in which the 5S pathway is important to suspect and screen early, to rule out the secondary sarcopenia, to assess the severity and share decision making while giving the management options. So some key highlighting features of this guideline, that they have given stress on the clinical suspicion. If applicable, we can take help from some biochemical markers. The equal importance are given for muscle mass, strength, and physical performance, and any 2 out of 3 is required for the diagnosis. The secondary sarcopenia in cachexia and physical inactivity has been incorporated, and also they stated that instead of cuff circumference, we also measure the upper arm circumference, and as it takes all the muscle and the fat tissue, so we can get the mid-arm muscle circumference by adjusting it with the triceps fold thickness. So if we see the values, there are some minimal differences from the Asian working group for grip strength and gait speed, and the other values are not validated still in our population. So we can still use the Asian working group of sarcopenia values. So now coming to the management of sarcopenia, the most important is diet. The dietary advice when we are prescribing to the patient should be palatable, acceptable, affordable, and available, and it should be individualized to the patient, particularly the patient in chronic kidney disease. Obesity paradox is an often discussed topic where the hypocaloric diet is the core management of diabetes and weight reduction. But here it has seen that in individuals more than 65 years in of BMI between 24 to 30, there is mortality benefit if we maintain this BMI. So it is better to avoid a strictly hypocaloric diet in these individuals. Also, Mediterranean diet and time restricted eating both have some beneficial role in sarcopenia. The protein intake, we can increase it up to 1.2 to 1.6 gram per kg per day in older adults. Protein pulsing is a thing where we continuously, we want to continuously supply the essential amino acid for muscle regeneration. For that, we can advise 20 to 30 gram of high quality protein per meal thrice daily. And not only the protein quantity, the protein quality is also important. So casein based, leucine, hydroxymethyl butyrate, arginine all has a major beneficial proteins that can help in muscle regeneration. And also the long chain omega-3 fatty acid, green tea, berries, turmeric all demonstrated promising anti-sarcopenic properties by their anti-inflammatory role. Vitamin intake, the calcium, iron, folate all should be optimized. Millets are affordable source of protein in a rice-based population like us, and also as the role of gut microbiota on muscle function and mass are well established, so the pre and probiotic from the usual Indian diet should be encouraged. And last but not the least, the adequate hydration should be ensured. Among management, the resistant training like weightlifting, bands, they all increase the muscle mass and muscle strength, and on the aerobic exercise, they increase the muscle endurance. So if we combine both, we can get the maximum benefit of strength, all the components, strength, mass, and the endurance. Some other modalities, especially in elderly, in whom high intensity exercise or gym training is not possible, the velocity based training can increase the exercise capacity and decrease the fatigability. Blood flow restriction training is another thing. So we can generate the muscle hypoxia by partial occlusion of artery and the complete venous occlusion. It has shown increased muscle mass and strength. And we have a nice early morning session of yoga that increase the muscle flexibility in balance in elderly, and whole body vibration therapy can increase the adaptation. Some simple daily physical activity should be encouraged, like if there is no knee pathology, the usual oriental style toilet, sitting on the floor cross-leg, non-mechanized way of carrying the activities, using stairs instead of lifts, and avoiding uninterrupted sitting for a longer period, and also to take short walking break in between long desk work. Among pharmacotherapy, nowadays there is no definite pharmacotherapy for sarcopenia. Still in trials, the enobosarm has shown to increase the muscle mass and physical performance, but there is mixed result for the muscle strength. Testosterone, it obviously increased the muscle mass and strength, but it should be kept in mind that the effectiveness has shown only in the clinical and biochemical hypogonadism, not in the eugonadal state. The optimal route of administration is still debatable, but few studies have shown that the intramuscular route has some beneficial effect on muscle mass and strength in comparison to the transdermal preparation. Estrogen and tibolone, there is no dedicated randomized control trial with them for sarcopenia, so it cannot be commented for any on the benefits of this agent on the muscle on muscle. DHEAs, there are only few studies that show benefit in the physical activity, but isolated supplementation may not seem to lead to gain in muscle mass or volume and strength. IGF-1, very few studies, growth hormone and growth hormone secretagogues, mostly data generated from the athletes and the older people, which mainly in the context of hypopituitarism. So the growth hormone and anamoreline, ghrelin agonist, they showed to increase in muscle mass, but results are variable in improving muscle strength and performance. There are some newer molecules like monoclonal antibodies against activin receptor type 2B, like bimagrumab. So in the trials, it has shown increase the muscle mass and strength, but the mixed result in physical performance. as we have already discussed the effect of in getting mimetis. So in this recent trial, the bimagrumab has been combined with semaglutide, and this combination shows the maximum loss of fat mass exchange for a moderate in the exchange in the lean mass occurred in comparison to the semaglutide when used at the highest dose. The green line is not the dark green line is the semaglutide alone, and the dark pink line is a both combination of bimagrumab and semaglutide. Another agent, the epitagrumab, it also been mixed with the tirzepatide, and the combination had a statistically significant lower decrease in the lean mass than the tirzepatide alone. Some also the newer agents, the landogrozumab and the trevogrumab, both are the myostatin inhibitors. They increase the muscle mass, but partial improvement was observed in muscle function and mobility. Vitamin D supplementation, the isolated use was not studied. All the RCTs was done in combination with diet and exercise, and all who responded had a vitamin D deficiency state in the baseline. AC inhibitor and ARB, they were tried for their anti-inflammatory benefit, but no trials showed any benefit in sarcopenia. So when we are putting a patient in some kind of management, so how will you check the effectiveness? So the gait speed, the gait speed is increased by at least 0.1 meter per second, or the short physical performance battery score by 1 point. There we can use the sarcopenia quality of life questionnaire. The change in grease trend we can monitor, but there is no definite cutoff to say this the condition is improving, and also the improvement in daily physical activities also to be monitored. There are some newer strategies in the pipeline. The metformin under TAM project, we can also target the exerkines. Some senolytic drugs are also in the development stage. There is the newer data is coming up with the fecal microbiota transplantation, mesenchymal stem therapy, and gene therapy are also being tried in sarcopenia. So we can take help from the digital health technologies and health literacy also. So we may be confident enough to comment on these options in the future. So muscle is an important organ, not only for mechanical benefits, but also potential metabolic role. Thus, when we are very much excited to decrease the fat mass, it should be kept in mind that in a fat losing tussle, never forget the muscle. Thank you for your patient hearing.
Thank you, our speaker, for such nice demonstration. Now please come and join with us so that we can take few questions if there is a few questions from audience. Any doubt anyone wants to clear it? No. No, there is no question here. So we think we can conclude the session now. And
thank you, sir, for the thoughtful session. Now I request all the esteemed faculty members to kindly remain on the stage for the group photograph to commemorate the enriching scientific session. And I also request to call Dr. Devadip Tosharash on the dais.
Come to the dais for the photo session.
A gentle reminder, all the chairpersons and the speaker, please come to the side dais for the felicitation. Dr. Arindam Hajra, I would like to request you to kindly felicitate the moderator and the chairpersons.
The Bengal Diabetes Foundation has been a driving force in promoting excellence in diabetes, endocrine care, and beyond that. Through its unwavering commitment to academic exchange, research, and public awareness, it continues to inspire generations of healthcare professionals. By Bringing together experts from across the country, it continues to foster scientific excellence and improve patient care. With great respect and pleasure, may I invite Dr. Amitabh Bishas sir and Dr. Shomik Goswami sir to kindly grace the stage and welcome our respected guest speakers. Now I request to call Dr. Taraknath Chattopadhyay sir on the dais to welcome our chief guest lecturer, Dr. Manoj Chadha sir, and I request to felicitate Dr. Manoj Chadha sir to Dr. Amitabh Vishta sir and Dr. Shomik Goswami sir.
Sir, please come on the dais, sir. I would like to request Dr. Amitabh Vishwas sir and Shomik sir to kindly felicitate Dr. Manoj Chadha. Dr. Manoj Chadha has practiced endocrinology in Mumbai and Navi Mumbai for nearly 4 decades and completed 25 years of distinguished service at PD Hinduja Hospital, Mumbai. With 39 years of clinical experience and 17 years as a postgraduate teacher, he has shaped generation of endocrinologists. His academic contributions include 67 peer-reviewed publications and 8 book chapters spanning diabetes, thyroid disorders, osteoporosis, metabolic bone disorders, and obesity. He has served as principal investigator for multiple national and international clinical trials, and his work has helped shape guidelines such as ISBMR position statement on osteoporosis and the APCO framework for osteoporosis care. Dr. Chadha is a fellow of Indian College of Physicians, a fellow of Royal College of Physicians, Ireland, and a conjoint fellow of the University of Newcastle, Australia. He had been a member of the Endocrine Society USA since 2003 and of the European Association for the Study of Diabetes since 2004, among numerous other national and international professional bodies spanning over 3 decades of association. It is now my honor to invite Dr. Chadha to deliver the second BDCON guest lecture, Type 1 Diabetes, Redefining What's Possible, Hope Through Innovation, Technology, and Partnership. Sir, the stage is yours.
Today's the BDF guest lecture will be delivered by Dr. Manoj Chadha. He will discuss on type 1 diabetes, redefining what's possible, hope through innovation, technology, and partnership. Manoj, please, over to you.
Well, it's a great pleasure to be here and the honor that you bestowed. I don't even know whether I deserve all this. But thank you, Dr. Amitabh Vishwas, Swami Goswami, and the managing team that invited me here. So, type 1 diabetes, at least Bengal is in the forefront, both nationally and internationally. Our colleagues have been trying to work on this. And I'm not sure how many of you are actually involved in managing type 1 diabetes, but I can tell you, it's a very difficult task. And at the end of my talk, I'll show you some slides of what we are doing at Hinduja, especially because we have a grant from corporate social responsibility. So that is possible and what we have been doing. But let's begin with what is really happening. So the last 100 years since insulin has been discovered, we've seen a lot of progress. I mean, I can tell you as a student in the late 70s and the early 80s, so that's good 45 years ago, we used to have the glass syringe, that 26 number needle, boil the syringe every time before the injection, and it used to be so painful. So things have improved. We've got human insulin, then we've got analogs, and the last decade has been very interesting because of the advances. So I'm going to try to paint a rosy picture and not a despair picture. What we can do for our patients in today's scenario and in the future. I know someone is going to stand up and say, sir, but all this is very expensive. But I mean, it's a price we have to pay for technology, and hopefully with technology becoming more available, it will become cheaper. But till such time, we have to depend upon donations, collecting funds, maybe the central and the state government, but it has to be done. So, in the last 30, 40 years that I have seen type 1 diabetes, the picture is changing. It used to be a thin, lean child, sick for most of the time, not doing anything productive. And today, you see a healthy child, you see a healthy teenager, you see they are being very productive, they're as good as the other peers who don't have diabetes. And that is all thanks to the understanding of the disease and how technology has been helping these patients. So let's look at what was there, and then we'll see what we can talk about for our patients. So type 1 diabetes, unlike type 2 diabetes, is a autoimmune beta cell destruction. So the word autoimmune is important, so you can't blame anyone for it. And it's a progressive beta cell destruction to separate it from type 2 diabetes, where there is no destruction as such. It is dysfunction of the beta cells. And as we all know, there is absolute insulin deficiency. So we keep talking about oral tablets in type 1 diabetes, but most of it is conjecture, trial basis, but the only thing that works is insulin. And it is lifelong insulin replacement. So that is an important point that we have to remember, and maybe not on day one, but we have to talk to the parents and the child. And when we are treating such type 1 diabetic patients, I don't like the word brittle, but the fact is that there are multiple swings from severe hyperglycemia to hypoglycemia. Both are possible in these patients. And, this is not like, say, hypothyroidism or type 2 diabetes or hypercholesterolemia, where you're given a prescription and you tell them, come after 3 months, come after 6 months. There has to be a support system day to day managing these patients. You may not be able to do it in your practice, but there has to be a support staff who understands what is happening and how to go about helping these children. So we keep looking at the glycemic part, the hyperglycemia, the hypoglycemia, the glucose variability. But remember, we're looking at schooling, we're looking at meal times, we're looking at the type of meal, then the sleep pattern. And what is most important is the psychosocial element. The distress of having a lifelong disorder when the child is still young, the fear that goes with this, because there's a lot of misinterpretation, misinformation in the social media, the financial burden, the medical burden that is there on the family. So these are all factors that have to be built up in the support system. So in the last about, say, 2 decades, there has been remarkable improvements in the type of insulin that is available. I remember as a student 45 years ago, we had what is today called as the dirty insulin. But that was the only insulin available from the bovine source, the porcine source. In the 80s, we started getting human insulin, which was initially enzyme modified, and then you had from the recombinant technology. And in the last, say, 3 decades after that, you've got the analogs, you've got long-acting analogs, short-acting analogs, ultra-short-acting analogs, ultra-long-acting analogs. So there has been a lot of improvement in the types of insulin that are available. We've started understanding diet, we've started understanding carbohydrates, their glycemic index, glycemic load, the importance of protein in our diet. So these things have made us more intelligent. We are probably handling these problems better. Plus, along the way, you had glucometers and other technology which has improved. But the important thing is still what is missing is that beta cell which is not there in these type 1 diabetic children. What can we do for that in the meantime till we have a solution for recreating beta cells? And that is creating a feedback loop. So in a normal person, you eat food, the glucose stimulates the beta cell to release insulin. The insulin goes and does its function. So these artificial loops have now been created where you have a sensor feeds into the insulin pump, and the pump based on algorithms can deliver the required insulin. So there are so many generations of insulin pumps that have been developed. So if we look at what has happened in the last decade in terms of technology, I think the most important thing is continuous glucose monitoring. Everyone here is aware of how continuous glucose monitoring works and the types of CGMs that are there in the market. I hope so. So all this while it used to be multiple finger stick checking and getting maybe 1, 2, 3, 5 blood tests in a day. So this has then moved now to a continuous glucose monitoring where every 15 minutes the sensor sends a message to the app. Now it's come down to every 3 minutes for 15 days. So that's the life of the sensor. So the sensor accumulates this information and gives you, a lot of information in terms of charts, diagrams. But what we need to work or understand is that we want to keep the glucose values within a certain range. So that is called time in range. And in patients, it's very difficult to have 100% time in range. So then we look at time above range and time below range. So just to give an idea, time in range should be at least 70-75%. Time above range should be less than 15%, and time below range should be less than 1%. Because hypoglycemia is more dangerous than hyperglycemia. In addition, whether the sugars are high or low, we want less variability because now we understand that variability is more damaging than hyperglycemia. So we try to understand what is it that brings about this variability, and whether it is diet, whether it is activities, whether it is sleep, lack of sleep, stress. So whatever these factors are there, we try to understand from looking at the CGM charts and then teach the parents and the children how to interpret that. Yeah, so these are the figures that we look at. So we would like most of our readings to be between 70 and 180. And if you look at the graph at the top, you can see that there is a dark blue line, which is actually the median. It's not the mean, it is the median of glucose values at that time over the 2-week period. And then there is a dark blue band, which will tell you the variation between 25th and 75th percentile. And the light blue band is the variation between 10th and 90th percentile. So as far as possible, we are happy if most of the figures are around the median line in the dark blue band. But there are going to be outliers and we have to accept that. So with this information, see, you used to have your still photographs and now you have the video photographs, which gives you a impression of what is happening. So similarly with CGMs, instead of relying on an HbA1c alone, see, HbA1c is an average of highs and lows. So you can have a normal HbA1c and still have a lot of highs and lows. So the CGM now tells you what is time in range. It tells you where the glycemic variability is. So instead of saying HbA1cs now, you can talk in terms of time in range, and what is it that makes you go out of range. So the child or the teenager can understand where he can contribute to better control. So it's important that not only discuss problems, but even try to find solutions. So with the CGM, at least in our practice, again, it's not something that the child can have it 24/7 and every day for the rest of his life, but we try to give them a CGM for 2 weeks, then wait for 1.5, 2 months for them to get used to it, and then give them another CGM. So I think this is one of the major advances that we have in our managing type 1 diabetes children. From multiple tricks, which is not easy, I think it's a torture, and to this CGM story, which tells you what is happening through the day, and especially during night. Who does blood test during the night? Unless they get up with hypoglycemia, no one gets up at night. So the CGM tells you the story, what is happening. And then also, based on whether it is a continuously basal elevation or it's postprandial elevation, you can choose on the type of insulin that you're going to give your patient. The next wonderful thing that has happened in the last maybe 5 years is what is called as automated insulin delivery. See, we've been using insulin pumps for a long time. Again, it's not something that every child can use. At least in the developed world, in Europe and US, every type 1 diabetic child gets a free insulin pump. It's free, everything is taken care of. But in our setup, that is not possible. However, please understand, next to the body's pancreas and the body's beta cells, the automated insulin delivery is a wonderful boon for the children. What we have is a CGM which is applied on the arm or the abdomen. This talks to via Bluetooth to the insulin pump, which has the insulin reservoir. It has already been fed algorithms through AI. The pump decides the amount of insulin that goes into the body. So it is a true artificial pancreas. And for most part of the day, maybe 10 to 15% variation in sugars, the insulin dose is also adjusted by the pump itself. Unless, the figures are going out of range too much, then the child has to take the dose himself. And if it's going towards hypoglycemia, there is an auto shut off for the next 30, 40 minutes or 60 minutes. The pump will calculate how much insulin is there in the body and how much time will it take to get metabolized, and then it starts on its own. So hyperglycemia, you have to treat. Hypoglycemia, the pump treats. And for most part of the day, because of this automation, the insulin delivery continues. So what has happened with this? We were fortunate, like I said, we have a CSR. At Hinduja Hospital, we have about 23 pumps for our children. And the control has changed fantastic. I will show you in the end some figures of how we have helped them physically, we have helped them scholastically. They have started representing the state and the country at sports events also. So something which was just unheard of 5 years ago, it has totally changed now. So with the AID, the variability has gone down drastically. The A1C has started coming down very impressively. The time below range becomes less than 1%. And the overall treatment burden in terms of morbidity starts going down. So, I still remember about 10 years ago sitting in an international conference and hearing about these AID devices. So it was, like a futuristic science fiction story. But today these are available, expensive but available, and hopefully these will get subsidized. The manufacturers will get competition from other companies, and prices will come down. Competition and usage always reduce the prices. So these AID systems are today and great hope for our children. And as I said, it's not only hyperglycemia getting corrected, the risk of hypoglycemia goes down drastically. The children sleep better. The potential of defensive eating goes away. Their scholastic performance improves, and overall confidence in management improves both for the patient and the family. So this part has been in relation to what we can do for the glycemic control. But as I said, it's the beta cell which is lost, and we don't have anything to get new beta cells. I mean, people have talked about beta cell transplant, people have talked about xenotransplants also, but it's very sparingly used because the amount of immunosuppression that you need. So we are now talking of replacing beta cells, but before that, we have a drug now today. So again, from science fiction to reality, there is a anti-CD3 monoclonal antibody which protects these beta cells in stage 2 and stage 3. See, stage 1 you will not come to know about that something is going wrong. But if you have a patient and you look at their siblings who are moving towards type 1 diabetes, 14 days infusion, 1 hour infusion for 14 days can delay the onset of type 1 diabetes between 2 to 3 years. For a 12 or a 14-year-old, 2 to 3 years is a long period. See, at 50, 60, if I say 2 to 3 years, you may feel that, oh, it's not a big deal. But for a young child, there is now hope. And there are newer drugs that are being into phase 2 and phase 3. But this is a US FDA approved treatment. And as you can see, there are children who get the diagnosis is delayed even up to 4 years. So that's a great boon for management of or prevention of type 1 diabetes. And probably now we are moving towards stem cell derived beta cells. That's also a reality. It's not a science fiction. Small numbers, but we are moving towards getting stem cells also for this type 1 diabetic children. So you can see up till now what I have told you is that in the last 40, 45 years that I have seen type 1 diabetes, there's been a sea of change. Multiple injections, glass syringe, steel needle, multiple abscesses, poor performance, admissions for ketoacidosis, those have now become thing of the past. I know it's still there, but they are now much less. We are understanding the problem. We are looking at therapies. So in future, like I said, what was science fiction 10 years ago is there today. So what is science fiction today may be there in the next 5 to 10 years. Looking at precision immunotherapy, stem cell derived beta cell replacement, encapsulation and putting in the beta cells within the body, gene editing, smart glucose responsive insulin, so the risk of hypoglycemia goes down, and further modification in the automated insulin delivery. These are all hope. Maybe not affordable, not available, but hope. And even if you start with one patient in your practice, this will multiply for sure. So please remember, technology is great. I mean, it helps us in management of everything. I mean, whether you're looking at cardiology or neurology, technology is fantastic. But we have to keep the patient, his status, his economic status, his educational status at the center of the whole management plan. The family needs a lot of support, so there has to be a support system. I mean, as a consultant, you may not be able to answer queries 24/7, but someone in your team should be there. There should be a place where they can send messages and wait for answers. So the team approach is what is really necessary for managing type 1 diabetes. So what used to be a doctor or a physician now becomes a coach, a teacher, a technical person, a problem solver, and a partner in this management of type 1 diabetes. I'm going to show you, okay, so the last thing is, instead of, we see children who are naughty, we see children who are not taking their medications properly, but instead of, scolding them, getting angry with them, as far as possible, I know it may not be possible in every child, but instead of, looking at why the sugars are high, it's better to get them to answer, what do you think happened there? Was it availability of insulin, or was it that you forgot to take it, or you were busy with something, or was it exam stress, or something at home? So it's nice to be not only a doctor but a friend and probably a mentor. So another 10 years from now, how is type 1 diabetes going to be? Hopefully things will improve everywhere. You'll have more AID, autonomous loop systems, longer acting. We know now weekly insulins are available. Okay, so this is all science fiction becoming reality. From 3 to 4 days times of insulin, now you've got once a week insulin. Earlier screening, so there are some developed countries which have started screening for type 1 diabetes. We are still screening for type 2, but that's okay. We'll get there sometime. And then the stem cell derived cells, the immune tolerance and hypoimmune cell products, and the use of AI in managing our patients. These are all nearly there. So it's something that we all look forward to. So my last slide for this part of the talk is what is possible, the hope that I'm trying to give here, that we have better therapies. That's the innovation part, that technology is improving, hopefully get affordable as the time passes, and the partnership is most important. When I say partnership, it's not only the doctor and the patient, but the government, the corporates, the private-public partnership, the CSR, which we have been tapping at Hinduja Hospital. Each one of you, I'm sure, has at least some contact. So start working on that. And this is our Hinduja project, which has been going on for the last 7 years, thanks to a CSR. And let me tell you, it's not right to say, oh, you are in Hinduja Hospital, Mumbai, you've got very rich patients. Type 1 diabetics, unfortunately, most of them come from the lower socio-economic status. And even those who are on the middle class, eventually managing type 1 diabetes, they go into a lower socio-economic status. So, we try to support them. We do all the best things that are possible in terms of checkup, in terms of medication, in terms of the support. I think the most important is the support that we have for these patients. And, we've got siblings of, with patients, in parents who just can't afford 2 square meals. But we are looking after not 1, but 2 children in such families. And the cost with the best of treatment is about 12,000 rupees a month, but it can be done at probably half the cost also. And the hospitalizations have come down. So you see, most of our children are in the teenage, but we've got from 1-year-old also, right up to 18. We look after them till they're about 18. The antibody positivity is something which tells us the hope. And why it's important is that if we start looking at siblings, because one part of I'm not getting into the research that we are doing, but one thing is we are finding siblings, and today we can't afford to give teplizumab, but probably someone will come up and support us with that. So the important thing, if you see, is the height has improved in the last few years, the weight has improved, the scholastic performance has improved, and their involvement in other activities besides studies has improved over these last 6-7 years. We've got about 500 children now. We started off with 1 and 2, but it's reached, because it was the COVID period, so we had a bad 1 year. But after that, now it has picked up, and everything in terms of A1C, lipid profile, renal function has improved. There is another ongoing project with ICMR and young diabetics, and good centers are there, and their A1C's average is between 8.5 and 8.9. We have managed to get below 7 and at least half our patients. And the 23 children who got that Medtronic 780G AID pump, Their A1Cs are below 7, and thanks to them, we get about 2 to 3 publications at international and national conferences along the way. So thank you very much for your patience, Erin. I hope that I've been able to give you some hope for your type 1 diabetic children, and we'll look at technology, somewhere economize the whole thing, but just putting things away and leaving everything to Sujoy Ghosh is not going to work. Everyone has to be involved in managing type 1 diabetes. If you don't have time, give it to colleagues who have time. Otherwise, don't treat them as if they're type 2 diabetics, seeing them once in 3-4 months. It doesn't work that way. Thank you very much.
I request everyone to please rise and give a standing ovation for this wonderful session. Thank you so much, sir. I request every faculty member to please kindly remain on the stage for the group photograph.
As is customary in a guest lecture, invited lecture, we won't have any questions for this session.
Now I request Dr. Shubham Das sir and Dr. Devadita Das sir to come on the stage and moderating the next session.
The next session is our plenary session. It will be delivered by none other than Dr. Raman Puri, Senior Interventional Cardiologist at Indraprastha Apollo Hospital, New Delhi. May I request Dr. Shubham Das to kindly felicitate Dr. Raman Puri. Dr. Puri holds the credit for being the personal cardiologist of the former Prime Minister Dr. Narasimha Rao, and he is recognized for his contribution in the field of medical healthcare. Dr. Puri's accomplishment in the field of interventional cardiology and community-based preventive cardiology is absolutely because of his determination than destiny. With more than 1 lakh non-invasive cardiac procedures and more than 3,000 invasive procedures to his credit. He has passion to reduce the incidence of atherosclerotic cardiovascular disease among Indian population with a special focus on adolescent and young adults. He has been pioneer and instrumental in framing expert consensus statement to treat dyslipidemia among Indians and Asians. He has worked and is continued to work for the welfare of people by organizing health checkup camps to screen dyslipidemia and hypertension among adolescents and adults. He has established Asian Familial Hypercholesterolemia Registry where such cases can be reported by Asian healthcare workers and patients. Sir, please sit. He has conducted an epidemiological study to understand the prevalence of dyslipidemia in school-going children, abstract published in JACC. Since 2016, in association with Lipid Association of India, which he is founder of, organizing lipid certification course endorsed by International Atherosclerosis Society. He is one of the expert author of the position paper, Statin Intolerance, an attempt at a unified definition. He is instrumental in starting Healthy Heart Cricket Tournament, has first round tournament on 1st April 2018, a unique initiative for his increasing awareness among doctors and public. And since Sir is staying with us since yesterday, we know he is a fun-filled person with healthy and disciplined lifestyle practices. Thank you, sir. The stage is yours.
Okay, कर दिया. So, good afternoon, everyone, and thank you, Dr. Biswas, for giving me an opportunity. And I will be talking on a topic which I think none of you have ever heard about it, And that is one of the most important topic because everybody who is sitting here, there is a 30% chance that someone of us will suffer from cardiovascular disease. And unfortunately, we don't bother, though it is preventable. So you will ask me an important question that how I'll get to know that what is my future risk of heart attack. Everyone is interested not to suffer from heart attack. So there are a number of cardiovascular risk assessment tools available internationally from United States to Scotland, UK, Italy, Germany, Europe, Asia Pacific. In 2026, we'll have India also in this map. We are also coming out with the LIASFD risk calculator. We'll launch in another 2 months' time. So what is the advantage of, calculating the risk? Because by this you will come to know that what are your chances of having heart attack, stroke, or peripheral artery disease in 10 years, 30 years, or lifetime, depending upon which risk calculator you are looking at. And based upon that, the treatment can be modified from lifestyle intervention to, more intensive lipid-lowering drug and other evidence-based medical treatment. There are a number of, important, internationally important risk calculator and Framingham risk score, every one of you are familiar with, then followed by Q risk score, then American Heart Association came out with pool cohort equation, then subsequently they came out with the Prevent 2023, 2026, and we have a European score also, and now the entry will be of LIASFD risk calculator this year. The first risk calculator was, I will give you some background about risk calculator so you understand better what exactly LAI risk calculator will be and how it is different from them. So first risk calculator was in 1967. It was a Framingham risk score. Rather, it laid down the foundation for its subsequent version, and also it helped for other risk calculator also, because whatever they started with was adopted by many other risk calculator. The most famous was in 1998 Framingham risk score because it was very simple for clinician to use it, and it provided us 10-year risk. It was not lifetime, it was only 10-year risk. And these were the 7 traditional risk factors on which it was based upon, and classified patients into mild risk group, intermediate risk group, and high risk group. And only limitation of this risk calculator was that it was 10-year risk, and this is not very friendly for the younger people because it always underestimates the risk. When risk calculator was applied to the Caucasians and South Asians, you can see that there is, what predicted and what observed risk was there overlapping in Caucasians, but there was a wide gap in South Asian of what you predicted and what you observed. Then, Q risk score from UK came. It was published by NICE guidelines, and what they did that they incorporated a calibration factor of 1.4 for South Asians. What is calibration factor is whatever is the risk calculated by this risk calculator for European, and that will be multiplied by 1.4. That will become for South Asians. And so they included 5 more variables than 7 traditional risk factors. And of that, one was ethnicity, then diabetes, CKD, atrial fibrillations. And definitely it was superior for South Asians as compared to Framingham risk score. Then subsequently they came out with Q risk 3, and they added another 9 variables. And subsequently lifetime risk calculator was published by NICE in 2018, and this is good for Indian younger population, because whatever underestimation of risk is by other risk calculator is not with this, because it predicts risk at 80 years, not at just 10 years or 30 years. In 2013, ACC came out with risk, pool cohort equation. It also gave us 10-year risk of ASCVD events. And in addition to the 7 traditional risk factors, it incorporated 2 more variables. One is whether the patient is on antihypertensive drug or not. And second is that race, which was whether the patient is a white population or African Americans and others. If you look into, and then, at the pool cohort equation, the age was from 40 to 79. So it is not applicable for Indian because majority of patients who, 25% of patients who sustain MI in India is less than 40 years of age. So 40 is too high for Indian population. Then they came out with an ASCVD risk estimator where they brought down the age from 40 to 20. Then came up the PREVENT score, in which they added another 14 variables. The most important variables were EGFR, HbA1c, urine ACR, and BMI and social deprivation index. And they classified patient risk into low risk group, which was less than 5%, borderline 5 to 7.5%, intermediate was 7.5 to 20%, and high was 20%. In and they gave us 10 years and 30 years risk. And in 2026, they updated this, risk score again, in which the low risk was less than 3%, borderline was between 3 to 5%, intermediate was from 5 to 10%, and more than 10% was high risk group. When pool cohort equation and Q-risk score was applied to South Asian versus Caucasian, you can see that almost overlapping risk, scored for European and South Asian. But when you see the risk of events, the risk of events in South Asian was 2 times more as compared to, Caucasians. So we have discussed about Framingham risk score, we have discussed about pool cohort and Q risk, whatever they have done, but still the risk is still high. But therefore, because each risk score is applicable only to the population from which it is developed, and because if you look into the South Asian population in worldwide, it is from 2 to 5%. Maximum is in Europe, and in USA it is only 2%. But these risk calculator and subsequently the lipid guidelines of USA and America was very good for their population. If you look into the CVD death and ISD death, there have been a significant decline from 1990 to 2023, and also in Europe also. But those South Asians living in United States and in Europe, despite following their lipid guidelines, despite following their risk calculator, despite following their other evidence-based medical treatment, they still continue to have 2 times more events as compared to their native population. We have been following, we still love, many of us still love Europeans and American lipid guidelines. Remember, we have been following it for decades together, and mortality has gone up by 41%, and even we don't understand the reality, and we close our eyes. We love Americans and European guidelines to such an extent that we don't bother about the mortality. There are a number of reasons why we have higher events, because we have high prevalence of atherogenic dyslipidemia, we have high prevalence of traditional risk factors, we have visceral adiposity, very nice topic yesterday evening session, they talked about adiposity, and risk factors coming at a younger age, because we develop diabetes 10 to 20 years earlier as compared to the European Western population. We have a poor control rate of hypertension, hypercholesterolemia, and diabetes, and poor awareness of dietary pattern and sedentary lifestyle amplify lifetime risk, and therefore the risk in Indians starts earlier and it accumulates faster. Americans and Europeans are very true to us. They say, look, South Asians, you are not as much risk as we have. You have more risk as compared to us. So what they do, they indirectly tell you that you are a risk enhancer. So they have put South Asians into a risk enhancer category, in a category where they have put lipoprotein A more than 50 milligram and LDL cholesterol of 160 to 189 milligrams. So means whatever the risk LPA of more than 50 or cholesterol of 100 and LDL cholesterol of 160 to 189, that much risk, extra risk we are going to have. That is as per whatever they have stated in their guidelines. Even European Society of Cardiology also have said the same thing, that South Asians, you are a risk modifier for us, and your risk category is equivalent to those with a family history of premature coronary artery disease or LPA of more than 50 milligram. I'll just give you an example what LPA of more than 50 will contribute to. That much, whatever contribution of LPA more than 50 means South Asian ethnicity is going to contribute to that if you have the same target as Americans and Europeans. At any risk, whether it's a 5% risk or 10% risk or 15% or risk 25%, as the LPA goes up, the absolute risk goes up. Now from 25% risk, the risk goes up by 43% to 68% when the LPA goes from 70 milligram to 150 milligram. And it goes from 15 to 40.8% jump of 25.8 in moderate risk group. And in 5, it jumps from 5% to 13.6%. So at any level of risk, whatever risk you have, if you have LPA more than 50 milligram or 70, the jump, it increases the risk of cardiovascular event. When you incorporate lipoprotein A in the risk calculator, why I am going to say this, because our risk calculator incorporates lipoprotein small a, the lifetime risk goes up from 30.4 to 52.1. So this means without LPA incorporation, your risk is underestimated, and once you incorporate LPA, the risk goes up. That is the added advantage which this LEI risk calculator is going to have. So looking into all this, the CVD in India is basically a health emergency. We developed heart disease 10 years earlier as compared to other ethnic group. And as I said before, also 25% of MI occur in patients under the age of 40 years. And 50% of death related to coronary artery disease in India is in individual below the age of 50 years. That shows we lose quite a young, lives. So here comes the role of LEI-ASCVD risk calculator. These are all Bollywood actors. I think you are familiar. These faces are familiar. We lost them. And these are the Bollywood characters. They were saved because they got the intervention, and they were prevented from the catastrophe. So you will all ask me that why don't we have calculator like your risk calculator? Because we don't have long-term national cohort data. You have to follow 100,000 population for 10 to 15 years to come to and make risk calculator, because that will tell you how many of these patients died. And when you evaluate these patients who died, you find out what risk factors were there. And then you make various formulas to calculate the risk. Then lab variability is there, from no unified follow-up system, poor event capture, and population heterogeneity. South India versus North India, East versus West, the dietary patterns are different, environmental factors are different. We realized all these things in 2016, and we took 2 years to frame the Part 1 consensus statement based upon major ASCVD risk factor, high-risk conditions, and non-conventional risk factor. We classified patients into low-risk group, moderate risk group, high-risk group, and very high-risk group. We were the first association in the world to recommend LDL cholesterol less than 50 milligram in patients with high-risk group. We updated our risk algorithm again in 2020. We modified non-conventional risk factor. We added 4 non-conventional risk factor, removed metabolic syndrome from this, and we created a new risk category, which was an extreme risk group, which was further divided into category A and category B. The basic prerequisite for extreme risk group was underlying ASCVD. And category A was those patients of ASCVD or coronary artery disease who had one or more features of high risk group. And category B were those patients of coronary artery disease or ASCVD who had features of very high risk group. And for category B, we recommended LDL cholesterol goal of less than 30 milligram. That was again first time in the world. But 1 year after our recommendation, National Lipid Associations of United States for their South Asian population also recommended LDL cholesterol of 30 milligram by creating a new risk category in their risk category group of extreme risk group. So they followed exactly what we did 1 year after we published our consensus statement. Then in 2023, we updated again our consensus statement, but this time our main emphasis was on subclinical atherosclerosis. We wanted to prevent sudden death in younger population, and also we created some category, new category, category C, and we included number of risk modifiers. We included number of high-risk features, and category C were those patients of category B who, despite following all possible treatment, continue to have cardiovascular events. So there were very few patients. You may encounter 1 or 2 patients in your whole span of your practice, or you may not be encounter these patients, but we did consider these patients and came out with a new recommendation of LDL cholesterol target of 10 to 15 milligram for category C. We see this algorithm looks quite busy, so it will be very difficult for you to calculate the risk based upon this algorithm. So we have incorporated all these variables which are there in the algorithm in our this risk calculator, or you can call it as a risk estimator. And this is available for Android phone at present, but it is available soon for iPhone, and it is also available for desktop. But we have not released it so far for the doctors, and even not for the patients also, public also. You have to provide basic information, medical history, and lab investigations based upon whatever is there in our risk algorithm. And in this lab report, we have included ApoB, we have included coronary artery calcium score, we have included high sensitivity CRP, we have included lipoprotein small a. All those factors, risk modifier, which are important, we have included in our risk calculator. None of the risk calculator in the world has so many variables included, which will give you a perfect risk assessment of the person, of what is the future chances of having events in these patients. This is the final report. It gives you low risk group, moderate risk group, high risk group, and very high risk group. And in addition to the risk category it gives you, it tells you what should be the LDL cholesterol target of this patient, what should be the non-HDL cholesterol target of this patient, what should be the ApoB target of this patient, and why this patient is in the low risk group, why he is in moderate risk group, why he is in very high risk group, and why he is in extreme risk group. It provides you the basic reasoning for classifying that patient into that particular risk group. Now, coming to the initial experience we have, I can tell you that unofficially we have used this risk calculator in more than 10,000 Indian population. And there are about 70 doctors who have been using this risk calculator at present. But for its validations, we cannot have the natural history for 10 to 15 years, so we have adopted 2 methods to validate it. One is the pre-CAT study which we are doing, is that it will assess the validity of this risk calculator will be applied to those patients presenting with the first ACS in the emergency department, to find out what would have been the risk category of this patient if I would have applied this risk calculator about 7 days before. What was the risk category would have been the risk category of this patient. And I'll just give this is not the perfect, because I'm not going to disclose those data at present, but I'm just going to give some information about. This is Kerala data of about 763 patients. In this, it was found that 83.4% of the patients who presented with first ACS were in high or very high risk group. And another 404 patients from the Kerala, in which LAI was compared with the Q risk score, it shows that LAI predicted in 86% of patients was in high or very high risk group, as compared to 45.2% with the Q risk score. Then this is the data from Lucknow, where LAI was compared with Q risk and prevent score. You can see 81% versus 30% versus 14%. So overall, it tells us that what LAI is predicting the risk of those patients who presented with the first ACS, they were basically in high and very high risk group. And these are the group of patients where your LDL cholesterol goals are lower and you are more aggressive. Now, the question is that, do we have any evidence in the other international scenario also? Fortunately for us, when we started pre-CAT study, 1 month later we got a study from USA, it was published in JACC Advance. They also did the same, their method was same to predict the risk category of a patient presenting with ACS a week before using ASCVD risk estimator plus and prevent risk calculator. Here you can see that when the risk estimator was applied, 45% of these patients were either in low risk group or borderline risk group, which even didn't require statin treatment nor further investigation. And in prevent, it was 61%. So means the estimation by them was quite poor to predict that this patient is going to have future cardiovascular event. Even in a study from Medanta Hospital, they used various risk calculator and they found that the JBS3 was able to predict this just in 44% that patient was in high risk group, those who presented with ACS. Now question comes that you will say that your risk calculator is predicting high and very high in all patients, so your number is gone up. So no. We have another apricot study, which are being this risk calculator is applied for general population who doesn't have clinical ASCVD. And at present, this is from one center where the patients, majority of patients are in low or moderate risk group, and only 30% were in high and very high risk group. ALA apricot study will be the first study to be published. So I will give you some information that there is a strong agreement with QRIS3 and prevent with increasing risk stepwise across all LAI. So when LAI risk goes from low to moderate, moderate to high, similarly Q risk goes from low to moderate to high. But LAI risk calculator up-classify many Q risk lifetime moderate or moderate high subject into high risk group. This is especially important in a younger population where long-term risk is high despite low 10-year risk. Together, these findings support LAI as a more context-appropriate tool for earlier ASCVD risk detection and prevention in Indian population. We are going to compare our LAI risk calculator with Prevent 2023, Prevent 2026, and QRisk Lifetime. There is no study internationally, no study yet internationally, which has such a comparison. Only there are a few limitations. We have not it is not derived from the long-term natural cohort data, and quantitative risk values are not provided. To summarize, accurate ASCVD risk assessment is fundamental to guiding key therapeutic decision in cardiovascular prevention. No prospectively validated ASCVD risk calculator exists for the Indian population. Existing tools derived from US, UK, and European cohort have limited applicability in Indians. By incorporating Indian-specific cardiovascular risk factor, it enables more precise risk stratification and rational LDL cholesterol lowering strategy. Now I am going to show you two videos. Yes, it will be there. Okay. Yeah.
Know your heart rate.
1 minute. We are going to release this video or song on 15th of August. This is LAI Anthem.
Every heartbeat tells a story. A healthy heart is strength and glory.
India's bright, shining bright. Take good care of your heart tonight.
The Lipid Association of India says, know your heart risk and healthier ways.
After age 18 to 20, don't delay. Get your lipid profile today.
Check your LP level too. Know the facts that matter to you.
a difference somehow. Regular checks can ease your fears. A healthier future through the years. Know your heart risk today. Know your heart. Know your heart risk today. Regular screening leads the way. Regular screening leads the way. Build a healthier India. Stay away from heart attacks. The Lipid Association of India calls. Know your risk and take control.
The Lipid Association of India has a message for everyone. Use the LAI SCVD risk calculator
To understand your heart risk well.
Get regular health screenings.
Take the first step today.
Choose the path to a healthier life.
And keep your heart strong every day.
Know your heart risk today.
Know your heart.
Know your heart risk today.
Regular screening leads the way.
Regular screening leads the way.
Build a healthier India. Stay away from heart attacks.
The Lipid Association of India calls.
Know your risk and take control. See your doctor if needed.
And something more. Wait, something more.
শুরু হোক একবার অন্তত পরীক্ষা হোক লিপিড প্রোফাইল এলপি দেখুন আজ নিজের ঝুঁকি জানুন
ভালো খাবার দিন থালায় ফল আর পূর্ণ শস্য থাকুক প্রতিদিন একটু যোগ ব্যায়াম শরীরটা থাকুক সহজ আর আরাম
দিনে 30 মিনিট চলুন হাঁটুন নড়ুন ঘাম ঝরান
মদ ধূমপান তামাক নয় জাঙ্ক ফুডকে আদি না বলুন
হৃদয়টা বাঁচিয়ে রাখুন
আজ পরীক্ষা করান
হৃদয়টা বাঁচিয়ে রাখুন
আজ নিরাপদ থাকুন
হৃদয়টা বাঁচিয়ে রাখুন
রাখুন ঝুঁকিটা আগে বুঝুন
হৃদয়টা বাঁচিয়ে রাখুন
রাখুন আজ সুরক্ষিত থাকুন
মাদকের জালে পা দেবেন না নিজেকে আজই আঁকড়ে ধরুন
এলো এআই এর সবার জন্য কথা সতর্ক থাকুন সচেতন হন
ঝুঁকি বুঝতে হিসাব করুন
এসসিভিডি রিস্ক ক্যালকুলেটর
ছোট পদক্ষেপ বড় রক্ষা
এটাই সুস্থ ভবিষ্যতের সূত্র
দিনে 30 মিনিট চলুন হাঁটুন নড়ুন ঘাম ঝরান
মদ ধূমপান তামাক নয় জাঙ্ক ফুডকে আজ না বলুন
হৃদয়টা বাঁচিয়ে রাখুন
আজ পরীক্ষা করান
হৃদয়টা বাঁচিয়ে রাখুন
আজ নিরাপদ থাকুন
হৃদয়টা বাঁচিয়ে রাখুন
রাখুন ঝুঁকিটা আগে বুঝুন
হৃদয়টা বাঁচিয়ে রাখুন
রাখুন আজ সুরক্ষিত থাকুন
আজকের সিদ্ধান্ত আগামী দিন স্বাস্থ্যই হবে আপনার ঢাল
থামুন ভাবুন এগিয়ে চলুন নিজের হৃদয় রাখুন সামাল
হৃদয়টা বাঁচিয়ে রাখুন
আজ পরীক্ষা করান
হৃদয়টা বাঁচিয়ে রাখুন
Thank you very much.
What a wonderful, beautiful, and engaging session. Let's thank our speaker in the best way possible with a standing ovation. Thank you very much, sir. I request all the faculty members to kindly remain on the stage for the group photograph.
Thank you, sir. To steer the discussion for the next session, may I request our moderator, Dr. Amitabh Vishwas, sir, to kindly come forward and take the stage. Our next session is the industrial sponsored session. Amitabh Vishwas, sir. So please welcome Dr. Amartya Shankar Chaudhary, sir. The session is chaired by Dr. Arnab Chakraborty, sir, and moderated by Dr. Amitabh Vishwas, sir.
Hello. Good afternoon, everybody. Nice sessions this morning. Thankful to you all for a great gathering and enjoying the programs. It's a sponsored session. I invite Dr. Arnab Chakraborty, Dr. Gautam Rai, Dr. Vikas Shaikia. Please come on the dais as chairperson. Gautam Rai, Dr. Vikas. Dear delegates, this is an era of, we are all discussing about the obesity and the other which is now newly coined terms of the adiposity-based chronic diseases based on the 3 lectures. And we'll discuss, have a panel of discussion at the end of the 3 sessions. I invite for the first session Dr. Amartya Shankar Chaudhary to deliver a talk on the obesity, a silent multiplier of diseases. I invite Dr. Amitabh Sur to start the topic.
Slide
Slide, change the slide. Dr. Amitabh Sur.
No, you have to change the slide first. No. এটাই তো হ্যাঁ it's okay. Slide is okay, sir. So at the outset, thank you, Chairperson, sir, for the kind introduction. Thank you to the organizing committee of BDCON and Eli Lilly for this opportunity to speak in front of this August gathering. Obesity has now taken shape of a silent pandemic in our country, globally actually, but particularly more so in our country. It's a harbinger of so many diseases. So it becomes all the more important to talk about obesity as well as its treatment. This is a multi-speaker symposium sponsored by Lilly. My job will be to introduce obesity to you. Obesity, a silent multiplier of diseases. As it is a Lilly-sponsored symposium, I also have been hired by Lilly for this program. So, coming to the agenda. So, intended key learning from the presentation will be to understand why obesity is gaining recognition as a disease worldwide. why is obesity a silent multiplier of diseases, how excess adiposity is related to diseases like type 2 diabetes, obstructive sleep apnea, hypertension, and physical diseases like osteoarthritis. Why is it important to treat obesity proactively? So as I said, obesity is a silent epidemic, pandemic, whatever you say. In world, 2.5 billion adults are living with overweight, and roughly around 890 million adults are living with obesity. Life expectancy for people who are living with obesity per se is reduced on an average by 1 to 2 years for people who are having a BMI between 27.5 to 30, and it may be by around 8 to 10 years for person who are having a BMI in the range of 40 to 50. The ICMR India 17 study showed that in India, roughly around 30 crore people, 33 crore to be precise, might be living with either overweight or obesity. Now it is prevalent throughout the country, but then certain states like Kerala, Punjab, Delhi and Tamil Nadu have very high prevalence of obesity. Mind you, these all are, this data or whatever it is through, these data have been collected based on the BMI, which itself is has got some limited interpretation, which we also will be discussing. Obesity per se is defined as a prevalent, complex, progressive and relapsing chronic disease, which is characterized by excess body fat that can impair health. It is a chronic, progressive, relapsing, multifactorial neurobehavioral disease, wherein the increase in body fat promotes adipose tissue dysfunction, and abnormal fat mass physical forces result in adverse metabolic, biomechanical and psychosocial impact. Obesity has got multifactorial origin, from genetics to epigenetics, from physiological factors, environmental, socio-cultural and also behavioral factors affect obesity. Obesity is not prioritized as a disease, leading to delays in diagnosis and management. That's the unfortunate fact of the society in which we live. It has been seen in various surveys that patients who are consulting their healthcare professional in last 5 years, and those who are obese, actually only 50% of them say that their obesity have been ever discussed by the physician with them. So this is very low actually. Only 21% of people say that they have been offered any weight reduction, lifestyle or medical management. So it's very poor actually. So first of all, we have to improvise upon ourselves as physicians to discuss about obesity as a problem with our patient. Whichever problem the patient comes with, we need to discuss about obesity, even if the patient is not highlighting obesity as an issue. So to keep patient informed that this is also a problem. BMI is something which we often use to see whether the patient is obese or not. In Indian context, BMI of 23 to 25 is regarded as overweight, and BMI above 25 to 30, it is obesity class 1, 30 to 35 is class 2, and above 35 BMI it is class 3. But BMI has got so many limitations. BMI, as you understand, body mass index, it doesn't take into corporation the muscle mass of that person. Many athlete or athletic type body individuals with high muscle mass can have high BMI, but they may not be having very high fat mass. Similarly, patients who are sarcopenic, who have less muscle mass, might be having relatively low BMI, but they are still obese because of high fat mass in them. It also doesn't capture ethnicity, adipose tissue dysfunction, the risk lifestyle factors into incorporation. It also doesn't capture the influence of sex and age so far as obesity is concerned. So we definitely need some better marker for obesity, and we also need something which is more sensitive and specific to assess obesity per se. Now, bioimpedance based fat mass assessment with the help of BIA based machines are nowadays very commonly used, where we measure the total fat mass of the individual. Here the percentage of 30 and 25% cutoff we need to remember. 30% for men, 30% for women and 25% for men, above which we say that fat mass is more than normal and the person is obese. Then there are anthropometric component which we need to remember. waist circumference, waist to hip ratio and waist to height ratio are more commonly used. Waist circumference cutoff of 90 and 80 centimeter for men and women is taken as benchmark for Asian Indian patients. Waist to hip ratio of 0.9 and 0.85 for men and women. Waist to height ratio of 0.5 and above is regarded as obese. 0.6 means the person is having very high risk of obesity related complications. Now, we say a person is obese when the BMI of the person is above 25 in presence of at least one anthropometric parameter or at least two anthropometric parameter, either waist circumference or waist to hip ratio or waist to height ratio is showing that the person is obese. In absence of visceral fat, in absence of BIA based fat assessment tool available to us. Also, we have other classification system for obesity which are more rational compared to the BMI based classification. For example, the Canadian Society recommend the EOSS, that is Edmonton Obesity Staging System, which has got 5 stages, stage 0, 1, 2, 3 and 4. Stage 0 means the person might be obese but is having no other risk factors or no other comorbidity with obesity. Stage 1 means the person might be having some comorbidities like pre-diabetes, etc., or just raised blood pressure. Stage 2 is when the person is having some hardcore diseases which are related to, linked to or caused by obesity, like diabetes, hypertension, obstructive sleep apnea. Stage 3 is when the patient has got some event like heart failure, CKD, MI, etc., and the person is obese. And stage 4 is when the person is having limited life expectancy and is completely wheelchair bound. Similarly, there is a Lancet classification. We have preclinical obesity as well as clinical obesity. Preclinical means again obese but do not have any obesity related complication or diseases, and clinical obesity when the patient is obese and is having clinical obesity related diseases like diabetes, MASLD, etc. Now, so if you in your prescription actually want to stage obesity, you have to check for the BMI of the patient and anthropometric data. If any one anthropometric data along with BMI is positive, then you label the patient as obese. Preferably mention class 1, 2 and 3 as I have mentioned. And also preferably, it is not very difficult to do, mention the EOSS grading or EOSS staging so that you can have a better purview that with this, whether this patient will require obesity related medication or not. It may be so that a person is having a BMI of 27 or 28 but is having so much risk factors or complications for obesity like MASLD, maybe heart failure with preserved ejection fraction, and is a more deserving candidate for obesity related medication. Then a person is having a BMI of 32 but is having preclinical obesity and not having any obesity related diseases. So, obesity, in obesity, the adipocyte dysfunction is a key driver for related complications. Healthy individual display normal adipocyte, but in obesity, adipocyte increase both in size and number, and there is increased fat deposition, both visceral fat and ectopic fat. Visceral fat in the retroperitoneal space, omental, mesenteric, and the ectopic fat in epicardial, pericardial, hepatic, pancreatic, etc. phases. And this enlarged and dysfunctional adipocyte lead to local and systemic inflammation and insulin resistance. Cytokines like interleukin 6, TNF alpha, MSMPP1, these all increase and they contribute to the pathogenesis of obesity, which contributes to diabetes, sleep apnea, hypertension, heart failure, osteoarthritis, CKD and other obesity related cancers. So risk of all these actually increase in patients living with obesity. For example, risk of type 2 diabetes increased by up to 5 times in patients who are having obesity than those who do not. Obesity per se actually also increases hyperglycemia because increased adiposity leads to expansion of adipocytes and inflammatory milieu that at the level of skeletal muscle lead to increased lipid uptake and increased lipid storage, and thereby it reduces glucose disposal at skeletal muscle. At the level of liver, it causes increased fat accumulation, increased triglyceride secretion, increased insulin resistance, and therefore increases glucose production at the level of liver. And at the level of pancreas, it leads to increased islet cell damage and reduced beta cell function. And all this contributes to hyperglycemia. Similarly, increased adipose tissue deposits in key areas can lead to obstructive sleep apnea. Like localized increase in adiposity around neck and throat leads to obstructive sleep apnea. In turn, that can reduce lung volume, reduces chemosensitivity, and that in turn exacerbates or increase OSA further. It also creates hormonal imbalances, and that also contributes to insulin resistance and increases hypertension. Excess adipose tissue as such also increases hypertension by causing hyperinsulinemia, which overactivates the renin-angiotensin-aldosterone axis, and it also activates the sympathetic nervous system, causing vasoconstriction and increased sodium reabsorption, water retention, and that actually propagates hypertension. Similarly, obesity leads to chronic low-grade inflammation at the level of cartilage, its degradation and synovial inflammation, fibrosis, etc., which actually propagates and drives osteoarthritis. So therefore, addressing obesity may improve or prevent obesity-related complication. In fact, it has been seen that up to 5% weight reduction offers you benefit in terms of hyperglycemia as well as hypertension, but then chances of diabetes remission become very, very significant if there is a weight reduction of more than 15%. Similarly, fibrosis reduction in MASLD or MASH, you can say, is significant to an extent of 40 to 50% if the patient loses more than 15% of body weight. There is significant benefit in terms of obstructive sleep apnea and osteoarthritis if the person can lose more than 15% of body weight. So weight reduction can improve person's quality of life. Excess weight reduces person's quality of life, and weight reduction as little as a BMI percentage 0.1 reduces quality of life, and this also has been documented. Now, key takeaways from today's presentation: obesity is a complex, chronic, progressive and relapsing disease driven by complex interplay of systems within the body and require long-term management and treatment. In obesity, adipocyte dysfunction is a key driver of related complication. Diagnosing and treating obesity with urgency can prevent or reduce the risk of spectrum of obesity-related complication and improve the quality of life of people living with obesity. With this, I stop here.
Good speech, Dr. Amita Basur. We know that obesity is a silent epidemic. So I want to say it is associated with diabetes mellitus type 2, cardiovascular diseases, fatty liver diseases, with osteoarthritis, then after that obstructive sleep apnea, as you have told. So there are some medicines also, those which are making obese, such as antidepressants, antipsychotic drugs, and also with corticosteroids. So many of the drugs such as naltrexone, bupropion, after that orlistat, this type of drugs has been used. Now GLP-1 receptor agonist also has come. So my question is what is the successful rate in the near future for this?
The panel discussion will discuss at the end of the sessions. Call the next lecture.
May I now invite Dr. Amartya Shankar Choudhury, an eminent, distinguished and renowned endocrinologist of Mission Hospital. His topic is GLP-1 receptor and beyond, Monjaro as a class of its own.
Thank you. Slide changer. Eta. Back. Eta. Pointer. Thank you, respected chairperson, and as a part of the organizing committee, I extend my warm welcome to those who have come here to attend the conference, and also thank our national speakers who have spared their valuable time to come over to Durgapur, adding a lot of, giving us a lot of new insights into the newer therapies for the management of diabetes and metabolic disorders per se. So this is a sponsored session. I'm the second speaker of this session. I'll be speaking on Monjaro tirzepatide, a GLP-1 receptor agonist, beyond GLP-1 receptor agonist, having a class of its own. Okay, these are the disclaimers. Yeah. So whenever I come across patients with type 2 diabetes, the most important thing which I discuss is the diet. Nowadays, with a lot of changes in the lifestyle and diet, I try to promote protein intake in most of our patients, reduction of carbs, more of fiber. And while discussing protein intake, I ask them, most of the Bengali patients, I ask them, how much protein do you take, or the intake of protein? Are you taking fish regularly? Are you taking eggs regularly? So we know that Bengalis cannot live without fish. Bengalis are primarily fish eaters. Now, having said that, recently I've discovered that now, just 2 days back, a patient came. ডাক্তারবাবু এখন তো শ্রাবণ মাস, সোমবার দিন মাছ খাচ্ছি না, তাহলে ওকে টিউসডে ওয়াটার, টিউসডে হনুমানজি, Thursday we have vegetarian diet since 200 years, it's a family traditions. Okay, Friday I take chicken and fish. Saturday, recently I met an astrologer, said my shani is very bad, I'm taking vegetarian diet on Saturday. So ultimately the protein intake of Bengalis have come down. The Bengalis have moved from a fish-centric approach to a more veg-centric approach, from like just like diabetes has moved from a glucocentric approach to more of a cardio-renal benefit-centric approach. So Bengalis have learned to live without fish and have adopted vegetarian diet, but physicians, diabetologists and endocrinologists, we have not learned to live without incretins day in and day out. We have been using incretin-based therapies over 20 years, but a single day, I'm telling you, guarantee you, no physician can spend a single day without prescribing a single incretin, be a DPP-4 inhibitor, be a GLP receptor agonist, or the dual GIP-GLP. Now we have been using GLP-1 based injectable therapies for quite some time, almost 2 decades, and probably the best injectable option we had other than insulin. Tirzepatide is basically an enhancement of the concept of GLP-1 receptor agonist, where it is a dual agonist of both GIP and GLP-1, and is basically a different class of molecule. Even the national bodies, the international bodies, ADA, I would say all the guidelines now recognize these as a separate category of diabetic therapy. Even the ATC classification of WHO has placed it under a separate subgroup and not clubbed it together under GLP-1 receptor agonist therapy. So it has a class apart. It is not just a plain GLP-1 receptor agonist we have been using for so many years. It has distinct advantages of extra receptor activity on the GIP, which is probably more potent in releasing of insulin, more better action on the adipose tissue metabolism, definitely much better weight reduction and HbA1c reduction. Now, how much the clinical trials will translate into clinical practice, we will come to know only if we discuss some hypothetical cases. I'll move into 2 cases. First one is a clinical case where Mr. Ajay is a 52-year-old, diabetes, has hypertension, mild neuropathy, diabetic for last 9 years. He's on metformin, empagliflozin, hypertensive on amlodipine, telmisartan, rosuvastatin. Now he has a BMI of 30.7. Dr. Amitabh has nicely mentioned about the classification of BMI in Indian context. A1C is pretty high, 9%, fasting 150, PP of 210. He doesn't have pancreatitis, he doesn't have severe NPDR. Now, for those who are starting to use GLP-1 receptor agonist-based therapies or incretin-based therapies, these are the 2 important histories you should always take before initiating these molecules, because we do not give this in patients who have pancreatitis or who had a history of pancreatitis, and we will avoid using it in a patient with active proliferative retinopathy requiring active intervention. Now, what would be your treatment goals for these gentlemen? A1C target and the weight loss target. Now, A1C target, most of us will agree definitely in young patients less than 7, even less than 6.5, if we can bring it down with medications which will not cause hypoglycemia. And weight loss, we expect a weight loss at least a target of 5 to 10% if the patient is obese in a 3 months period of time, and maybe more over the period of time. 10 years back, many people would have been happy adding just a sulfonylurea, A1C would have come down in a period of months. Some patients, okay, sulfonylurea will, okay, give a basal insulin too. But at present scenario, everyone in this room and probably everyone else would agree that a incretin-based therapy is either a GLP-1 receptor agonist or a dual agonist of GIP-GLP-1 like tirzepatide would be the most suitable option in these gentlemen, where we want to bring down the A1C as well as want to reduce the obesity so that we can reduce the cardiometabolic disease or cardio-renal burden of this patient in the future. ADA recommends when choosing glucose-lowering therapies, prioritize medications with beneficial effects on weight, and for these tirzepatide and semaglutide are the most preferred injectable therapies in today's world, and these are the molecules the most sought after when we attempt not only to reduce blood glucose but also to reduce body weight. Now comes the question, among these two molecules, which will be the better, while if you want to reduce the A1C, which will be the better if you want to reduce the body weight. So we have answers, we have clinical trials, we have head-to-head clinical trials with injection semaglutide versus injection tirzepatide. This is the SURPASS-2 trial, where these two molecules were compared, followed up for 40 weeks, and then we had the results. If you can see the results, even the minimum dose of, this is not working, anyways, even the minimum dose of tirzepatide of 5 milligram weekly was superior to semaglutide in reducing the A1C. It was 1.9% with semaglutide, it was almost 2.1 with 5 milligram, and very high, up to 2.5 A1C reduction with 15 milligram of tirzepatide weekly. Now, meaningful A1C reduction, 1.9% is not a bad number. It's actually a huge number if you consider the different pharmacotherapies in the treatment of type 2 diabetes. Meaningful A1C reduction was seen with semaglutide as well, the 1 milligram dose, which is the approved maximum dose for treatment of type 2 diabetes. But even with the minimum dose of tirzepatide fared much better if we consider A1C reduction. Now, it is not the A1C reduction in one single patient. We want to see the overall picture, the treatment success. 9 out of 10 patients achieved A1C of less than 7% with the minimum dose of 5 milligram weekly. 51% patients achieved normoglycemia, that is an A1C of less than 5.7 with tirzepatide of 15 milligram weekly. Weight loss has always been there. So even with the minimum dose of 5 milligram weekly, tirzepatide was superior to semaglutide in terms of weight reduction, 7.8 kgs with 5 milligram, 6.2 with semaglutide 1 milligram, up to 12.4 kgs of weight reduction was seen at the end of 40 weeks with Mounjaro 15 milligram weekly, clearly superior than semaglutide. Now, this is one of the most important things when we talk about comprehensive management of diabetes. We need to see the composite endpoints. It is not the A1C reduction. So we want A1C reduction in a obese patient, we want weight loss, and we want this not at the expense of hypoglycemia, we want this without hypoglycemia. So patient achieving this composite endpoint of less than 6.5% A1C, weight loss of more than equal to 10% without clinical hypoglycemia was achieved in 60% of patients with Mounjaro 15 milligram weekly, and this is something which is huge, which is something almost we have achieved the most important target of treatment in the management of type 2 diabetes. Overall safety profile is similar to all the GLP-1 receptor agonists we have been using for so many years, mostly GI side effects, and thankfully the GI side effects are mild to moderate. We have not encountered pancreatitis recently with these molecules. I have not encountered in more than around 180 cases of tirzepatide I have been using over the past 1 year or so. GI side effects initially start for the initial few weeks, but patients do tolerate the molecule after a period of 4 to 6 weeks. Dietary changes are something which is very important to reduce the GI side effects. You have to forewarn or caution the patient that these are the molecules which will reduce your appetite, which will delay gastric emptying, avoid oily food, reduce your oil intake, drink water, drink more fiber, and take less portions, and make them mentally prepared that you are going to face the GI side effects, which is only then you'll realize that medicine is working. So once they are already they are cautioned that this is going to happen, the tolerance is better and the complaints are definitely less. So Mounjaro can help patients like Mr. Ajay in superior reduction in A1C, significantly number of patients achieving normoglycemia, and then definitely superior weight reduction. Now coming to a patient who is obese without diabetes, this is Veena, 45-year-old, 35 kg BMI, had multiple attempts in reduction in body weight without pharmacotherapy, still unable to lose weight. Now, a lot of interventions have been tried. She went for a calorie restricted diet of 500 kilocalorie restrictions. Then a very low calorie diet was tried. And then ultimately, she decided that pharmacotherapy is needed. Now, one pharmacotherapy for one disease, we can reduce the pharmacotherapy of around 10 diseases. This is something where we need to understand, where we need to make ourselves more aware. We need to treat obesity as a disease and not just an extra burden or extra luggage along with other diseases. If we treat obesity, we can reduce the pharmacotherapy of hypertension, dyslipidemia, we can improve cardiovascular outcomes, we can go for diabetes remission, we can improve osteoarthritis, sleep apnea, definite improvement in MASLD and also PAMOS, or the previous terminology of PCOS, also patients improve with weight reduction. So weight loss occurs with Mounjaro as early as 4 weeks, up to 22.5% average weight reduction has been seen with 15 milligram weekly of Mounjaro when it was given for 72 weeks. Now again comes the question, we have two wonderful injectable incretin-based therapies, semaglutide with lot of wealth of evidence in cardiovascular safety, renal safety. And again we have Mounjaro, which we're speaking about today. Now if you consider weight reduction as the main target, which is superior, again we have clinical evidence. The SURMOUNT-5 trial compared 15 milligram, up to 15 milligram or maximum tolerated dose of tirzepatide with the maximum approved dose of semaglutide, that is up to 2.4 milligram weekly. And then again we see that significantly superior weight reduction was seen with tirzepatide up to 21.6% compared to 15.4% on semaglutide. And then achieving targets, body weight reduction targets is again something which is very important. 25% achieved, 36% achieve a weight reduction of 25% with Mounjaro 10 or 15 milligram. 54% of the patient achieved weight reduction of 20% with tirzepatide 10 or 15 milligram. Now we are thin fat Indians. This is not just about weight reduction. We need waist circumference reduction as well. We need to reduce the belly. Up to 8 inches reduction in waist circumference was seen with tirzepatide, and this is again something which is important in Indian context. Side effect profile again very similar to we have seen in the previous trials. Discontinuation rate in the obesity trial with Mounjaro was slightly less, around 6% compared to semaglutide, which was around 8%. Not very different significant statistically, but this less discontinuation rate just clearly shows that this drug maybe is more tolerable to patients who are obese without diabetes, and definitely goes a long way in, the compliance improves, it will definitely go a long way in reducing the body weight. So definitely tirzepatide is a molecule we can help patients to achieve greater weight reduction, greater waist circumference reduction, and a sustained weight reduction for a pretty long period of time. So to summarize, this is the first and only approved GIP, GLP-1 receptor agonist for the treatment of type 2 diabetes and obesity, as well as people with obesity without diabetes. It is a separate subgroup which the ADA as well as WHO have classified under. In people with type 2 diabetes, tirzepatide can significantly reduce A1C, it can achieve normoglycemia and diabetes remission, more weight loss compared to semaglutide. And in people with obesity without diabetes, again, significant weight reduction up to 22.5%, which was seen previously only with bariatric surgeries, waist circumference reduction, and definitely superior weight reduction has been demonstrated in clinical trials compared to semaglutide. With this, I end my presentation. I thank you all for your patient hearing. Thank you, chairpersons. Thank you.
Thank you, Dr. Amartya Shankar Choudhury, for wonderful, spectacular, and marvelous presentation.
Good afternoon, everybody. The next topic is decoding Mounjaro superior results versus semaglutide. And the speaker is none other than Dr. Somik Goswami, who is presently at NRS as Associate Professor. To Dr. Goswami, please.
So very good afternoon to all of you. I'll begin with lines from a Rudyard Kipling poem, which goes like, I keep 6 honest serving men. They taught me all I knew. Their names are what and why and when, and how and where and who. The reason being, unless we ask questions, we cannot become a better clinician, we cannot become a better doctor. And unless we know how and why tirzepatide is better than semaglutide, the mechanisms, the physiology, the pharmacology, we won't get the confidence to actually prescribe, go out and prescribe the same. So this is the mandatory disclaimer. Please do not take photos. This is a sponsored session. And we begin with the discovery of the incretins. We know that after we take in food, it goes to the intestine. In the proximal intestine, we have the K cells. And from these K cells, in response to glucose as well as proteins, as well as fats that are there in our meal, we release GIP. Now, interestingly, GIP was first discovered in 1969. It was called gastric inhibitory peptide. It was known to inhibit gastric acid secretion. It was much later that it got renamed as glucose-dependent insulinotropic peptide when it was realized that it also releases insulin. GLP-1 is secreted, released from the distal gut, the L cells which are there in the distal gut, and GLP-1 was actually discovered much later, but unfortunately, GIP remained the so-called forgotten incretin. It was discovered earlier, but people forgot about it. Only when GLP-1 was discovered and these drugs started to come into development that GIP came into focus once again. But if you look at how GIP and GLP-1 act, we'll realize that GIP is actually the big brother. GLP-1 is the little brother, or GIP is bosses over GLP-1 more often than not. How is it so? If you look at their effects on the brain, both of them decrease appetite, but while GIP has an anti-emetogenic effect, GLP-1 increases nausea, which means that if you put them together, possibly there could be less nausea than giving GLP-1 alone, while both of them would suppress appetite. More interestingly is their effect on the beta cell. We know that the total amount of insulin that is released after a meal, of that, 2/3 comes from the incretin effect, and only 1/3 comes from blood glucose level. So most of the insulin that is released after a meal is not due to glucose acting on the beta cell, but due to the incretin effect, 2/3. Again, if you look at the total incretin effect, 2/3 of the incretin effect comes from GIP, only 1/3 comes from GLP-1. So this is the predominant mechanism by which we release insulin after a meal. If you look at glucagon suppression, here in hyperglycemic states, GLP-1 has an upper hand compared to GIP. But when you have hypoglycemia, it is GIP which drives the counter-regulatory response and prevents persistence of hypoglycemia. At the level of the subcutaneous tissue, there is magic with GIP which is absolutely absent with GLP-1. So what does GIP do at the level of the adipose tissue? It does 3 specific things. It's not only the subcutaneous adipose tissue, but also in the gluteofemoral compartment as well. 1, it increases the blood flow to the adipose tissue, and by increasing the blood flow, more nutrients reach the adipose tissue. 2, it increases insulin sensitivity at the level of the adipose tissue. So in the postprandial period, more glucose enters the adipose tissue. You can store glucose. 3, it increases lipoprotein lipase activity so that you can store fat into the adipose tissue. And this is very, very important because if you consider the adipose tissue like a bank locker, you can store fat, excess fat there, instead of storing it in the heart, in the liver, in the pancreas, which means that if you store the fats in the subcutaneous adipose tissue or the gluteofemoral compartment, you prevent the spillover into visceral adipose tissue, and we know that visceral adipose tissue is not good. At the level of the stomach, GLP-1 reduces gastric emptying, but tachyphylaxis occurs. When you use a GLP-1, for the first 2 weeks, there is reduction of gastric emptying by GLP-1, but after that, this action goes away. What's even more interesting is the so-called metabolic switch or nutrient partitioning mechanism. To put it very simply, as I said, GIP in the fed state, when there is excess of circulating fat, converts it into triglyceride and stores it into the subcutaneous adipose tissue. But subcutaneous adipose tissue has a limit. You can't keep on storing fat endlessly. So when you are not eating, when you are fasting, when the insulin levels are low, but there is GIP because you have given tirzepatide, This GIP breaks down this fat and uses it as a nutrient. So when you are feeding in a fed state, it stores fat in the subcutaneous tissue. In the non-fed state, it causes lipolysis, breaks down this fat and uses it as a nutrient. So this is interesting with GIP, which is not there with GLP-1. Now again, when we are talking of tirzepatide has both GIP and GLP-1 activity as was being discussed, but the GIP activity is similar to endogenous GIP. The GLP-1 activity is somewhat lower compared to endogenous GLP-1. Now you might say, if the endogenous GLP-1 has greater activity, how does tirzepatide give you good effect? The reason is that the GLP-1 action of tirzepatide has something which is called biased GLP-1 agonism, which means that when you stimulate the GLP-1 receptor, there are two things which can happen. Cyclic AMP can increase. There is something called beta-arrestin which can also increase. If beta-arrestin increases too much, there is down-regulation of the GLP-1 receptor and loss of action. Interestingly, with tirzepatide, it has biased GLP-1 agonism, which means that it increases cyclic AMP but does not increase beta-arrestin, because of which there is more potent GLP-1 stimulation compared to giving GLP-1 alone. These, of course, are knockout studies showing that tirzepatide has both GLP-1 and GIP activity, which all of us know, and this is a sort of video representation. It almost looks like the atomic bomb cloud. We recently celebrated Hiroshima Day, but again, jokes apart, this is an interesting depiction which shows how tirzepatide has both GLP-1 receptor action as well as GIP receptor action. Now we come to interpreting how this influences insulin secretion, insulin sensitivity, and so on and so forth. Now there is published data to show that compared to semaglutide, tirzepatide increases both the first phase as well as the second phase of insulin secretion. So what is the first phase? Immediately after a meal, almost within minutes, there is release of pre-stored, pre-formed insulin, which is the first phase of insulin secretion. And over the next 20 to 30 minutes, new insulin is produced and released, which is the second phase of insulin secretion, both of which are better with tirzepatide compared to semaglutide. If you look at insulin resistance, it comes down much better with tirzepatide compared to semaglutide. Again, there could be several explanations. One, as I said, it increases insulin sensitivity at the level of the white adipose tissue, and therefore it reduces insulin resistance. Its GLP-1 action is more potent possibly compared to semaglutide because of that biased effect, biased agonism. It reduces glucose better, reduces glucotoxicity better, and if you put these two together, better beta cell function, less insulin resistance, so automatically you get better glucose control. What about inhibition of glucagon release? Again, as we discussed, GIP, GLP-1, in response to hyperglycemia, both of them reduce glucagon release. So naturally, during a hyperglycemic state, tirzepatide reduces glucagon better compared to semaglutide, and when faced with hypoglycemia, it maintains the counter-regulatory response. This was the metabolic part of the story. What about weight reduction? Now again, when we look at these agents as anti-obesity therapy, the predominant mechanism by which they cause weight reduction is suppression of appetite. They reduce our appetite, and since we eat less than before, there is a negative calorie balance, there is a calorie deficit, which over a period of years leads to significant weight loss. And this is data to show that both Mounjaro as well as semaglutide, they cause similar decrease in appetite. But when you look at results where you compare body weight reduction, you will see that in trial after trial, Mounjaro causes better body weight reduction compared to semaglutide. So what's happening here? So although they cause similar food intake reduction or appetite reduction, if you look at studies, again, the GIP is possibly coming into play here. The reason being, one, GIP has an anti-emetogenic effect, which possibly helps tolerate the drug better over a longer period of time. GIP improves insulin resistance, so there is less hyperinsulinemia in the postprandial state, and we know that hyperinsulinemia promotes weight gain. Third, GIP has been found to increase the sensitivity of GLP-1 action at the level of the brain, at the level of the hunger center. So over a longer period of time, there could be better appetite suppression with tirzepatide. And four, most interestingly, preclinical studies have shown that tirzepatide could also increase energy expenditure to some extent. So both semaglutide and tirzepatide, they reduce food intake, but with tirzepatide, possibly, at least preclinical studies have shown, energy expenditure also increases. Now, when you lose weight, by whichever mechanism, it could be bariatric surgery, it could be lifestyle modification, semaglutide, Mounjaro, you mostly lose fat. About 2/3 or 3/4 of your body weight reduction comes from a loss of fat, but 1/4 to 1/3 comes from a reduction in lean body mass. Now again, when this lean body mass is measured, it's not 100% muscle and bone, because the techniques which are used to measure lean body mass also pick up intracellular water or intrahepatic glycogen as a part of the lean body mass, but you do lose some muscle and bone. But at the end of the day, your fat to muscle ratio improves after losing weight with these agents, because you lose far, far greater amount of fat compared to the amount of muscle or bone that is lost. Again, appetite suppression relates both to reduction of homeostatic hunger as well as hedonic hunger, which means that your appetite for rice, dal reduces as much as your appetite for biryani and rasgulla. So, irrespective of whichever food you are thinking of, you are looking at, your appetite comes down with the use of these agents. So, we spoke about glucose control, beta cell function, weight reduction. What about cardiovascular risk factors? So you do get good BP reduction with these agents. So an individual who is close to their BP goal but yet not at goal could benefit without the addition of an additional antihypertensive agent. Waist circumference reduction is more or less equal numerically to the amount of weight loss from baseline, which means that if you lose 20% of body weight from baseline, your waist circumference will come down by about 20 centimeters. If you look at the effect on lipids, again, like most lifestyle modification or weight lowering agents, the effect on triglyceride is much, much more impressive compared to their effect on, say, HDL cholesterol or LDL cholesterol, but there is overall a good effect as far as the lipid profile is concerned. So if you put it all together, there's a jugalbandi here happening between optimum GIP-1 activity and optimum GLP-1 activity, which contributes to appetite suppression with an anti-emetogenic effect of GIP put into it, effective insulin release, effective glucagon suppression in the fat state, glucagon release in the hypoglycemic state. Due to the metabolic switch and nutrient partitioning happening, it stores fat in the fat state as good fat, and it causes lipolysis and releases it for energy, use as energy when you are in the fasting state. And if you put all of this together, you get better glucose control, better weight reduction over a longer period of time when compared to semaglutide alone. So with that, I bring an end to this, and I think we'll have the panel discussion. Thank you.
Thank you, Dr. Goswami, for extensive and informative talk. Please come and sit with us.
Now the session is open for the questions. First of all, Dr. Goswami, as you nicely mentioned that with the increasing dose of the GLP-1 and GIP, more of weight reduction is there, more of the glycemic control is there, other benefits are also there. So how much you contribute, suppose one benefit is from the increasing the dose, escalating the dose. Another benefit is from the combination of the GIP and GLP-1. How can you say the things more happening with this combination other than only GLP-1?
So I think it is, as I said, the optimum jugalbandi between GIP and GLP-1 which contributes. For example, if you look at studies which have looked at the effect on the brainstem of GLP-1, if GIP and GLP-1 are given together, the effect of GLP-1 is potentiated. Similarly, at the level of the adipose tissue, there is GLP-1 resistance. But when GIP is given along with it, it overcomes this resistance and helps GLP-1 act at the level of the adipose tissue as well. So GIP-1 helps, as a big brother, it helps the little smaller brother, the GLP-1, to act better, which possibly over a longer period of time also contributes to greater weight loss.
As there is already delay in diagnosis of obesity unless there is some comorbidities or some markers. How you assess the patients and how the message should go that at what stage we should think of initiating this GLP-1 or GLP-1-GIP combinations in the patients without any other clinical manifestations?
So in my clinical practice for all the patients, I check the BMI of the patient first. Although BMI and anthropometric parameters should be checked simultaneously, that should be the ideal case. But for limitation of time, what I do in my practice, I check for the BMI first. And if the BMI of the patient is more than 25, it's routinely done in my clinic to check for anthropometric parameter of the patient. And also side by side, if any one anthropometric parameter, either waist circumference or waist to height ratio, which we commonly see actually, is more than normal and the patient is having a BMI of 25, I always do EOSS grading. That helps me a lot, because as we had discussed also, at same BMI level, a person with a BMI of 32 may be relatively much more healthier compared to a person who is having a BMI of 27 with say MASLD or with any other comorbidities. So EOSS grading or staging rather, stage 1, 2, 3, 4, helps me to decide that which patient I should prioritize so far as GLP-1 or GLP-GIP co-agonist treatment is concerned. So here also I have one question from Shomikda also. For patients who are relatively having borderline BMI, say for example the patient's BMI is 27.5, I started say for example semaglutide for MASLD indication, okay, and I am targeting weight reduction of 15%, but a weight reduction of 15% will reduce his BMI way below 27. So now suppose after 6 months his BMI has come to 25.5 and the patient is tolerating semaglutide well, I have documented MASLD for the patient. Am I supposed to continue semaglutide?
So I think we measure BMI at the beginning and not later on, because we measure BMI to know whether there is an indication for using the drug or not. After that, we only measure the percentage of weight lost from the baseline. And of course, if you are looking at MASLD, you do the fibroscan or you do the FIB4 at a certain interval. So we begin from a certain baseline body weight and a BMI of say more than 27. But after that, you just keep on measuring the body weight and see if you have reached the target, 10% or 15%, whatever you are targeting, reduction from the baseline. But again, having said that, in MASLD, a lot of the benefit comes beyond weight reduction. So even if they lose, say 5% of body weight, there is weight independent effect of these incretin agents which give benefit in MASLD.
Yeah, I agree.
So it's not just for weight reduction in MASLD. Treatment per se for MASLD, I think it's better we'll be continuing semaglutide. With the patient it's lifelong.
Yeah,
it's lifelong. It is not just the weight reduction which we are attempting at to reduce MASLD, because there are, Shomikda has rightly mentioned, there are much more other actions beyond weight reduction by which MASLD is taken care of with GLP-1 receptor agonist therapy, semaglutide.
And for obstructive sleep apnea, what should be the ideal percentage target of weight reduction? 15%? Or more than 15%?
From 10% you start getting benefits, but again there are weight independent actions. For example, on central component of sleep apnea, like tirzepatide has published data to show that there are benefits.
Even though GLP-1 receptor agonists, those are like giving a much more good effect for patients. Patient is still living a sedentary lifestyle with lack of physical exercise. So like how many days we should continue with this? It is lifelong, or it is like people are using again, living again, people are using after 1 month. So how many days we should continue, and if we go on continuing with this, whether it will be having a successful rate in the future, or will be suffering from adverse effects much more?
So whatever adverse effect happens at the beginning or after every dose titration. So once you have reached the optimal dose and the patient is not experiencing an adverse effect, the patient will no longer experience an adverse effect. Regarding withdrawing it, there have been studies which have tried to sort of withdraw it or reduce the dose, but it has been seen that the weight comes back again. So if you stop it in the next 2 years, you will regain 80% of your lost weight. You might still maintain 20% of what you lost total. For example, if you lose 10 kgs, you will regain 8 kgs. You might get only a 2 kg benefit after 2 years. So at this point of time, we need to keep on continuing these drugs. There are trials going on as to whether if you reduce the dose somewhat or shift to other weight losing agents, if you can maintain that weight loss. But as of now, we need to keep the patients on these drugs. Optimum weight loss takes about 72 weeks. So it's almost 1.5 years. So at least we have been using these agents for a year or more. So at this point of time, our patients have to be on it at least to experience maximum weight loss. And then as far as current evidence goes, you need to keep the patient on that unless we get data to show that you can reduce the dose or shift them to some other agent.
Any question from the audience?
These are the unanswered questions we have as of now regarding these newer drugs. How long to continue, when to stop, when to reduce, what is the optimum days? These are unanswered questions, but one of the very important points to remember that once the patient stops these medications and the patient again starts gaining weight, and again you start this medicine, again this patient starts losing weight. This weight cycling, or the yo-yo, sometimes we call yo-yo cycling or yo-yo diet. This is again has much detrimental effects. There are studies to show that patients who have continued to have weight cycling have worse cardiometabolic outcomes, more risk of all-cause mortality, cardiovascular mortality. Even in type 1 diabetes, recently around a few months back, a trial was published. They have shown that this weight cycling even impairs or worsens the renal functions in patients of type 1 diabetes as well, even though we are not using GLP-1 in type 1 diabetes, but weight cycling does have its negative impact as well.
I want to know few words about new oral GLP-1 receptor agonist orforglipron and triple hormone agonist retatrutide, GLP, GIP and glucagon agonist.
So again with orforglipron, the same manufacturer is working on it. So there have been published trials on it where it can be given orally. It's a non-peptide molecule irrespective of meal intake, unlike oral semaglutide. So there has been the attain-maintain trial where after injectable tirzepatide they were shifted to orforglipron and they sort of maintained weight. I cannot speak too much about this. You can go into the trial because, as I said, they have certain compliance issues. So we can speak, if anyone is interested, we can speak on a 1:1 basis after the meeting. And regarding retatrutide, again, it's a triple agonist. Along with appetite suppression, it increases energy expenditure to some extent as well, and the weight reduction is even greater.
Thank you.
With orforglipron, the advantage over oral semaglutide is that it doesn't require an empty stomach. So it can be taken any time of the day, even after food. That is the advantage. And weight reduction up to around 11-12 kgs has been seen. The GI side effects are the most prominent side effects which have been observed as of now.
So I am Dr. Arijit from Asansol. Regarding the side effects, and does tirzepatide cause more of aspiration when during endoscopy because of its larger retention of gastric contents?
So regarding gastric emptying, slowing down of gastric emptying, it is GLP-1 which slows down gastric emptying, not GIP. But as I said, tachyphylaxis occurs. So after 2 weeks of use of GLP-1 or GLP-1 GIP co-agonist, there is no further increase or no further action as far as gastric emptying is concerned. So all the nausea, all the GI side effects are happening in the brain. It's not happening at the level of the GI tract.
Sir, is there any difference in gallbladder stone disease among the two?
So whenever you lose weight rapidly, you can have increase even with diet, calorie restricted diet and exercise. But with these agents, with GLP-1 agonists particularly, there are trials which have shown some increase in gallbladder stone compared to placebo. So that is possibly because of more rapid weight loss.
So if there is no further question, conclude the session, please. Thank you. Thank you all the speakers, thank all the panelists.
Thank you everyone for enlightening us with the crux of combination from the guidelines and practical scenarios. Now I request everyone to come forward for the group photograph. I request Dr. Arindam Kumar Hazra sir to come in the side stage for the felicitations. After an intellectually stimulating morning, it's only fair that we let our digestive hormone to take the center stage for a while. Lunch is now served. Next session will be post-lunch. Thank you. Lunch for the delegates on the 4th floor and for the faculties it is on the 2nd floor.
Since we are running short of the time, we will keep the lunch session for half an hour only.
Good morning, everyone. Thank you, the organizing committee, to get me chance to give it.
Check. Check. Hello. 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 কেটে যাচ্ছে নাকি? Check. Hello.
check, 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 hello, check, hello, check, hello, check.
Hello, hello. Hello, check one. Hello, check. Hello, check. Hello, check one. ಇತ್ತು. Hello. Hello, check 1, 2, 3, check. Hello, check 1. Hello, check.
afternoon, everyone. I hope everyone had a refreshing lunch and re-energized for an exciting afternoon of learning. We now turn our attention to an area where meticulous endocrine management can make a significant difference to surgical outcomes. This session is on perioperative endocrinology. To conduct this important scientific session, may I respectfully invite our moderator, Dr. Nilanjan Sengupta sir, Professor and HOD of Endocrinology of NRS Medical College, to join us.
So, good afternoon, everybody. So, my job is not to make you fall asleep and keep you awake. And I have two of my lieutenants who will help me in keeping you awake. The first lieutenant is Dr. Kumar Shapnil, who is a consultant endocrinologist in the city of Patna. He has passed from our institute at NRS Medical College. He will be taking us through preoperative optimization in hyperthyroid patients. And may also call upon Dr. Tomogno Maiti, if he is there around, who is the chairperson of this session. So, Dr. Maiti, please, and over to Dr. Kumar Shapnil.
Sir, may I start, sir? So, a very good afternoon. And my topic of discussion for today is preoperative optimization in hyperthyroid patients. So, hyperthyroidism is a clinical condition which develops due to the excess production and secretion of the thyroid hormone by the thyroid gland. The common causes are Graves' disease, toxic multinodular goiter, and solitary toxic adenoma. Almost every organ system in our body is involved, but the most serious involvement is that of the cardiovascular system. The treatment options are anti-thyroid drugs, radioiodine ablation, and surgery. So coming to Graves' disease, this is the most common cause of hyperthyroidism. Along with the features of thyrotoxicosis, there is the finding of goiter, eye signs, and dermopathy. In case of clinical uncertainty, we can use technetium per technet scan, then TRAB assay, USG to look for the vascularity, and the treatment offered is via radioiodine ablation, anti-thyroid drugs, and surgery. So, the choice of therapy for the Graves' disease depend on the other comorbid conditions, the presence of any past therapeutic that the patient have received, the patient age, and the other comorbid conditions. So, depending on that, we choose our therapy. In the Western world, the most preferred therapy for the Graves' disease is radioiodine ablation. In our country, anti-thyroid, that is thionamides, is preferred, followed by radioiodine therapy or surgery. So, what is the need of this pre-operative optimization in a patient of Graves' disease? So, the simply answer to this is to prevent the thyroid storm. Now, thyroid storm is a clinical state of hyperthyroidism, where there is the features of hyperthyroidism along with the systemic decompensation signs involving multiple organ systems and involvement, and it should be treated aggressively in an intensive care unit with a proper vital monitoring as well as medicines including hydrocortisone. So, is that true that pre-operative preparation is actually worthy? Though no head-to-head comparison studies till date has been carrying out which shows the benefit of pre-op preparation to those who were not actually prepared with the anti-thyroid drug, but the ATA as well as the ETA, they simply propose that in order to reduce the incidence of thyroid storm and other complications during the surgery, as well as to reduce the length of hospital stay and early discharge of the patients, they recommend that you please do bring the patient to the euthyroid status. Though the surgeons, they actually say that the risk of actually thyroid storm, even after making the patient euthyroid, is almost equivalent in both types of patients. So why a combination of medicines before this? So the combination usually that we use is the thionamides. Most commonly is methimazole, followed by potassium iodide, beta blockers. The others that can be used are the corticosteroids, cholestyramine, lithium, and the second line is therapeutic plasma exchange when other modalities fail. So while using in a combination, what they do in combination is they reduce the synthesis of the thyroid hormone, they decrease the secretion, as well as the peripheral effect of the thyroid hormone is also blocked. And also within a short span of time, they bring the disease under control, and the post-op complication rates are also reduced. So this is the table where the ATA, ETA, and it's a table taken from an article that was published in Curis, and they have said that pre-op what we need to look after is to look after the vocal cord assessment, voice assessment. Then for the pre-op medication, the ATA actually prefers methimazole plus minus beta blocker, whereas the ETA recommends methimazole with beta blockers and glucocorticoid too. The alternative medicines suggested by these are iodine as well as beta blockers, glucocorticoids, cholestyramine. So, and they have proposed that in the pre-op, immediate pre-op also, iodine should be given so that the vascularity of the gland as well as the it will make the gland more firm, and the chances of complication in the form of hypopara as well as nerve palsy is less. The Surgeon Society, they recommend that it should be given for up to 7 to 10 days, whereas the ATA and ETA, they have recommended that it should be given for at least 10 days before the surgery. So what is the indication of surgery? So in those patients who are planning for pregnancy within the 6-month span, in that we can give. Then those who are having large goiter, having the compression symptoms, the uptake of radioiodine where there is low, then also when there is any suspicion of malignancy, a coexisting hyperparathyroid conditions, and with moderate to severe active Graves' orbitopathy. So surgery is not a favorite option in those elderly or fragile patients or those having cardiopulmonary diseases, any end-stage cancer diseases or other debilitating diseases. Also, surgery should not be preferred in those centers where the case load is not that much high. It should always be done by a high volume center surgeons. So the benefits of surgery is actually it's a permanent solution to the disease. Also, we avoid the intake of the thionamides for a long duration and its side effects, and also we avoid the exposure of this radioiodine. But there are certain, so while planning for a surgery, the usual plan is a total thyroidectomy or near total thyroidectomy, and usually what we do is we make the patient euthyroid first by methimazole plus beta blocker. Also, vitamin D and calcium should be taken care of, and in the immediate pre-op period, potassium iodide should be added in the form of either SSKI or Lugol's iodine. Post-operation, levothyroxine needs to be added, and depending on the operative complication, we need to monitor for the calcium phosphate as well as IPTH. The advantage of the surgery is a complete remission, but the disadvantage associated with the surgery is hypoparathyroidism, recurrent laryngeal nerve palsy, and other local complications. So coming to the first molecule, that is thionamides. So propylthiouracil, methimazole, and carmimazole are the 3 molecules known. They block the action of TPO and thus reduces the organification and coupling to the active form of hormones. Methimazole is proposed by both ATA and ETA, but propylthiouracil, there is certain stances where they can be used, and it is the thyroid storm as well as the first trimester of the pregnancy. Before prescribing these medicines, there should be a written, in a written form, the major and minor side effects should be explained, and a baseline evaluation of the liver function test as well as the complete blood count should be done. The usual time to achieve euthyroidism with thionamide is approximately 3 weeks to 8 weeks. So the methimazole, the task force group suggests, depending on the free T4 value, the different doses of this methimazole, but the maintenance dose for this drug is usually 5 to 10 milligram per day. And initially, in the initial phase, when the thyrotoxicosis or the clinical manifestations are severe enough, then we can use a split dosing in the initial days, and then after once daily for the better compliance can be used. For thyroid nodules, the dose required is usually up to 10 milligram per day only. Coming to propylthyracil, in addition to the synthesis part, they also block the peripheral conversion of the T4 to T3, but there is a serious side effect with this molecule, that is hepatotoxicity. The usual starting dose is 50 to 150 milligram TDS, and the maintenance dose is 50 milligram of BD. So these are the major and minor side effects that is associated with these molecules, and the patients on thionamides need to be monitored with the clinical and lab features. The free T4 and T3, if we are in hurry, they should be monitored after 2 weeks to look whether the patient has achieved the euthyroid state or not. Because usually within a span of 3 weeks, they can actually achieve the euthyroid state. And after the euthyroidism is established, we can now reduce the dose to 50%, and further, accordingly, the maintenance dose can be given. Now coming to the second molecule that is preferred is the beta blocker, because hyperthyroidism do have the features that increases sympathetic activity by upregulating the beta receptors as well as sensitizing this beta pathways. So for the symptomatic relief of the patients, beta blockers should be added. Usually we prefer non-selective beta blocker like propranolol, but in those patients where propranolol can't be used, cardioselective molecules can be used, and also injectables esmolol can be used for the patients having atrial fibrillation. So these are the molecules that can be used in the beta blocker category. Now coming to the iodine. So they act rapidly and they are best for the pre-op preparation. The effect starts within 24 hours. They decreases the synthesis as well as inhibits the secretion of the hormone, and the maximum effect is attained by the 10th day of the therapy. Then after, there is escape of this therapy. So it is proposed by the different bodies that on the very 10th day, the operation can be taken. They reduce the flow of the gland, the vascularity, decreases the cytokines, as well as reduces the blood loss during the OT period. So coming next is the corticosteroids. So corticosteroids, it is proposed that by decreasing the synthesis of this TSH receptor antibody, they can actually decrease the drive of synthesis. Also, they decrease the peripheral conversion from T4 to T3, and they also maintain the adrenal reserve. Usually it is prescribed on the day of OT with hydrocortisone 100 milligram and then after 100 milligram TDS, and gradually tapered over the coming days. The other molecule in the steroid category used are dexamethasone and betamethasone. Now, a patient of postmenopausal, in our DM days, a patient came. She was a postmenopausal patient, a known case of Graves' disease, who was on neomarcazole, and she presented with jaundice with the skin rashes and hives. The LFT was deranged, it was of obstructive pattern. We stopped the neomarcazole, but seeing the large size of goiter, now we planned for the OT. To control the hyperthyroid state, we had other options also other than the regular molecule, because iodine is not regularly available. Thionamide was contraindicated, so we had to look for the other molecules that is available to control the state of hyperthyroidism in that patient. So we started in this patient lithium. Lithium, they accumulate actually in the thyroid gland in a concentration that is approximately 3 to 4 times that of the plasma, and they decrease the secretion as well as the release of the hormones. The usual dose is 300 to 450 milligram TDS, and because of the narrow therapeutic window, the plasma level should be monitored after a week interval time, and it should ideally be between the range of 0.5 to 1 milliequivalent per liter. Caution should be taken in those patients who are elderly category as well as in renal failure patients. Then the other options can be cholestyramine. This is a bile acid sequestrant. Since T4 and T3 undergo enterohepatic circulation, so by their mechanism of action, they block this and helps us to reduce the hyperthyroid state. This is the second line therapy, that is therapeutic plasma exchange. When all other modalities of therapy fail, then this can be used. Now for rapid pre-op preparation, what else we can use? So in that cases, we have the options of ipodate with dexamethasone and beta blockers, as well as a combination of dexamethasone with lithium can also be used. And it is seen that it is effective, safe, as well as rapid, with the same rate percentage of complication as compared to the conventional one. So now a patient of Graves' disease, if present with thyroid nodule, what to do? So evaluation will be according to the ATA guidelines, and ultrasound will be done, TRARS scoring will be done, then FNAC, and we can further plan for surgery. But if the patient is in hyperthyroid state, first we make sure that the patient turns into a euthyroid state, and then after we should proceed for the surgery. Now for toxic multinodular goiter and toxic adenoma, the options available are, for toxic multinodular goiter is a total or near total thyroidectomy, and for toxic adenoma it can either be lobectomy or isthmusectomy. So pre-op preparation in cases of toxic multinodular goiter can be done in the same fashion like that of the Graves' disease, with methimazole and beta blockers. A total or near total thyroidectomy can be done, and the surgery should obviously be done by a high volume center surgeon. Definitely in the post-op period, hypothyroidism will be there. So from the very next day, levothyroxine replacement should be done, and we need to monitor the calcium, phosphate, as well as the parathyroid hormone in these patients. For toxic adenoma patients, other than the usual practice, it is very mandatory to go for an ultrasound so that we can pick up any residual nodules, or because if we are planning for lobectomy or isthmusectomy and still there more nodules are there, so it will go in vain. So for that purpose, actually an ultrasound should be done to rule out whether there is any other nodule or not. Again, it should be done in the high volume centers and should be monitored in the same fashion. Now my reference for this was ATA, ETA, the textbook of endocrine, and there was a paper which was published in Curious, so, and other paper also. So with this, hyperthyroidism before OT needs to be prepared to prevent the complication of thyroid storm. Usually thionamides with beta blocker, and in the pre-op period iodine should be used. If thionamides can't be used because of any reason, then either allergy or non-responsiveness, then a combination of other medicines can be used, as we have seen, and we need to monitor the calcium phosphate IPTH in the immediate post-op period, because Graves' patient can either land into hypoparathyroidism because of the OT or into hungry bone syndrome. So based on these biochemical parameters, we can somehow differentiate, and also in those patients who are at high risk of hypopara or hungry bone, an adequate replacement of the calcium as well as vitamin D is suggested. The different bodies have suggested that calcium tablets of 1 gram TDS for up to 3 to 5 days in the pre-op, as well as vitamin D replenishment with 60,000 if needed for consecutive 3 days, can be given to the patients to prevent the post-op complications and thus prepare the patient for the OT purposes. For toxic adenoma, iodine should not be used in the pre-op, as it can exaggerate the features of hyperthyroidism. And with this, I end my session. Thank you.
Well, thank you for your comprehensive talk and keeping to time. Are there any questions from the floor? As you think about a question, maybe we can allow one or two. May I ask you one question? You have talked about thyroid surgery, preparation for thyroidectomy in Graves' patients.
Sir.
But you would be getting more commonly patients of Graves' hyperthyroidism, uncontrolled, having toxicosis, not impending upon storm, but uncontrolled toxicosis, has to have an elective surgery, say cholecystectomy, or an emergency appendicectomy. So how do you go about in these two cases?
Sir, in that cases, what we can offer the patient is the combination of therapy with thionamides along with beta blockers and corticosteroids, because corticosteroids are rapid acting, they will act within hours. So corticosteroids can be
Probably
used.
also iodine.
Yes, sir. Iodine also. Yes, sir.
And for the elective surgery?
For elective surgery, the convention we can follow is with thionamide, beta blockers, and iodine, and then we can prepare the patient for the OT.
So when would you prepare?
Sir, approximately for iodine, they have said that approximately.
No, how would you look? Means for an elective surgery on thyrotoxicosis, on therapy, what would you look at? The T3 is normal, T4 is normal, TSH is suppressed. The anesthetist says we won't do surgery. So what?
Sir, the TSH can be remain suppressed for long days or weeks, but by monitoring the free T4 value as well as the total T3, the operation can be done.
If they are acceptable within limits, you
Yes,
can
sir.
go for
Yes,
an
sir.
elective surgery.
Yes, sir.
And for emergency surgery, you have to, because the surgery may be life-saving, you cannot say that we will control the thyrotoxic state
Exactly, sir.
and then we'll subject to surgery. You have to go for maybe high dose of thionamides, maybe glucocorticoids and iodine. Be cautious that the patient may land up into some sort of surgical storm and manage accordingly, but rather prevention of a storm would be more advisable than treating it.
Yes, sir. No, it means the therapy can't be, the operation can't be denied only because the hyperthyroid state is not controlled. Because since till the recent studies, there is no head-to-head study where they have seen that by doing or making a patient to the euthyroid, it's actually doing far, far better than those who are not prepared. In both categories, they have seen that either of them can land into thyroid storm. So definitely, if surgery on an urgent or immediate basis is required, we should offer the patient surgery.
Okay, thank you. Any questions? If not, thank you, Dr. Shopnil, and I also thank my co-chairperson.
Thank you, sir. Thank you, sir.
So now, may I now request our chairperson for the next session, Dr. Arindam Chatterjee, to join us in the podium, and may I request Dr. Shayantan Roy, faculty in endocrinology from AIMS Bhubaneswar, to take the podium and enlighten us through the perioperative care of a patient after pituitary surgery. You can be here.
Thank you, sir, for the kind introduction, and good afternoon to all of you. This topic may not be very familiar to many of us, so I shall try to focus on mainly the water balance disorders and the steroid management in a patient after pituitary surgery. So, as we know that, may I get the presenter mode? Yeah, thank you. So, as we all know that the arginine vasopressin, which comes from posterior pituitary, the major stimulus is increased serum osmolality or decreased serum volume. And the outcome of the stimulation is increased free water reabsorption via the collecting duct aquaporins with reduced serum osmolality and increased serum volume. So, the normal result of ADH stimulation is reduced urine volume and increased urine osmolality and the corresponding increase in blood volume and decrease in serum osmolality. So, this basic physiology and the pathophysiological alterations will help us to understand the water disorders. Now, these are the key post-operative complications one patient who underwent pituitary surgery may present with. And on the right panel, the onset of these complications are mentioned. So that helps us to identify what problem the patient may present with during the post-operative phase. Now, post-operative diabetes insipidus is a central diabetes insipidus, that is because of loss of posterior pituitary vasopressin or ADH production. So, I will come in the detailed criteria. let us spend some time with this pathophysiology of post-operative DI. What happens? This classical triphasic response happens because in the immediate post-operative period, that is within 24 to 48 hours, the AVP deficiency develops due to partial or complete pituitary stalk section. That is the connection between the AVP neuronal bodies in the hypothalamic neurons and the nerve terminals in the posterior pituitary. So this prevents the stimulated AVP secretions. So that is why there is early diabetes insipidus. Then what happens? In next 7 days, after a week, there is a delayed SIAD-like picture that follows the early AVP deficiency. Why? Because of the uncontrolled release of the stored AVP by the degenerating nerve terminals in the posterior pituitary. Now, after this, further episode of AVP deficiency may develop that can occur because of that stored AVP in the posterior pituitary has already been released. Now, if greater than 80 to 90% of AVP neuronal bodies are destroyed, then they undergo a retrograde degeneration. Therefore, because of this retrograde degeneration, now there is no AVP. So, this will lead to a permanent diabetes insipidus. But on the lower panel, you may see that patient may also present with isolated hyponatremia, that is directly to the SIAD phase, not following this triphasic pattern. So these are the criteria we usually follow for diagnosis of early AVP deficiency, that is acute diabetes insipidus after pituitary surgery. That is relatively common. We see in our day-to-day practice the referrals from the neurosurgery department. So these are the criteria for polyuria. Now, if patient is not catheterized, you may take this more than 800 ml over 4 hours. Now, one important point is that this acute neurosurgical central diabetes insipidus may co-represent with also the anterior pituitary hormone deficiency. So if there is cortisol deficiency, then free water excretion will be impaired and polyuria may not develop. So it may mask the DI. And you can look at these other causes of polyuria. That is also very important. We have to notice that whether the patient received fluid during the intraoperative period, whether there is hyperglycemia, patient received any diuretic therapy, or after surgery for acromegaly patients, when there is rapid decrease in growth hormone, that they may present with polyuria. So the clinical algorithm is we have to monitor the fluid balance and urine specific gravity. The confirmatory tests are serum osmolality more than 300, serum sodium more than 145. Patient may have excessive thirst and the response to desmopressin. So the key managements are initially we have to give a free water access with IV fluids if required. If not controllable, then add desmopressin, monitor fluid balance 3 to 4 hourly and recheck at every third day interval. So regarding the clinical algorithm, we may have two situations. One is conscious patient having a thirst intact, and one is inadequate perception of thirst or having altered consciousness. So depending on the situations, our management approach shall vary. So we have the options of desmopressin in oral and intranasal form. We don't have the parenteral form available. It is easy for administration because after the posterior pituitary surgery, usually the patients have some nasal pact. We cannot give intranasal desmopressin. And usually the maximum dose of desmopressin, what we have seen in postoperative patients, that rarely exceeds the requirement of 200 microgram daily. So oral preparations have two forms. One is standard tablet and another is a sublingual preparations. And after IV dose, when it is, if it is available, usually after 1 microgram, we get the peak antidiuretic response within 12 hours. And here is the potency equivalence given, that is 1 microgram of parenteral desmopressin is equivalent to 10 microgram of intranasal, which is equivalent to 100 microgram of oral and 60 microgram of sublingual preparation. That is Menerin melt. So this desmopressin is, if not available, we can give aqueous vasopressin 5 units subcut every 6 hourly. Desmopressin is long acting and don't have the pressure effect, that is the advantage. So here I have put the stepwise approach of management of postoperative DI with the oral, intranasal and sublingual and subcutaneous doses are mentioned here. So transition to scheduled DI therapy, if it is persistent DI, then it requires a regular dosing. So you cannot give when required. We have to give a regular dosing of desmopressin in that situation. Now coming to permanent DI, that is, these are the risk factors when patients can go to permanent AVP deficiency. And if there is permanent AVP deficiency when the proximal section is above the median eminence, so if the patient develops within 24 to 40 hours post-operatively, then they have a chance of permanent DI. Usually in early post-operative period, we give desmopressin on demand basis, via usually given as a subcut or IV injection, 1 or 2 microgram. That suppresses diuresis within 30 minutes and it lasts for 8 to 12 hours. Usually the postoperative DI is transient, requires 1 to 2 doses, and if it is going for a permanent DI, patient should be managed with oral formulations and educated on the treatment of AVP deficiency and symptoms of hyponatremia, which is the commonest complications of desmopressin therapy. And what we can advise patient, they can escape 1 dose or delay 1 dose, that will lead to some escape diuresis. This is the important education we have to give patients, that drink to thirst, avoid excess fluid and recognize hyponatremia symptoms. Now, adipsic AVP deficiency is probably the most dangerous situation when there is presence of DI without thirst because of some hypothalamic injury, usually we see in post-craniopharyngioma surgery. Here, the scheduled fluid intake is the most important advice, should be the most important advice. Coming to SIAD, the second part, the criteria, we are mostly familiar with this criteria. There is excessive ADH release leading to water retention, leading to hyponatremia and hypoosmolality. Now, the basic difference between DI and SIADH is high urine output. In SIAD, urine output is usually low or normal. And DI patients usually presents with excessive thirst. Here the thirst will be absent or a minimal. And we can differentiate with serum sodium. The important, if the facilities available, we can go for a paired plasma and urine osmolality as well. Now, sometimes what happens if there is DI along with cerebral salt wasting? Sometimes the transcranial approach of pituitary surgery is done and patient may present with cerebral salt wasting. In that situation, the problem is both of them present with increased urine output. But we may differentiate with urine sodium level. In cerebral salt wasting, urine sodium will be sky high. And also they present with hyponatremia, but DI, they may usually have a hypernatremia. So timing and clinical patterns, usually SIAD develops 5 to 8 days after surgery. May present with isolated hyponatremia or a triphasic response. Management is according to the degree of hyponatremia. If mild hyponatremia, mostly the fluid restriction, but for severe hyponatremia with symptoms, usually we treat with hypertonic saline or Vaptans. Now coming to the third part, that is perioperative cortisol deficiency. That is secondary adrenal insufficiency post-pituitary surgery that requires a careful management. Depending on the preoperative status, that is whether the patient is having a normal HP axis or is already known adrenal insufficiency or uncertain sometimes, but at risk. According to that, the perioperative and postoperative glucocorticoid management will depend. Key principle is that inadequate cortisol treatment, what I have already said, can mask DI and cause hemodynamic instability. And complications of under replacement and over replacements, both will be there. So this is a glucocorticoid replacement algorithm. There may be preoperative adrenal insufficiency or preoperative adrenal insufficiency present or absent. So on the day of surgery, we give hydrocortisone 50 to 100 milligram and then 50 milligram every 8 hours. Then on day 1, it is reduced to 20 to 25 milligram every 8 hours. And on day 2, we give only the morning dose and send a plasma cortisol concentration at 8 am. Depending on the cortisol concentration, if it is less than 10 microgram per dl, we continue with hydrocortisone 15 to 20 milligram or an equivalent dose of prednisolone. If cortisol is more than 18 milligram, no further steroid is required. If it is more than 10 but less than 18, usually we continue or give advice for only the stress management, and we re-evaluate the HP axis at 16 to 12 weeks after surgery. One important thing is we should also assess the thyroid axis, and if low free T4 is there, treat only after HP axis assessment and correction of cortisol deficiency. So if there is no preoperative adrenal insufficiency, on the day of surgery, what I have mentioned already, and then on day 3, measure a serum cortisol. Depending on the cortisol level, we can plan our glucocorticoid dose and the re-evaluation schedule. So cortisol monitoring and hormone replacement on post of day 3, 8 am cortisol, we actually want to assess the immediate adrenal insufficiency. And we take this cutoff of 10 microgram. If it is below that, we initiate hydrocortisone. At week 6, we assess HP axis recovery with a ACTH stimulation test. And we continued glucocorticoid if required. At week 12, we confirm resolution of secondary AI. And then we plan a taper or discontinuation of glucocorticoid. And at 3 months, to 12 months, that is 1 year, that is the annual reassessment. For long-term HP axis assessment, we adjust the replacement as needed. So the bottom line is, do not discharge the patient without assessment of HP axis function, and patient may develop adrenal insufficiency even with a normal immediate post-op cortisol. So this is the glucocorticoid tapering strategy. According to the timeline, depending on the cortisol level, we actually plan a glucocorticoid replacement dose and plan for the next management level. So coming to the long-term follow-up schedule, in first week, we need repeat lab test for the electrolyte imbalance. We need osmolality. Imaging here is optional. Neurosurgery will check the wound. Then at week 6, we assess HP axis along with thyroid axis, also the other pituitary axis, and also do imaging to know the visual deficit, if any, do the clinical checkup. Then at week 12, if not previously done, we go for a baseline MRI post-op and a full pituitary profile along with clinical assessment. At 3 months and 3 to 6 months and 12 months, we check MRI for any residual or recurrent tumor. And after 1 year, it is usually a yearly assessment with annual MRI every 3 to 5 years with an annual clinical follow-up. So the discharge recommendations should be for fluid management, drink to thirst if the patient is conscious, avoid restricted fluids, monitor urine output. For DI symptom awareness, patient should be educated about excessive urine output, inappropriate thirst, and especially nocturia. Medication compliance should be there. And from adrenal insufficiency, patient should be educated about the symptoms. From surgical point of view, the CSF leak warning signs, patient should be aware of that. So these are the key diagnostic criteria which I have already discussed for diabetes insipidus, SIAD, and adrenal insufficiency. So these are the, in summary, of the treatment algorithm for mild DI or a symptomatic DI, mild SIAD or a severe SIAD, and a cortisol deficiency, as well as CSF leak from clinical surgical point of view. These are the red flags which actually alerts us when to escalate the care. And the key takeaway from today's presentation is, monitor fluid balance and osmolality closely in the first post-operative week. That is very important. Diabetes insipidus presents with polyuria, hypernatremia. On the other hand, SIAD presents with hyponatremia and oliguria. Adequate cortisol replacement is essential. CSF leak is rare but serious. That patient should watch for rhinorrhea and meningitis signs. Patient education on stress dosing, hormone compliance, and red flags are very critical. Long-term follow-up is essential for this patient. 50% of diabetes insipidus may resolve. Some develop persistent hypopituitarism. So to conclude, post-operative DI, SIDH, and adrenal insufficiency, key to successful management is early recognition, appropriate monitoring, patient education, and long-term follow-up. Thank you.
Thank you for your excellent talk, and the floor is open for any question if is there. Any question? So from my end, one or two. So what are the clinical suspicion? How we can assess that one or 2 points? What are the things that is going wrong here after post pituitary surgery?
Usually after pituitary surgery, we actually receive mostly the refers from neurosurgery department that patient is having increased urine output. So during that time, we monitor the urine output. If it is more than 250 to 300 ml for the consecutive 3 to 4 hours, then we look for the sodium. But if patient is drinking adequately, sodium may not rise. Then if the urine output criteria is fulfilling, then if patient is within the first week of surgery, then most probably it is early AVP deficiency. It usually requires 1 to 2 doses of desmopressin or vasopressin. It usually resolves. And now if we are seeing the patient is after a week of surgery, and usually they at that time presents with hyponatremia mostly. That period is for SIADH presentation. And after this period of hyponatremia, they usually may present with a permanent DI, or they may resolve this triphasic response. They may go to triphasic response or only isolated hyponatremia. Sometimes the confusion happens when patients may have cerebral salt wasting. Then we need to differentiate because it's a hypovolumic condition. The management will be different as compared to SIAD. And sometimes patients present with polyuria that may be due to cerebral salt wasting. At that time, maybe serum sodium and urine sodium may help us to differentiate between that. And currently, if available, can go for fractionate urate excretion to differentiate between SIAD, reset osmostat and DI. That we can use, fractional urate excretion. But it's not always available actually.
Thank you for an excellent discussion. Just to remind the audience, just as diabetes insipidus or AVP deficiency after a neurosurgery can be both transient and permanent, similarly glucocorticoid deficiency can be transient and permanent, because many a time we find that the patient has been put on glucocorticoids, hydrocortisone, and without testing of the axis, the patient keeps on taking it for years on end. So, as you have pointed out, at one point of time after the initial recovery, the axis has to be tested, maybe on repeated occasions, to ensure that it has recovered or not recovered. If it has not recovered, then of course the question of long-term indefinite glucocorticoid replacement would be there, but if the axis has recovered, then we can stop the glucocorticoid replacement too. So I thank both the speakers and both my chairpersons for conducting the session exceedingly well, and I declare this session closed and hand over the mic session to the organizing team for going through to the next session.
Thank you, sir. I would request our esteemed faculty members to be on stage for a group photograph. And I would request our sir, Dr. Piyush Ranjan sir, to felicitate our faculty. Kumar Shamnil sir, please join them on the stage. So I would request sir to please felicitate our faculties. The true burden, the future of medicine lies in breaking down specialty boundaries. Today's cardio-nephro-endocrine panel exemplifies that spirit, bringing together leading experts to discuss the science, challenges, and the future of integrated patient care. We now move to a multidisciplinary cardio-nephro-endo panel discussion. The panel features Dr. Satyendranath Datta sir, Dr. Rahul Kanjilal sir, and Dr. Neha Agarwal ma'am. The session is moderated by Dr. Robiranjan Shaumondal sir, consultant nephrologist and transplant physician at Mission Hospital. So I'd hand over the mic to sir to moderate the session.
So, very good afternoon, everybody. At the outset, I, on behalf of my team, wants to say thanks to this organizing committee for giving this precious 20 minutes time. You please come on. For a patient-based discussion where the treatment what we prescribe to a patient who is suffering from diabetes and its different complications, this treatment nowadays binds no boundaries. So we have to dissect a case, and in next 20 minutes we have with us eminent clinicians from Durgapur. All of them are from Health World Hospital. Dr. Neha from endocrine point of view, Dr. Satyen from cardiac point of view, and Dr. Rahul from nephrology point of view. So without wasting much time, let us go ahead with this case. So this is a patient, Mr. RK, 59 years old male, who had presented to us with progressive exertional dyspnea for last 3 months, bilateral pedal edema, poor glycemic control, and increased fatigue. If we look into the past history, he is suffering from diabetes for last 14 years, hypertensive for 12 years, having dyslipidemia, suffered a myocardial infarction around 3 years back, underwent PCI with drug-eluting stent. He is also having chronic kidney disease, which was diagnosed 2 years back. He is obese. His current medications remain metformin, glimepiride 2 mg, telmisartan 40 mg, amlodipine 5, rosuvastatin 20 mg, aspirin 75, and clopidogrel 75. While examining, we found that he is obese with BMI of 32, waist circumference 108 centimeter, blood pressure remained 146 by 86, pulse 78 per minute, mild bilateral pedal edema, basal lung crepitus were there, and there was no foot ulcer. Going through the lab values, HbA1c is high, 8.6%, fasting 172, postprandial 258, creatinine 1.8, GFR calculated 46 ml per minute per 1.73 meter square. Urinary albumin excretion is 380 milligram per gram, potassium 4.7, LDL cholesterol 78, triglyceride 210, and NT-proBNP remain elevated. ECG had features suggestive of old anterior wall myocardial infarction changes, and echocardiography with 45% ejection fraction with grade 2 diastolic dysfunction and mild hypertrophy. So we have to manage this case from all aspects, from cardiac point of view, from renal and metabolic point of view. So what we have this, this patient is having cardiovascular morbidities with history of myocardial infarction, suffering from heart failure with moderately reduced ejection fraction. From renal point of view, he is suffering from chronic kidney disease with elevated creatinine, low GFR, and increased urinary albumin excretion. From metabolic point of view, he is having HbA1c of 8.6%, which is sky high, and he is obese. So, in the snapshot, so the clinical challenges remained are poor glycemic control, established cardiovascular diseases, CKD with albuminuria, heart failure with moderately reduced ejection fraction, obesity, polypharmacy. It's a significant issue for this patient, and need to reduce the future cardiovascular and renal events and progression towards ESRD. So my first question to Dr. Neha would be, for this patient, how these oral hypoglycemic agents should be individualized considering his history of obesity, chronic kidney disease, and heart failure.
First of all, thank you for putting up the excellent academic case, which comprehensively is about cardiometabolic and renal syndrome, CKM syndrome, which we commonly say these days. So in this case scenario, as we have learned that the patient is having uncontrolled diabetes with established ASCVD, with heart failure and with CKD. And the patient, if you go at the treatment, what the patient is receiving is, patient is on metformin and glimepiride as the anti-diabetic agent. And despite on that, the patient is having uncontrolled diabetes. So looking at the like CKM syndrome which the patient is having, I would suggest to add agents which would provide cardiometabolic protection, which would help in weight reduction, which would provide cardiorenal protection, as well as it will reduce the number of CV events in future. This is the first point. Second, we should choose those agents which will help in weight reduction, and these other agents should be given in such case scenario irrespective of the A1C value. But when we add this agent, it will definitely give anti-hyperglycemic efficacy too. So I would suggest to add SGLT2 inhibitor first, because these agents will reduce the heart failure as well as it will prevent the CKD progression, it will reduce albuminuria. And again, considering the patient is at CKD stage 3A, I would continue metformin as the patient EGFR is 46. As per the EGFR cutoff, we can continue metformin 1000 mg per day at this stage, and we'll try to stop glimepiride in future if we find that with the addition of SGLT2 inhibitor, the patient's glucose profile is improving. And second agent, if the cost permits, I would like to add GLP-1, because that will give added benefit of both ASCVD in terms of reducing ASCVD events, MACE reduction, as well as weight reduction.
So,
Thank you.
Rightly pointed out, so we should not target the HbA1c only. Nowadays, the treatment is being shifted more towards organ protection rather than focusing only on HbA1c. So my second question will be to Dr. Satyen. How should diabetic therapy be integrated into secondary prevention after a patient who had suffered myocardial infarction in past?
Thank you, Ravi, for such a wonderful case. First of all, as per NEA, we should start SGLT2 inhibitor. It will not only be beneficial for the patient to reduce HbA1c or some degree of hyperglycemia, but it is nowadays a pillar of therapy for patients with myocardial infarction, especially with heart failure features, and reducing the body weight and hyperglycemia with GLP-1 analogs GLP-1 receptor agonist will definitely reduce the atherosclerotic burden in the patient. And we will target which are not in the range, not in the guideline-based target like LDL, blood pressure, weight. These things should be addressed as a part of continuum of therapy, not a single thing should be addressed individually. And using all these combination of drugs, we can reduce the overall chances of major cardiovascular events in the future, heart failure, hospitalization, and progression of CKD in this patient. The mainstay at this stage
looking like treating the patient for overload. He is in overload as per the clinical scenario, and reducing the glycemic burden as well as reducing the metabolic, modifying the metabolic parameters that are haywire right now. He doesn't have anything in control. His LDL is high, his BP is high, his weight is above the target range, his creatinine is also high. So these medicines, and we'll discuss further how we should go forward with reduction in LDL, BP, and other parameters in next discussion.
So till date, the most of the evidence in favor of cardiovascular events protection are going towards SGLT2 inhibitors and GLP-1 receptor agonists as far as the oral hypoglycemics are concerned. So the next question will be to our nephrologist, Dr. Rahul. How should this diabetic kidney disease be managed in patients with persistent macroalbuminuria, in spite of having probably the highest dose of telmisartan or other ARBs?
Thank you, Ravi. Thank you, Bengal Diabetes Forum. This is my first appearance at BDCON. A wonderful hospitality. Thank you, organizers. I think we both will agree, half of the question we never reach. I mean, how many of our patients can we actually take them to the maximum or the recommended dose of ARB? You see, losartan is 100 mg, telmisartan is at least 80 mg, you may go up to 120 mg. Most of our patients, we are not able to get to that level, not because of low blood pressure, but because of the hyperkalemia and all. So, said that, recently, I think, maybe a decade before, there was nothing other than ARBs and AC inhibitors. In this last decade, we have seen mainly 3 drugs. One is, as ma'am said, SGL2 inhibitors, GLP-1 receptor agonist, and there is another Finrinon, which is a non-steroidal MRA. So these 4 drugs is all we have. See, always remember, whenever we nephrologists, we try to save our kidney, somehow you have to do one thing, that is you have to reduce the intraglomerular pressure. Now this ACE inhibitor ARBs does the same thing. It dilates your afferent arteriole and hence reduces the intraglomerular pressure. SGLT2 inhibitors, they constrict your afferent arteriole and hence reduce the intraglomerular pressure and hence increases the kidney prognosis. Said that, if you see all the trials of these all 3 molecules, that is GLP-1 receptor, Finrinon and SGLT2 inhibitors, they always used to include patients and they used to write a sentence on maximally tolerated ACE inhibitor ARB. Most of the time, we don't do this. So this is first thing that I always emphasize wherever I go. First, increase the dose of ARB to the maximum tolerated dose, then introduce other drugs. Okay, just for the kidney protection I am saying. Now, SGL2 inhibitors is like, for diabetes we take care karega, heart failure we take care karega. Now, once you reach that dose, then you introduce SGL2 inhibitors or GLP-1 or Finrinon. In that order, little bit differences, like if they are cardiac patients, heart failure patients, you go for SGL2 inhibitors. If they are atherosclerotic cardiovascular disease patients, then you go for either GLP or SGL2 inhibitors. But another important thing, GLP-1 receptor agonist, I think, in the part of the state where we stay, you should always assess whether this patient will actually take this molecule or not. Because hota kya hai, you prescribe the drug and the patient is somewhere, suppose most of our patients are coming from periphery. So they don't take the drug which you have prescribed and they stop taking the earlier drugs also, and finally they land up in severe hyperglycemia. So,
you have rightly pointed out that most of the time we often fail to up titrate the dose of the ARBs. So first priority is up titrate them to the maximum tolerable dose and then add on drugs which can help to prevent proteinuria so that the further progression towards kidney end stage renal disease doesn't occur. So we don't have much time, so we'll be faster this time. Next question again to Dr. Neha. Would you prioritize GLP-1 receptor agonists or an SGLT2 inhibitors or both? And what are the evidences in favor of your answer?
I would say here that these days we again talk about the parallel therapy and not the sequential therapy. So whenever we see a patient with high risk of CKD, ASCVD, so in those situations it's better to start both the drugs simultaneously until or unless there is some contraindication or if there is some economic issues. But if possible, then start both the drugs together because their actions are complementary, and even the evidence shows that if you give both the drugs simultaneously, you will get better glycemic control and you will have better cardiorenal protection in terms of different events like SGLT2 inhibitor. As we discussed, it mainly reduces heart failure events, reduces CKD progression, but GLP-1 receptor, they mainly reduces MACE, they reduces ASCVD events. The data regarding the renal outcome is awaited. So we should use the drugs simultaneously and not like one by one. Yes, you can go one by one. If you want to prioritize, then one agent which we should add at the very first step would always be an SGLT2 inhibitor, especially in this case scenario, because most of the type 2 diabetic patients, they die of heart failure, then they die of CKD, and then comes the ASCVD events. So if you prioritize in terms of complications, then SGLT2 inhibitors would come as the first choice of the drug. Yeah, thank you.
So rightly pointed out. The next questions to Dr. Satyen is, should heart failure management be intensified despite only mild reduced ejection fraction in this patient?
Absolutely, we should not be misguided by the ejection fraction here. We can see the patient have features of volume overload with clinical evidence of edema, crepes and everything, and we have laboratory evidence of a raised anti-proBNP. So we should go for to treat the volume overload first, to decongest the patient with loop diuretics to achieve euvolemia. Then we should start their long-term therapies for mortality benefits. Evidence-based SGLT2 inhibitor is a class 1 indication in patients with heart failure, even if the ejection fraction is more than 40%. Others like RAS and beta blockers, these are more effective in the lower range of ejection fraction. Below 40, they are class 1 indication as of for now. But in the lower range of mid-range ejection fraction, patients like 40, 41, 42, lower the ranges of ejection fraction, more effective the RAS or ARNIs and beta blockers are. So, because we have to reach a reasonable blood pressure goal also, we can add them with a dual benefit of reducing the blood pressure as well as getting the mortality benefit from heart failure patients. And lastly, mineralocorticoid receptor antagonists are also can be used in this patient, keeping in mind that we should keep a watch on the potassium levels of the patient.
So we should not forget about the decongestion measures and of course the beta blockers, which has probably the highest evidence to reduce the recurrent hospitalization due to heart failure in chronic cases. So my next question will be to Dr. Rahul. Would you consider adding a non-steroidal MRA such as finrenone, and in whom and how you monitor the potassium level?
See, this patient is a candidate of finrenone, that's for sure. But the point is that, is he on maximum tolerated ACE inhibitor ARB? No, he is not. He is on telmisartan 40 mg and amlodipine 5. So first you increase the dose of telmisartan. If the potassium allows, then you go on to add finrenone, maybe at a lower dose 10. Now, as far as the potassium goes, be very vigilant about this potassium. This potassium has lot of problems. We always say to the patient that potassium ज़्यादा नहीं खाना है, low potassium diet, but we tend to forget. Now, अभी जो चल रहा है ना मार्केट में, वो है रॉक सॉल्ट, सौंदोक नून. So each and every patient, probably I'm sure around 30% of the people in our conference might be having this Sondok noon. So you see, salt is salty because of chloride. So chloride is an anion. So it has to have a cation. If it is not sodium, it will be potassium. So now coming back to the question, for this patient, I'll first try to increase the dose of ARB. After that, if my potassium is less than 5, I start Finrinon 10. I monitor the potassium after 2 to 4 weeks. If the potassium goes above 5.5, I stop it. If it is less than 4.8, I increase it to 20. Then again keep monitoring the potassium.
So, out of the track question, how many % of patients who are on Finrinon, from your clinical perspective, are actually having hyperkalemia?
I will say genuine hyperkalemia, not that home collection se ho gaya to cell lysis ho gaya to potassium बढ़ गया and all. Genuine hyperkalemia, Finrinon 10 mg, I will say around 30%.
Okay.
And discontinuation rate, one more important one, discontinuation rate. Discontinuation rate is less than 10%, even less than 5%.
Okay. So I have a experience of, it's probably higher, around 50% of those cases, and I had to stop patients on Finrinon because of hyperkalemia. It will be around 20% of the patients whom I put on Finrinon. So next question to Dr. Neha would be, at what stage would you discontinue sulfonylurea and reduce metformin?
So as per this case, the EGFR was 46. So as per the recommendations, we can continue metformin above 30 EGFR, but we need dose modification in between 30 to 45. If the EGFR is between 30 to 45, the maximum recommended dose is 1000 per day. And if it is above 45, then you can continue with the full doses up to 2 gram per day. Regarding sulfonylurea, depending upon the risk of hypoglycemia, and they are more in CKD, CLD patients, so it's better to avoid the long-acting sulfonylureas like glimepiride, because if once the episode of hypoglycemia happens, then it can be recurrent up to 2 to 3 days, and sometimes in clinical practice we have seen up to 5 days also. So it's better to avoid long-acting sulfonylureas. You can shift to relatively short-acting, that is the glyclazide, and in specific in that group also don't go for long-acting glyclazide, because that will again act as a long-acting sulfonylureas also. So, and especially, and again in this case, it's better to reduce glimepiride gradually, because the patient's A1C is uncontrolled. So, if you stop abruptly, then you won't be able to achieve the good glycemic control only with the SGLT2 inhibitor. So once you add SGLT2 inhibitor, you taper it down, and then when you plan to add GLP, then further taper it down to avoid the episodes of hypoglycemia. But keeping in mind that it should not cause rebound hypoglycemia. If that happens, then you have to continue the sulfonylurea. So it's never like that you have to stop it completely. It depends upon the patient's glycemic profile. You decide whether to continue or whether to stop. The aim is to maintain normoglycemia and to avoid hypoglycemia.
Okay, in those situations, I would like to prefer glimepiride also if the patient's hyperglycemia is not being controlled, rather than putting him on other agents. If the glycemia control is concerned, I'll prefer to continue with glimepiride because these are very cheap drugs.
Yes,
so
definitely.
This is better to continue.
So if the EGFR permits, like up to 30 or maybe up to 45, you can definitely continue with glimepiride. But once the EGFR starts falling around 30 or in between 35, it's better to switch to glyclazide. That is what I prefer in order to avoid hypoglycemia.
What about metformin?
Metformin, I just said, if the EGFR is less than 30, you should stop. And if the patient has AKI, sepsis, or in any acute condition.
Other than those acute situations, how many of your patients, in your experience, you have encountered lactic acidosis?
I think none. If
so
none. About 30, we continue metformin.
This is the situation, because lactic acidosis is very, very, very rare condition. It rarely happens. So even if the patient belongs to a very needy situations, we can continue with metformin to a GFR, maybe around 25 or 20 also. It's not the guideline based therapy. In my experience, I have used them without any significant effects on their renal function also. So the main concern remains lactic acidosis, which is very, very, very rare. Of course, we have to stop it in acute situations. So it's not being displayed. So the next question to Dr. Satyen would be, what cardiovascular benefits of SGLT2 inhibitors and GLP-1 receptor agonists influence your therapeutic choices?
This has been already been discussed. SGLT2 inhibitors specifically is indicated in patients with symptoms of heart failure. The ejection fraction doesn't matter. The patient is either diabetic or not, doesn't matter. SGLT2 inhibitors are the independent entity in treatment of heart failures. In atherosclerotic cardiovascular disease, GLP-1 receptor antagonist have more evidences compared to SGLT2 inhibitors, but all the effects on cardiovascular system and heart failure milieu, both these drugs effects are overlapping, and when used together, these drugs can have an additive effect rather than on top of their individual effects on the therapy. As an example, I can say if GLP-1 receptor agonists are used in a patient with an ejection fraction of 40% with heart failure with previous stentings, if his body weight reduces, his HbA1c is under control, his atherosclerotic milieu is reduced, and his chances of worsening LVEF reduces, and future events of heart failure also reduces with use of SGLT2 inhibitor. And SGLT2 inhibitor has clear evidence-based marked reduction in heart failure hospitalization, heart failure death, and worsening heart failure, along with CKD benefits and weight reduction also. So both these drugs have an overlapping effect on this atherosclerotic cardiovascular disease along with heart failure symptoms.
And now the question goes to Dr. Rahul. How should EGFR influence selection and dosing of your anti-diabetic medications? Probably this will overlap the previous question.
So this has already been discussed. The major class of drug which we were discussing about, sulfonylurea and metformin. So metformin, as Dr. Neha said, below 30 we usually discontinue or reduce the dose, and Rabi is very correct that we have never seen lactic acidosis. That is also correct, but the point is, suppose a patient develops lactic acidosis, then you will be charged. So there's the problem. Glimepiride, even glimepiride is being, even if you go through up to date and all, they are saying that glimepiride can be given even at a GFR of less than 30. But everyone here must have seen one patient on glimepiride with CKD who has come with hypoglycemia. So glimepiride as such, you're very correct, it's cheap, easily available and works very good. But the only problem is that we nephrologists are more afraid of hypoglycemia than hyperglycemia. So therefore we tend to avoid this glimepiride. Okay.
So next question goes to Dr. Neha. Apart from the glycemic control, which metabolic targets should be aggressively addressed to reduce the long-term complications?
Yeah, I think we have almost discussed the other cardio and this renal and metabolic parameters. So for all diabetic patients, we should go for ACR, we should go for creatinine. Other parameters like blood pressure reduction, management of lipids, target LDL to below 70 or below 55 if the ASCVD events are there, and go for like 5 to 10% of weight reduction. That will help in reducing insulin resistance and thus will improve the overall metabolic profile. So these are the things we should think beyond A1C.
And we should not forget about the blood pressure.
Yeah,
that's
blood pressure
one of the most important thing to prevent further progression. So Dr. Satyen, would you modify his current antiplatelet, antihypertensive or lipid lowering therapies according to the current guidelines?
Well, according to the current guidelines, we have to continue dual antiplatelets for at least 1 year. This patient is having high risk of thrombotic events, so we can continue with dual antiplatelet, aspirin and clopidogrel if the bleeding risk is low. There are studies like DAPT trial and others which showed that longer the DAPT is continued, the chances of reinfection and restenosis are less. But we have to keep in mind whether the patient is having high risk of bleeding or not, or other events of bleeding in the past or not. First of all, we can just switch to single P2Y12 like clopidogrel, or keep on with aspirin and clopidogrel. But other drugs we need to adjust, like he is on rosuvastatin 20, which need to be uptitrated to at least 40 milligrams. If the target LDL, which is less than 55, if we can't achieve it with rosuvastatin 40, we have to add other drugs like ezetimibe or bempedoic acid. Even with that, if we can't reach the goal, we can add PCSK9 inhibitors. So lowering the LDL is very important. Next, by hypertension, he is on amlodipine, telmisartan. We need to add he is on beta blocker also, I don't remember.
No.
If he is not on beta blocker, we have to add beta blocker. It has a clear mortality benefit on atherosclerotic cardiovascular disease. We need to uptitrate the ARB. And if we at all need to use a calcium channel blocker, we should avoid amlodipine because it causes some degree of fluid retention as well as tachycardia. So we can go to cilnidipine or other calcium channel blockers. These are the main modifications from my part, apart from adding SGLT2 inhibitors for heart failure benefits, adding GLP-1 receptor agonist for weight reduction and glycemic control, and phenidone if at all permitted in this patient for optimizing the therapy of this patient. And we need to exclude whether the patient is having any acute coronary event at this moment or not.
So this is probably the last questions. We have many of questions remaining, but time will not probably permit. So the next question to Dr. Rahul: which biomarkers or investigations should be followed to monitor the progression of chronic kidney disease and determine the timing of referral for advanced kidney care?
Okay, so this should be the first question. So you have just two things. One is creatinine and the other is your ACR. These are the two things you only need in a diabetes patient from kidney point of view. Widely available. Yes, you can in addition order the EGFR, which usually the lab people charges the patient, but you can even calculate it. Now as far as the referral goes, referral is something by criteria. If you see, by criteria it is somewhere around, let's say GFR less than 60, ACR more than 300, there is a rapid decline in the GFR, or you think that there is something other than diabetic kidney disease or complications of CKD. So these are the few referral criteria, but as such, every diabetic patient who has a kidney dysfunction should be at least evaluated once to rule out any possibility of non-diabetic kidney disease. This is the main point that I usually would like to highlight.
So thank you for the excellent and insightful thoughts from all the panelists. If there are any questions, I'll for foot ulcer?
Some gangrene is going to happen. Now, in that
Ensuing gangrene. Also,
yes.
This patient is probably having peripheral arterial disease.
Yes, he is having peripheral arterial disease. So, in that case, we are going to stop the LCLT inhibitor.
Dr. Neha?
Sir, actually in Canvas trial, it was seen that giving canagliflozin can precipitate or can cause gangrene. But in the further CVOT trials, no relation was found between the gangrene or between SGLT2 inhibitor. But if the patient is having sepsis because of the gangrene, or if because you are planning for some surgery for the gangrene like amputation, in those situations as a part of perioperative, in order to avoid complications due to SGLT2 inhibitors like euglycemic decay, in those scenarios only you need to hold the SGLT2 inhibitor, but not for isolated, just blackening of the skin would leads to, you should not stop SGLT2 inhibitor.
In that case, SGLT should be continued.
Yes, so there is no data suggesting, or there is no relation between stopping SGLT2 inhibitor will prevent the gangrene progression. Only in canvas trial it was seen that it can cause, but further data denied this, like there was no correlation with this.
Okay, thank you.
So, thank you everybody for your patience hearing, and I announce this session to be closed.
Thank you everyone for an excellent multidisciplinary discussion. Now I request our panelist and moderator to kindly come forward in the stage for the group photograph. And I like to call Dr. Shobhik Rai sir at the side stage to felicitate our panelist and moderator for this session. The true burden of diabetes lies not only in controlling blood glucose, but also in preventing its far-reaching complications. Our next session focuses on practical strategies to address these challenges in everyday clinical practice. May I now have the privilege of inviting our respected moderator, Dr. Debaditya Das sir, consultant endocrinologist from Gorakhpur AIIMS. The first topic of this session is prioritizing retinopathy management in diabetes. I would like to call the chairperson, Dr. Binitra Banerjee sir, gastroenterologist, associate professor at IQ City.
Good afternoon, everyone. So now we have a very pertinent clinical topic regarding management of diabetes and its complication. As we know, one of the very severe complication is retinopathy, and it can be proliferative or non-proliferative. And to address this session, we have an extremely knowledgeable speaker, Dr. K.K. Roy. I would urge Dr. Binitra Banerjee to welcome and give the introduction for Dr. K.K. Roy.
So, good afternoon, everyone, and thanks for joining us in this session. And without wasting much time, may I request Dr. Krishnakanti Roy, sir, to please be on the dais. Sir is the MS and a senior consultant, and currently at Devita Eye Care. Welcome, sir.
Thank you, sir, for nice introduction. For a days-long diabetic discussion, we are going to discuss a little bit about offbeat topic, that is diabetic retinopathy. Before myself, Dr. Krishnakanta Roy, ophthalmologist, Devita Eye Care. Before going to actual topic, we are going to little bit recapitulate the eye anatomy. I know it's a little bit different from medicine. So this is the cross section of the eye, where you can see the front part. You can So front part you can see the cornea, this is the lens, followed by this is the retina. So this is the actual picture of the retina, where you can see the center part, there is optic nerve head, and this is the macula, where this is the most important part of the retina, where distant object, light from the distant object, they are focused there. This is very important part for our near vision, reading, and for distance visions. Now, if we see that histology of the macula is like this. The cells, multiple layers are there, near about 10 layers in the retina, but this is very important for distant vision. Rods and cone cells are there. And we have fortunately one investigating tool by which in histology level we can see the cross section of a retina at macula, that is called optical coherence tomography. Like CT scan, we can see the cross section of the retina. This is a very good machine by which we can easily diagnose and manage our retinopathy cases. Come to our actual topic. Diabetes gradually increasing day by day throughout the world. One data by International Diabetes Foundation in 2050, near about 45% global diabetes patient will increase. In India, this rise will be near about 74%. That means our diabetic patient, which are present in our country, it will greatly increase in next few years. Another alarming part is that near about 43% patients remain undiagnosed in our country. So actual burden of diabetes is much more compared to what you normally see or data shows in our country. Talking about diabetic retinopathy, one study from 2021 shows the global prevalence of diabetic retinopathy near about 22%. In Southeast Asia, it is near about 17%. This is another study where it is postulated that near about 2045, we have 26 million of people diabetic retinopathy affected in Southeast Asia. In India, multiple study, they tried to see the prevalence of diabetic retinopathy. These are the few studies from South India, initially done, they shows near about 15 to 20% is the prevalence of diabetic retinopathy. Later on, large study done, cross-sectional study done throughout the India, they also shows near 15 to 20% is the prevalence. And lastly, this study published in 2021 from Sankarnathalaya group, throughout India, near about 21 states and participated in the study, where we can see that prevalence of diabetic retinopathy near about 12.5%. So, in next few minutes, we are going to discuss the pathophysiology of diabetic retinopathy, relevance of fundus examination from a physician perspective, and importance of eye examination before prescribing certain anti-diabetic medicines. Now, going to pathophysiology, before we have to consider one part, that is blood-retinal barrier. This is a barrier which separates eye from the our entire body. So, for the blood-retinal barrier, from blood directly anything cannot go inside the eye, and from eye anything cannot go inside the bloodstream. So, we have two blood-retinal barrier, one is outer and inner. Mainly the blood vessels, they are actually circulated inner side of the retina, that actually their inner blood retinal barrier is there, and another set of blood vessels are present outside of the retina, that is in the choroid, their outer blood retinal barrier there. For diabetic retinopathy, inner blood retinal barrier is most important. Inner blood retinal barrier composed mainly, it is present in around the capillary. If you see the retinal capillary cross section, this is the cross section of a retinal capillary, where it is mainly composed of two kind of cell, that is endothelial cell, and along with surrounding that there is basement membrane, and one important cell is there, that is called pericyte. These two cells, endothelial cell and pericyte, very very important for maintaining the inner blood retinal barrier, and that is play a very crucial role in diabetic pathophysiology, diabetic retinopathy pathophysiology. So, in this endothelial cell, there are tight junctions are there that actually prevent the leakage of fluid from inside capillary to outside retina, that actually form the inner blood retinal barrier. Along with this, pericyte gives a structural integrity of the capillary so that capillary cannot rupture and cannot bleed. These two things actually affected in diabetic retinopathy. What happened due to hyperglycemia? By multiple pathway, these pericytes and capillary endothelium lost or damaged. So what happened? Because of the pericyte loss, the structural integrity of the capillary become damaged. So there is a formation of outpouching surrounding the capillary. So there we can see some reddish dot in the early stage of diabetic retinopathy in fundus examination. This is called microaneurysms. This is the very earliest findings of diabetic retinopathy patient. Secondly, due to endothelial damage, the blood vessel capillary become very much leaky. So fluid from inside the capillary, they accumulate inside the retina, causing retinal edema or macular edema. So here you can see the fluid accumulation inside the retina, and if we see the cross section like our OCT in the center part, we can see fluid accumulation inside the macula. If fluid accumulation away from macula, it doesn't hamper very much, because outside macular vision is not that much important for our day-to-day practice, but macula is very, very important for reading vision, distant vision. So if fluid accumulated inside the macula, that causing very much problem, that is commonly known as cystoid macular edema or CME. Next stage, when the capillary damage very much permanent, then the capillary occlusions occur. Capillary become occluded, they damage very much, and the complete occlusion and obliteration of the capillary occur. So here it is a picture of angiography of the retina, like cardiac angiography, we can do the retinal angiography also. This is the normal angiography where you can beautifully see the blood vessels and capillary. Here, this is the diabetic retinopathy, the capillary, very profusely loss of capillary is noted due to capillary obliteration and occlusions. So that ultimately leads to ischemia of the retina. So retinal pigment epithelium is the most metabolically demanding tissue inside the body. That oxygen, due to oxygen demand, they are actually release VEGF to grow few abnormal vessels so that they can get the oxygen and glucose. That abnormal vessels is very much culprit for the diabetic retinopathy, because that ultimately causing further problem. So these are the abnormal vessels which grows due to effect of in VEGF, and that this abnormal vessels ultimately causing the blindness or other complications in diabetic retinopathy. So these are the pathophysiology, and this abnormal vessel we can see in angiography, they are very much leaking and staining. So these are the pathogenesis of diabetic retinopathy. These are basically two arms where there is disruption of the inner blood-retinal barrier, so there is fluid leakage and fluid accumulation inside the retina and macular edema. So retinal edema and macular edema. Another arm, there is a capillary occlusion or obliteration that causing retinal ischemia and causing release of VEGF, ultimately proliferation of abnormal blood vessels, that is called neovascularization. These two arms actually we are deal with diabetic retinopathy, and we treat separately these two arms. Now going for fundus examination. Fundus examination, as you all know, it should be done annually, and for type 1 diabetes mellitus, 5 years after diagnosis is recommended, and for type 2, at the diagnosis, we should do the first fundus examinations. Now question is, what is the importance? Why to do fundus examination? So before that, we all know diabetes are two kinds of complications, that is microvascular complications and macrovascular complications. In microvascular complications, there is retinopathy, neuropathy and nephropathy, and multiple study, they shows that throughout the world, they show that they are occur together and they are correlated. That means if a patient have a diabetic retinopathy, there is a fair chance they also have neuropathy and nephropathy. Then it is very easy to detect diabetic retinopathy. Only simply fundus examination we can detect the diabetic retinopathy. So we can tell that in by fundus examination we can predict the microvascular complications like neuropathy and nephropathy, and overall glycemic control we can predict. And secondly, obviously early diagnosis of diabetic retinopathy and prevent blindness. This is also another reason why should do fundus examination. Now question is always you have to refer this patient to ophthalmologist? No, it is not. You can do fundus examination by yourself. So people, you can actually, this is called people, because of small people you cannot see the retina very well. You have to dilate. You can use a combination of tropicamide and phenylephrine eye drop 2 to 3 times a day, 10-15 minutes interval, and wait for half an hour. It will dilate. Then you can examine the fundus. So the direct ophthalmoscope, we all know this is obviously you all see, and bedside this is used. But problem with the direct ophthalmoscope is that field of view is best. Means once at a time you can see this much of field. So what you have to do, you have to just rotate and see the posterior pole. Luckily for diabetic retinopathy, most of the changes they occur in the posterior pole. That means if you see this part posterior pole, if it is normal, there is a very unlikely the patient will have diabetic retinopathy, very less chance. So this is another one method. Another method is right now it is available, that is portable fundus camera. Many of us will have the portable fundus camera. It is very easy to take the fundus image, and without dilatation also you can take the image. You can print it, you can save it for the further documentation. You can upload in your EMR also. So this is the grading of diabetic retinopathy. In mild NPDR, there is a few microorganisms, and this is moderate NPDR. There is separate diagnostic criteria there. I am not going to that. This is severe NPDR, and this is called PDR. If you see this kind of patient, abnormal blood vessels, they are very, very dangerous. They can cause blindness. This patient will blind if you don't treat very early. So if you come across this kind of patient, you have to refer very, very urgently. Because mild, moderate, severe NPDR, we normally observe, we don't treat, we only by glycemic control, sometimes other problem also you have to treat. But proliferative diabetic retinopathy, you have to treat very early because it can cause blindness. 2-3 lines about cystoid macular edema. We already discussed the fluid can accumulate inside the retina, inside the macula, that is called cystoid macular edema. If you see the cross section, there by OCT, this is the normal OCT, this is the fluid accumulation inside the macula, and this cystoid macular edema we normally treat by giving intravitreal injection. That means inside the eye, you have to inject inside the eye. We have two kind of injection, one is called anti-VEGF, another is intravitreal steroid. So most of the injection, they works very well. Injection respond very well. It is very, very unlikely the injection will not work. But problem with this injection is that most of the injection, they work near about 1 month. So repeated injection requirement is there. So that is the main problem in treating cystoid macular edema, repeated injection and cost. So that there we have to sometime counseling the patient to take repeated injection to maintain their vision. Now, 2-3 drugs are there where that can cause problem in the eye. So before prescribing this kind of drugs, you should have a eye checkup. One of the drug is semaglutide. This is a very famous drug right now. This is the GLP-1 agonist, mainly used for obesity reduction and type 2 diabetes. So main ocular side effect is non-atrophic anterior ischemic optic neuropathy. What is that? This mainly occurs in the near about 50s age group patient, complain of sudden painless loss of vision, typically in the one eye and mostly in the morning. So patient will say, after awakening from sleep, so I cannot see in one eye. Okay. So on examination, that eye vision will be grossly reduced, color vision will be diminished, RDP will be there. And most of them, they have multiple systemic issues like hypertension, diabetes, hyperlipidemia, obstructive sleep apnea, smoking, cardiac disease, etc. So this is the typical presentation of a NAION patient. You can see this is a normal fundus. This disc is a little bit crowded. This disc edema is there, one eye. Presentation, patient have a sudden diminution of vision in the left eye, and on examination disc edema is there. Patient again came to us after 6 months with the complaint of diminution of vision in the other eye, in the right eye. There's again disc edema in the right eye, and this area become pale. At the 7th month, both discs become pale, vision is decreased. So this is the typical history of NAION. Unfortunately, we don't have direct any treatment for the NAION apart from controlling the systemic disease parameter. So what is the relation with semaglutide? So first of all, there is a significant association between semaglutide use and development of NAION. The chances of developing NAION in semaglutide patient near about 2.6 times compared to control group. That means semaglutide increase the NAION development chances near about 2.62 times. Prolonged use, near about more than 2 years use of semaglutide increase the risk of NAION. Patient sometimes have multiple risk factors. We already discussed multiple risk factors will be there, and small crowded optic nerve optic disc, they are very prone to that. And patient having nocturnal hypotension, this is one of the cause where can cause NAION. So these are the association or important points regarding semaglutide use. What is the recommendation? So before use of semaglutide, you are starting, you should have a optic nerve head examination or optic disc examination and retinal vascular sheath. That means simply fundus examination. If we, and that patient should be kept on regular follow-up if it is semaglutide use more than 2 years. Then high index of suspicion should be there and if patient having visual symptoms like this certain loss of vision. Now another drug that is pioglitazone or rosiglitazone, they can increase cystoid macular edema. What they are doing? They are actually increasing the endothelial cell permeability and they are increasing the VEGF level. That means the basic pathogenesis of diabetic retinopathy what is there, they are actually augment these things. So what they are doing? They aggravate neovascular proliferation or abnormal vascular proliferation and they aggravate cystoid macular edema, both. So this is the neovascularization and cystoid macular edema, they aggravate both. What you have to do? Before starting pioglitazone, you should have a dilated fundus examination and macular examination, preferably by optical coherence tomography or OCT. If it is normal, you can start. If there is an aggressive proliferative diabetic retinopathy, you should treat the disease like with PRP. And if a patient having aggressive macular edema or severe macular edema, you have to control it, then use. It is not contraindicated, you can use it after control. Take home message, diabetes and diabetic retinopathy rates increasing very rapidly. Annual fundus examination very much crucial. This not only detect diabetic retinopathy, prevent blindness, but also it tells us overall glycemic status of the glycemic control. Semaglutide can cause NAION, so baseline examination and periodic examination when you are using. And if a patient complaining the visual symptoms, you have to take it seriously and treat it. Pioglitazone can cause cystoid macular edema, can aggravate cystoid macular edema and diabetic retinopathy. So you have to check upon this factor before starting pioglitazone. Thank you.
A very nice deliberation on diabetic retinopathy. I thank you, Dr. Krishnakanta Roy, for your talk. And I also thank Dr. Binidra Banerjee for chairing the session. So due to shortage of time, we're not taking questions now. So I would request the chairperson and the speaker for the next session to come up. So next session would be on the very important topic of assessment of MASLD and MASH, and the chairperson would be Dr. Siddhartha Banerjee, sir, who is a consultant physician, MD Medicine from Asansol. And I would request sir to do something that is very difficult, introduce someone who does not need any introduction. One of my mentors and a national faculty for endocrinology and endocrine students, Dr. Nilanjan Sengupta sir. So over to you, Siddhartha sir.
As already told by you, he does not need any introduction as such because he is a known figure in all national and international conferences that we attend. So without wasting much time, we request to Dr. Nilanjan Sengupta to kindly start his deliberation. Thank you.
Very good afternoon to you all. Of course, this talk was supposed to be delivered by Dr. Anil Virbani, who is indisposed. So this is a last minute change. The topic has already been introduced. We all know about NASH, NAFLD and MASLD. Certain nomenclatural changes have taken place over the years, and judging its importance in relation to metabolic diseases, we are now calling the condition MASLD, and whereas NAFLD was probably a diagnosis of exclusion, MAFLD or MASLD is actually a diagnosis of inclusion of positive diagnosis. So I mention this because there are certain nomenclatural and we are calling it MASLD. But our main job today, this afternoon, is assessment of MASLD and MASH. And between MASLD and alcoholic liver disease, there is another condition which is MET-ALD, that is where both metabolic factors and alcohol consumption contribute to some extent in the causation of the disease. Now, so once again, the spectrum of steatotic liver disease, you look at it, are there any cardiometabolic conditions coexistent? If yes, we call it MASLD, that is metabolic dysfunction associated steatotic liver disease. Now, if there is no, then it may be something else. Then we look at the history of alcohol intake, more than 50 grams per day in women and more than 60 grams per day in men. That actually puts it to alcoholic liver diseases. We have the MET-ALD as well as frank alcoholic liver disease, and if there is no significant alcohol intake, again, that goes into MASLD. So about the cardiometabolic criteria which should be applied before satisfying a diagnosis of MASLD is steatosis plus at least one of these 5, that is obesity as determined by BMI, hyperglycemia, hypertension, and dyslipidemia. And if you search for this in all patients having hepatic steatosis, I can guarantee you, you will find one or the other. So for all practical purposes, the fatty liver disease that we deal with in our practice in a person who is not alcoholic is MASLD unless proved otherwise. So what is the typical presentation of MASLD? These patients are largely symptomatic or may have some vague symptoms like dragging sensation or vague upper abdominal pain, which may or may not be attributed to MASLD. They may come with an abnormal liver function test. Typically, the AST and ALT may be 2 to 5 times the upper limit of normal, depending upon the severity of the condition. Or the patient may come up with an ultrasonographic evidence of hepatic steatosis. And if we do care to examine the patient, which I'm sorry to say we endocrinologists rarely ever do, you can find a hepatomegaly, which may be tender or non-tender on examination. But I want to emphasize upon the fact that MASLD can exist in the absence of a clinically palpable hepatomegaly with normal liver enzymes, so in the absence of elevated liver enzymes and even in the absence of sonologic evidences of steatosis. So diagnostic evaluation, when do you suspect for MASLD? Again, the same thing. If the patient comes with an abnormal liver function test or an ultrasound suggesting fatty liver or has multiple risk factors, in our practice, in endocrine practice, all patients with coming to us, most of them either have obesity or type 2 diabetes along with other comorbidities, so they can be assumed to have some sort of hepatic steatosis unless proved otherwise. Now, what are the laboratory studies? You can go through a lot of studies to uncover or come to a diagnosis of MASLD, but commonly done tests include a liver function test and some imaging techniques. And this busy slide actually enumerates the common non-invasive tests and their normality cutoffs. So we have many indices, but the index that is commonly used is the FIB4 index, and that is how you calculate the FIB4 index. It's very easy. You only need the AST, ALT, and the platelet count, and that is used as a screening test. So a FIB-4 cutoff of less than 1.3 rules out MASLD, and a cutoff of more than 2.67 rules in MASLD, and the in between is the gray zone. But having said that, in my practice, I rarely, if ever, do the FIB-4 score, because this is a screening test, and for 95% of the patients coming to me with cardiometabolic diseases, I assume the person to be having a positive screen anyway, and I generally encourage for some sort of imaging studies. So there are other markers of fibrosis. A costly marker would be the ELF, or the Enhanced Liver Fibrosis Test, where you have to look at the hyaluronic acid, the amino terminal propeptide of type 3 collagen, and TIMP1. And this is how the ultrasound of MASLD looks like. It becomes very bright on sonography, but this comes with a caveat. Ultrasound is only a good at detecting steatosis, particularly if the hepatic fat content is greater than 30%. And conventional ultrasound is only a semi-quantitative tool in grading fatty liver, and that's how it is graded by the sonologists. Grade 1 is an increased echogenicity, grade 2 is blurring of the intravascular structures, and grade 3 is so much, the liver is so bright that you cannot separately discern the diaphragm. So that's how the sonologists grade. That's how it looks like. But what is better than a conventional ultrasonography is elastography. That is a variant of ultrasonography, but elastography gives much more information. It is a quantitative test, and elastography not only gives us an idea of the degree of steatosis, but also the gradation and degree of fibrosis. Again, there are variants of elastography. The ideal would be vibration-controlled transient elastography, or VCTE in short. Then acoustic radiation force impulse, or ARFI, and the 2D shear wave elastography. And of course, magnetic resonance elastography is also can be undertaken if available, but we generally go by the ultrasound-based tests. Now, why I mention details about it, because it is the VCTE which is typically used in quantifying steatotic liver disease, is probably more accurate than ARFI and shear wave elastography. But for this VCTE, you have to have a dedicated machine which costs lakhs of rupees. So most of the laboratories, they don't want to procure such a machine, just they want to do the shear wave elastography, which can be done in the standard ultrasound machine. And most of the studies are validated, and the treatment protocols are validated against VCTE. In innumerable times, I have advised for VCTE, specifically writing VCTE, specifically writing the name of the company, that is EchoSense. That despite, I find reports coming of ARFI and shear wave elastography, and the laboratories are charging as high as 5,000 rupees for an improperly done test. So that's how a report of VCTE looks like. So you have to look at the CAP. Now both this CAP, that is controlled attenuation parameter, and LSM, that is liver stiffness measurement, are proprietary trademarks of EchoSense FibroScan machine. So if somebody in shear wave elastography gives LSM, that is actually not an LSM, but some other index of fibrosis. And shear wave elastography cannot quantify steatosis. It can look at fibrosis only. Only thing is that if the person is massively obese, where your VCT may be unreliable, their shear wave elastography has an advantage over VCT in quantifying fibrosis. So more or less the threshold is around 240 decibels per meter, and higher than 290 means significant steatosis. Similarly, fibrosis can be graded because it has the correlation cutoffs with the METAVIR scoring system, which is a histopathologic scoring system. I just remember two figures, 7 kilopascals and 14 kilopascals. Less than 7 kilopascals is normal, and you can reassure the patient that the patient doesn't have any fibrosis. More than 14 kilopascals, meaning that patient is hovering towards cirrhosis, should be extra cautious, and 7 to 14 is in between. So this study, this meta-analysis actually shows the importance of VCTE over other modalities. It has excellent correlation, and VCTE can indeed act as a surrogate for histopathology, which happens to be the gold standard for diagnosis of steatohepatitis, but being invasive, that cannot be done in every patient for all practical purposes. Then we have a host of serological, go back. So then we have a host of serological tests. Then we have a host of serological tests that also can be done, but remains theoretical, because these are costly, not easily available, much easier to do the ultrasonography-based tests. A few words about liver biopsy. As I've said, though this is the gold standard and you cannot diagnose steatohepatitis with confidence without liver biopsy. With imaging, you can diagnose steatosis. With imaging, you can diagnose fibrosis, but you cannot diagnose inflammation until and unless you do liver biopsy. But liver biopsy has its downsides in that this is a global disease, but you are sampling one or at best two areas of the liver, so diagnosis may be missed, or you may not get the global picture. Second, it is an invasive test with its share of complications, can cause bleeding and other problems. And being an invasive test, most patients would not submit to liver biopsy for such a benign disease as MASLD. But additional histological findings, this how a histopathologist diagnoses MASH and classifies MASH. So indeed, indications of liver biopsy in MASLD are very limited. I remember one patient with fatty liver, having diabetes, very much elevated liver enzymes, not responding to any sort of therapy. She underwent, from Bardhaman itself, she had to undergo liver biopsy, and that was because she was suffering from autoimmune hepatitis and has been put on azathioprine and glucocorticoids, now is doing well. So if you have certain etiologies in mind, apart from alcohol, apart from metabolic diseases, that is causing, say, hepatitis or chronic active hepatitis, then only you can consider liver biopsy. But for the garden variety of MASLD, liver biopsy should not be done just to confirm the diagnosis. So, but should you do it, or in research setting, the histopathologists have very many activity scores to see the severity of MASLD or steatohepatitis. They look at steatosis, lobular inflammation, ballooning of the hepatocytes and fibrosis, and this is the NAFLD activity score, and these have been matched with VCTE, and the correlation is quite good. So finally, this is the diagnostic flow for MSALD. If you suspect MSLD in a patient of type 2 diabetes or obesity with persistently elevated liver enzymes, in a community setting, you can go for a FIB-4 score because that is easy to calculate. Again, I repeat, that requires only the AST, ALT, and the platelet count. If the FIB-4 is less than 1.3, that rules out any significant steatosis, and you can just reassess after 1 to 3 years. If the score is more than 2.67, there is very high likelihood of the patient having steatotic liver disease. In this guideline, it says hepatology referral, but I think that is not straight away needed. You just confirm it by BCTE, and now we have therapies like semaglutide, like off-label resmetirom, and maybe saroglitazar also, apart from metabolic control in managing MASLD, maybe in conjunction with the services of a hepatologist or a gastroenterologist. And in between, you have to look at the patient and take decisions likewise. But as I said, in my practice, since this FIB-4 is a screening tool, this is important to screen or rule in or rule out MASLD. In my patients, in most of my patients, I consider them to have already a positive screen when they are entering my clinic. Therefore, I do away with this FIB-4 score. I straight away encourage a VCTE, properly done VCTE, just to quantify the degree of steatosis and fibrosis and take therapeutic decisions accordingly. So to conclude, therefore, whatever said and done, it has been argued that MASLD now is a positive diagnosis, but I still feel MASLD remains a diagnosis of exclusion. You have to exclude chronic viral hepatitis, ideally. You have to exclude Wilson's disease, ideally, or drugs causing fatty liver. Now, but at the same time, MASLD will be missed if the clinician does not have a high index of suspicion. On the other hand, it is rather easy to diagnose MASLD if the patient knows about it. Screening should be universal in persons with type 2 diabetes and obesity. Therefore, it obviates the use of FIB score. FIB-4 is mostly used for screening, but is not reliable below 35 years of age, and the cutoffs are age dependent. Conventional ultrasonography fails to document steatosis if it is not more than 30%, and it should not be used to diagnose steatosis, but at the same time, conventional ultrasound is important in a patient with advanced fibrosis to have an idea of the liver architecture, whether there are cirrhotic nodules, whether there is splenomegaly or congestive portal hypertension. So conventional ultrasonography is important when the patient is having advanced liver disease to see the degree of liver disease, but conventional ultrasound should not be used per se to pick up steatotic liver disease. Most studies have been done with VCTE, and that should be encouraged over shear wave elastography and ARFI. And lastly, liver biopsy, the gold standard, has hosts of its disadvantages and is therefore impractical in the routine workup of MASLD. With this, I thank you for your patience, and next time when you have this platter of chart, please remember about your liver. Thank you.
Thank you, sir. As always, it was an excellent deliberation by Sengupta sir. We would love to take questions, but due to shortage of time, we can't. So we'll move on to our next session. So thank you, sir. And also thank you to Dr. Siddharth Banerjee. And for the next session, the topic is mental health assessment in obesity. As we all know, how much ever we Okay, so there has been a change of plans, rain check. So, we'll have our inauguration ceremony now, and followed after the ceremony, we'll move on with our academic discussion and academic program. So I'll hand over the mic to the organizers so that they can continue with the inauguration ceremony. Thank you.
Thank you, sir.
Hello. Good evening, distinguished guests, respected faculty, speakers, delegates, colleagues, and friends. On behalf of Bengal Diabetes Foundation, it is my privilege to welcome you to the inaugural ceremony of BDCON 2026, the 11th annual conference of the Bengal Diabetes Foundation. Okay,
15 minutes time.
So,
now we'll take 15 minutes time for the stage preparation for our next session, that is lamp lighting. Now I'd like to call Dr. Arpan Rai Chaudhuri sir on the side stage. And I would like to call Dr. Siddhartha Banerjee sir, Dr. Vinidra Banerjee sir. Please come on the side stage. Dr. Siddhartha Banerjee sir and Dr. Vinidra Banerjee sir to come on the side stage for the felicitations. I'd like to call the photographer on the side stage. Thank you, everyone.
Good evening, everyone. We are back after the brief pause. Good evening to the distinguished guests, respected faculty, speakers, delegates, colleagues, and friends. On behalf of the Bengal Diabetes Foundation, it is my privilege to welcome you to the inaugural ceremony of BDCON 2026, the 11th annual conference of the Bengal Diabetes Foundation. Over these 3 days, this conference brings together expertise, experience, and new ideas in diabetes, obesity, and metabolic medicine. This evening is our opportunity to formally celebrate that shared academic spirit. We are deeply honored by the presence of our distinguished dignitaries, faculty members, and delegates. I request everyone to kindly remain seated as we proceed with the inaugural ceremony. Knowledge grows where minds meet. Ideas are shared and experience is celebrated. Today we come together not merely to attend a conference, but to strengthen a community dedicated to improving lives through science and compassion.
Now, for the auspicious lamp lighting, I would like to call Swami Dibbananda Maharaj Ji. He will be accompanied by our organizing chairperson, Dr. Nilanjan Sengupta sir, our BDF chairman, Dr. Amitabh Vishwas sir, our secretary general, Dr. Shoumik Goswami sir, our organizing secretaries, Dr. Shubham Das sir and Dr. Taraknath Chattopadhyay sir, our treasurer, Dr. Manush Mollik sir.
जय सरस्वती माता, जय सरस्वती माता, जय सरस्वती माता, जय सरस्वती माता, सद्गुण वैभवशालिनी त्रिभुवन विख्याता, जय सरस्वती माता, जय सरस्वती माता. चंद्रवदने पद्मासिनी द्युतिमंगलकारी शोभे श्वेत वस्त्र अनुपम वीणाधारी. जय सरस्वती माता, जय सरस्वती माता. बाएं कर में पुस्तक शोभे दाएं वीणा, जग में ज्ञान प्रकाश फैलाती तू सबकी दीना. जय सरस्वती माता, जय सरस्वती माता.
It's our great privilege to welcome His Holiness Swami Dibbananda Maharaj Ji, an eminent spiritual leader whose message on compassion, wisdom, and service continues to inspire countless lives across the nation. Sir, please grace us with your presence on the stage. I would like to call on the stage our organizing chairperson, Dr. Nilanjan Sengupta sir, our BDF chairman, Dr. Amitabh Vishwas sir, our Secretary General, Dr. Shoumik Goswami sir, our organizing secretaries, Dr. Shubham Das sir and Dr. Taraknath Chattopadhyay sir, and our treasurer, Dr. Manush Mollik sir. Now, I would request our organizing chairman, Dr. Nilanjan Sengupta sir, and Secretary General, Dr. Shoumik sir, to felicitate our chief guest. Now, may I request Dr. Amitabh Bishwa sir kindly address the gathering.
Good evening, শুভ সন্ধ্যা, পরম পূজনীয় শ্রীমৎ স্বামী দীপানন্দজি মহারাজের চরণে প্রণাম করে আমাদের বেঙ্গল ডায়াবেটিস ফাউন্ডেশনের যারা কর্ণধার তারা মেজরিটি আজকে আমাদের স্টেজে আছেন। আপনারা সবাই যাদের হাত ধরে বিডিএফ হাঁটি হাঁটি পা পা করে আজকে 11 বছরে পা দিয়েছে, আমি রিয়েলি ভেরি প্রাউড অ্যান্ড ঈশ্বরের অশেষ কৃপা আছে যে আমি এমন দুজন লোককে পেয়েছি, ডক্টর শুভম দাস, ডক্টর তারকনাথ চট্টোপাধ্যায়। দে হ্যাভ ডান এ মিরাকল ইন দ্যাট ইজ এভিডেন্ট। আশা করি গতকাল সন্ধ্যা থেকে আপনারা অনুভব করেছেন। আমি বিডিএফ এর তরফ থেকে বিং এ চেয়ারম্যান ফর দ্য বিডিএফ পরিবার, আই ইনভাইট ইউ অল। ইটস এ সাইন্টিফিক এক্সট্রাভ্যাগেন্সা অ্যালং উইথ প্লিজ অ্যাকসেপ্ট আওয়ার হসপিটালিটি। I hope you will enjoy. Pranam. Namaskar.
I now invite the designated address from our organizing secretary, Dr. Shubham Das sir.
Namaskar, Shubho Shandha. Respected dignitaries on and off the dais, Pujaniya Swami Dibbanandaji Maharaj, our esteemed faculty members from across India and West Bengal, distinguished chairpersons and moderators, dear delegates, postgraduate students, colleagues and friends. A very warm afternoon and a heartfelt welcome to the 11th Bengal Diabetes Conference 2026. On behalf of the Bengal Diabetes Foundation and the entire organizing committee, it is my privilege as organizing secretary to welcome you all to Durgapur. Today, the 8th of August, incidentally also marks the death anniversary of Kavi Guru Rabindranath Tagore. On this occasion, I am reminded of those immortal lines from Gitanjali. Chitto jetha bhoye shunno, uchcho jetha shir, gyan jetha mukto, jetha griher prachir, আপন প্রাঙ্গণ তলে দিবস সর্বরি, বসুধারে রাখে নাই খণ্ড ক্ষুদ্র করি। In essence, Gurudev Tagore envisioned a world where the mind is without fear, where knowledge is free, and where narrow walls do not fragment the world into small compartments. And perhaps that thought beautifully captures the spirit of a scientific conference. Knowledge cannot remain confined within our own minds, institutions, specialties, or geographical boundaries. Knowledge becomes meaningful only when it is shared, questioned, and allowed to travel. That is precisely what we hope to achieve at BDCON. Over the last 10 years, BDCON has grown tremendously, both academically and in delegate participation. In our 11th year today, we are privileged to welcome nationally acclaimed faculty and colleagues from across the country. Our theme this year is Diabetes and Obesity Across the Lifespan, from Early Development to Healthy Aging. Is reflected throughout an exciting scientific program covering the obesity assessment, diabetes classification, sarcopenia, GLP-1 therapies, cardio-nephroendocrine medicine, steatotic liver disease, diabetes complications, and perioperative endocrinology. Tomorrow the discussions continue with diabetes remission, AI in complication screening, endocrinology in pregnancy, and obesity management. So I invite all of you today not merely to attend, but to interact, question, debate, and share, because that is how knowledge grows. My sincere gratitude to our faculty, delegates,
sponsors, and the entire organizing team. Welcome to BDCON 2026, where knowledge meets excellence and where knowledge is truly free to travel beyond boundaries. And thank you once again, and a very warm welcome to Durgapur and BDCON 2026. Namaskar.
Some moments are not merely meant to be heard, but to be felt. Some words do not merely inform, but illuminate the path within. It is our profound privilege to welcome His Holiness Swami Dibbananda Maharaj Ji, whose presence brings with it the fragrance of wisdom, peace, and inspiration. Maharaj Ji, with utmost reverence, we invite you to address the gathering.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मा अमृतं गमय ओम शांति शांति शांति. It is a great pleasure to be here in the midst of experts, students in especially diabetics. Diabetes has become an epidemic throughout the world, and our score is perhaps second position. In India, we have a large number of diabetic patients, including pediatric diabetes. The children also are suffering from this ailment. Anyhow, you are trying hard for last 10 years to think over it, and you are thinking of the process or the ways to reduce diabetes, especially in our country. যাই হোক, এখানে এসে ভালো লাগছে। অনেক আমার নিজের পরিচিত দু একজনকে পেয়েছি। আমার ডান দিকে যিনি বসে আছেন শুভম, তাকে আমি শৈশব থেকে দেখেছি। সে আমাদের ছাত্র ছিল। তার বাবা আবার আমার সহপাঠী ছিলেন, ক্যালকাটা টেলিফোনসে কাজ করতেন। রহড়া রামকৃষ্ণ মিশনে একবারে গাই ওদের বাড়ি। এখনও যোগাযোগ আছে আমার সাথে, ওর বাবার, ওর মায়ের। তো এইরকম আরও অনেকেই আমাদের রামকৃষ্ণ মিশনের আসানসোলের ছাত্র, তারকনাথ চ্যাটার্জি, অমিতাভ বিশ্বাস, এদের সাথে পরিচয় হলো। আর সামনে যারা বসে আছে তাদের সাথে এইভাবেই পরিচয় হয়ে গেল। পরে আপনাদের সাথে দেখা হলে খুশি হব। একটা কথা বলি যে আমরা এই পৃথিবীতে জন্মেছি কিছু ভালো কাজ করার জন্যে। অন্যান্য অ্যানিমালস, অন্যান্য জন্তুরা তারা ভালো কাজ করতে পারে না বেশি। মানুষকে ঈশ্বর সেই ঐশ্বর্য, সেই ক্ষমতা, সেই বুদ্ধি দিয়ে রেখেছেন। আমাদের এটাকে কাজে লাগাতে হবে। স্বামী বিবেকানন্দ বলতেন, যখন জন্মেছিস তখন একটা দাগ রেখে যা। বিডিকনেরও এইরকমই একটা উদ্দেশ্য যে আমরা একটা দাগ রেখে যাব। ডায়াবেটিক ফিল্ডে আমরা মানব কল্যাণে ব্রতী থাকব। গবেষণার মাধ্যমে, শিক্ষার মাধ্যমে, ট্রিটমেন্টের মাধ্যমে। আমার মনে পড়ছে এক গুরুর কাছে একবার এক শিষ্য গিয়েছিলেন, বলেছিলেন সংক্ষেপে আমাকে আধ্যাত্মিক জীবন বা ধর্মজীবন সম্বন্ধে বলুন। উনি ছোট্ট একটা উত্তর দিয়েছিলেন, অতি সংক্ষেপে বলবো তোমাকে, বলে একটা মাত্র শব্দ বললেন, অ্যাওয়ারনেস। তারপরেই শিষ্য বললেন, আরেকটু বড় করে দাও ওটাকে, মেক ইট এ বিগার সেন্টেন্স। তখন উনি একটা কমা দিলেন, আবার অ্যাওয়ারনেস লিখলেন, আবার একটা কমা দিলেন, অ্যাওয়ারনেস লিখলেন। তারপরে প্রশ্ন হলো, হোয়াট ডাজ দিস থ্রি অ্যাওয়ারনেসেস মিন? গুরু বললেন, অ্যাওয়ারনেস 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 মিন নাথিং বাট অ্যাওয়ারনেস। এটাই শ্রীরামকৃষ্ণদেব বলতেন, মানুষ তো মানুষ, মানুষকে সবসময় সচেতন থাকতে হবে। ডাক্তাররাও কেবল পুঁথিগত বিদ্যা নিয়ে ক্ষান্ত হবেন না, যেটুকু পড়েছেন। ডাক্তারদের জীবনও সারা জীবনই শিক্ষার জীবন। এখনো অনেক সিনিয়ররাও অনেক বই পড়াশোনা করেন, নতুন নতুন কি গবেষণা হচ্ছে জানেন, এই কনফারেন্সগুলোতে সেটা বোঝা যায়। যাবৎ বাঁচি তাবৎ শিখি, যতদিন বাঁচব ততদিনই শেখার আছে। তো সেই রকমই আমরা সারা জীবনই সচেতন থাকব চারপাশের প্রবলেম নিয়ে। এটি ছেলে এসেছিল অল্প বয়সের বিবেকানন্দের কাছে, বলছেন আমি বিভিন্ন জায়গায় যাই, যে যা বলে তা পালন করি, আমি দরজা বন্ধ করে মেডিটেশন করি, কিন্তু কিছুতেই আমার শান্তি লাভ হচ্ছে না, কি করব বলুন তো? তিনি বলেন এর উল্টোটা করতে হবে, তুমি জানলা দরজা খোলো, পাশাপাশি যাও, গিয়ে দেখো মানুষের কি প্রয়োজন আছে, সেই প্রয়োজনগুলো মেটাবার চেষ্টা করো, তাহলেই তুমি শান্তি পাবে বাপু। আর অন্য কোনো পথ নেই। নান্যপন্থা বিদ্যতে অয়নায়, বেদে উপনিষদে বলা আছে ঈশ্বরকে জানলে তবেই সমস্যা মেটে। আর ঈশ্বর কোথায় আছেন? তিনি মানুষের মধ্যে আছেন। এখনকার দিনে বাচ্চারা এত সজাগ। আমি একটা 9 বছরের মেয়েকে জিজ্ঞেস করলাম, বলো তো তুমি কখনো ঈশ্বরকে দেখেছো, জ্যান্ত ঈশ্বরকে? 9 বছরের মেয়ে বলল প্রত্যেক দিন আমি 6 জন লিভিং গডকে দেখি, জ্যান্ত ঈশ্বরকে। ইংলিশ মিডিয়ামে পড়ে মেয়েটি। তারপরে আমি বললাম তারা কে? মেয়েটি বলল আমার মা, বাবা, দাদু, দিদিমা, আর আমাদের বাড়িতে থাকেন একজন পিসিমা, আর আমি, ইনক্লুডিং মাইসেলফ, 6 জন লিভিং গড। এইটি রামকৃষ্ণদেবের কথায় বারবার আছে। উনি হরিহর ব্রহ্মা স্তোত্র থেকে বলতেন, যত্র জীব তত্র শিব, যেখানেই জীব সেখানেই শিব। ভারতবর্ষ এক অদ্ভুত দেশ, পুণ্যভূমি। স্বামীজি বলতেন পৃথিবীতে যদি কোনো দেশ থাকে যাকে পুণ্যভূমি আখ্যা দেওয়া যেতে পারে তা হলো আমার দেশ ভারতবর্ষ। এখানেই এইসব উচ্চারিত হয়েছে। বেদে একটা অদ্ভুত মন্ত্র আছে যার অর্থ হলো প্রতিদিন যে শিশুগুলো জন্মাচ্ছে, জন্মগ্রহণ করছে, তারা আসলে সেই পরমাত্মা পরমেশ্বরেরই মূর্তি। ছোট ছোট শিশুগুলো আজকেও যারা এই মুহূর্তে জন্মগ্রহণ করছে নার্সিংহোমে, হসপিটালে, মেডিকেল কলেজে, এরা সব লিভিং গড, জ্যান্ত ঈশ্বর। আমাদের দায়িত্ব এই শিশুদের পালন করা। সব থেকে কঠিন কাজ হলো প্যারেন্টসদের। পৃথিবীতে হার্ডেস্ট ওয়ার্ক হচ্ছে নিজের সন্তানকে ভালো করে তৈরি করা। অলরাউন্ড ডেভেলপমেন্ট, পার্সোনালিটি ডেভেলপমেন্ট বলি আমরা, পার্সোনালিটি ডেভেলপমেন্ট, দিস ইজ দি হার্ডেস্ট ওয়ার্ক। বিডিকনের কাজ তো খুব হার্ড, কিন্তু তার থেকে নিজেদের ছোট ছোট সন্তানদের মানুষ করা খুব কঠিন। সুকান্ত ভট্টাচার্যের কবিতার শেষ লাইনে আছে, আমি এই পৃথিবীটাকে শিশুদের বাসযোগ্য করে যাব, এই আমার দৃঢ় অঙ্গীকার। সত্যি আমাদের প্রত্যেকের এই অঙ্গীকার থাকা উচিত। শিশু কেন, বৃদ্ধ, তাদেরও যাতে আয়ু বৃদ্ধি হয়, তারা যাতে সুস্থ থাকেন, তার জন্য আমরা কাজ করব সকলে মিলে হাত দিয়ে। সবার হাত যুক্ত হবে এই কাজে। এই কনফারেন্সগুলোর উদ্দেশ্যই এই যে এতজন, প্রায় 200 জন ডেলিগেট বা 300 জন ডেলিগেট পার্টিসিপেন্ট, তারা একত্র হয়ে এই এক চিন্তা করবেন কি করে ডায়াবেটিস দূর করা যায়, মানব কল্যাণ করা যায়। ডায়াবেটিস থেকেই তো অনেক প্রবলেম হয়। সমস্ত লিম্বগুলো নির্ভর করে, এই নষ্ট হয়ে যায় যদি ডায়াবেটিস কন্ট্রোলে না থাকে। অল লিম্বের ফেলিওর হবে, সমস্ত অঙ্গগুলো, যদি আমরা ডায়াবেটিসকে না ঠিক করতে পারি। কারো গ্লুকোমা হয়, চোখ খারাপ হয়ে যায়, আরও কত কিছু যে হয়, কিডনি খারাপ হয়ে যায়, আস্তে আস্তে সব অঙ্গগুলো নষ্ট হয়ে যায় যদি ডায়াবেটিসকে আমরা দ্রুত দূর করতে না পারি। আমি কদিন আগে গেলাম ডালাস, আমেরিকায়। সেখানে এক বাড়িতে দুপুরে লাঞ্চের নেমন্তন্ন ছিল। সেখানে দেখলাম যে হাউসওয়াইফ, যিনি আসলে ওয়াইফ না, হাউসওয়াইফ নয়, তিনি গৃহকর্ত্রী, তিনি কাজ করেন একটা বড় হসপিটালে, আইসিইউতে। আমি কথাবার্তায় বললাম এখানে কিডনি ট্রান্সপ্ল্যান্ট হয় খুব ভালো, ছোটদের হয় জানো? বলে এই কদিন আগে 2.5 বছরের একটা শিশুর কিডনি ট্রান্সপ্ল্যান্ট হয়েছে, আমার আইসিইউতে ছিল, এবং সে এখন সুস্থ হয়ে গিয়েছে। এরকমভাবেই ছোট শিশুদেরও প্রচুর অসুখ হচ্ছে। আমি কদিন আগে এখানে আসবো বলে গুগল দেখছিলাম, সেখানে দেখলাম ডায়াবেটিস কত জনের আছে, পেডিয়াট্রিক্সদের কত আছে, শিশুদের কত আছে, টাইপ এ কেমন আছে ডায়াবেটিস আমাদের, সত্যি অ্যালার্মিং। সেই জন্যেই বিডিকন এই যে কাজটি করছে 2026 11th কনফারেন্স, আমি আশা করি এটা ফলপ্রসূ হবে এবং আগামী দিনে সব ডাক্তাররা একত্র হয়ে এই কাজ করে যাবেন। কাজ কোনোদিন শেষ হবে না, আসলে যত দিন যাচ্ছে প্রবলেম বাড়ছে। আমরা ফিজিক্সে পড়ি chaos is increasing, chaos মানে এন্ট্রপি ইজ ইনক্রিজিং, এন্ট্রপি বাড়ছে মানেই হলো ওই chaos বাড়ছে, প্রবলেম বাড়ছে, লাইফস্টাইল চেঞ্জ হয়ে যাচ্ছে, সব দিক দিয়ে মানুষের সামনে পথ নেই। সেই জন্যেই ডাক্তাররাই আমাদের বন্ধু, তারাই আমাদের এই সমাজের এই দুঃখটাকে দূর করতে পারবেন, এই আমার বিশ্বাস। এখন 3টে বই হয়েছে, জানলে তোমরা অবাক হবে। একটা হলো রামকৃষ্ণদেবের চিকিৎসা এবং চিকিৎসকগণ, আরেকটি বই হয়েছে একই লেখিকার সঙ্গমিত্রা চৌধুরী, সেটা আরেকটি হলো নাম শ্রী মা সারদা দেবীর চিকিৎসা এবং চিকিৎসক বৃন্দ, স্বামী বিবেকানন্দের চিকিৎসা এবং চিকিৎসক বৃন্দ। সেখানে আমরা দেখি ওরা প্রয়োজনে কত রকম ডাক্তারের কাছে গেছেন, কত চিকিৎসকের কাছে গেছেন, আবার ডাক্তাররা যা বলেছে সেইগুলি পালন করেছেন সিরিয়াসলি। রামকৃষ্ণদেবের জীবনী পড়লেও পাওয়া যায়, কথামৃত পড়লেও পাওয়া যায় যে এরা ডাক্তারদের বলছেন ঈশ্বরেরই মূর্তি। সত্যি শিশু যেমন ঈশ্বরের মূর্তি, তেমনি আমাদের সামনে যারা বসে আছেন, আমার ডান দিকে বাঁ দিকে যারা বসে আছেন, অল আর ডিফারেন্ট ফর্মস অফ গডস। ঈশ্বর ছাড়া আসলে দুই তো নেই, বেদান্ত বলে একটাই আছে, অদ্বৈত বেদান্ত, শঙ্করাচার্য বললেন। সেই জন্যে সবার মধ্যে ঈশ্বর, কিন্তু ডাক্তারদের মধ্যে সেই ক্ষমতা আছে আমাদের দুঃখ দূর করার জন্যে। তাদের ইন্টেলেক্ট, তাদের শিক্ষা, একাডেমিক, এইগুলি তাদের হাতিয়ারের মতো করে সমাজের এই দুঃখ দূর করার জন্য তারা চেষ্টা করবেন, করছেন, আরও করবেন, উজ্জ্বলতরভাবে করবেন। সমস্যাও যত বাড়বে তত বেশি এরা কাজ করবেন। প্রবলেম কিন্তু কোনোদিন থামবে না। ভাগবতে একটা খুব সুন্দর কথা আছে, সমুদ্রে শান্ত কল্লোলে স্নাতুম ইচ্ছতি দুর্মতি। সমুদ্রের তীরে গিয়ে কেউ যদি ভাবে সমুদ্রের ঢেউ যখন শান্ত হবে তখন আমি স্নান করব, সেই ভদ্রলোক বা ভদ্রমহিলার স্নান করাই হবে না, ঢেউয়ের মধ্যেই স্নান করতে হয়। সেই জন্যে সমাজে প্রবলেম থাকবে, ফ্যামিলিতে প্রবলেম থাকবে, চারিদিকে প্রবলেম থাকবে, কিন্তু এরই মধ্যে ডাক্তাররা কিন্তু দমে যাবেন না, ডক্টররা কাজটা বন্ধ করবেন না, যতই বাধা বিপত্তি আসুক। ও রবীন্দ্রনাথের কবিতা পড়লো চিত্তজেতা ভয়শূন্য ইত্যাদি, সেটারও একই শিক্ষা যে আমরা সব সময় নির্ভীকভাবে কাজ করব, লিভ ফিয়ারলেসলি। সত্যি আজকে খুব প্রয়োজন। আমি একটা ছোট্ট কাহিনী বলে শেষ করি। একটা বই আছে, ডাইং টু বি মি, অনিতা মুরজানি, সিন্ধি মহিলা, সিঙ্গাপুর বেশ করে এখন থাকেন, ইন্ডিয়ান অরিজিন। ওনার ব্রেন ডেথ হয়ে গেছিল। উনি লিখেছেন বইয়ে তার নিজের আত্মকথার মতো যে আমি, আমার সোলটা বডি থেকে আলাদা হয়ে গেল, আমি যেন পরলোকে চলে গেলাম। সেখানে আমার মৃত বাবার সাথে দেখা হলো, আমার এক বান্ধবী, তার সাথে কথা হলো। বাবা বললেন তোমার দুটো অপশন আছে, একটা হলো ওল্ড বডিতে ফিরে যাওয়া, আর একটা হলো নূতন বডি গ্রহণ করা, নূতন দেহান্তর প্রাপ্তি হবে। কিন্তু তোমাকে বলি, যদি তুমি ফিরে যাও নূতন পুরনো শরীরে, লিভ ফিয়ারলেসলি, নির্ভীকভাবে থাকবে। উনি ফিরে এলেন, এবারে কেমন ফিয়ারলেসনেস, বইটা তোমরা পড়ে দেখতে পারো, অপূর্ব বই, ছোট্ট বই, বেশি দাম নয়, ডাইং টু বি মি বাই অনিতা মুরজানি। সার্চ করলেই পাওয়া যাবে, বাড়িতে চলে আসবে বইটা, অ্যামাজনকে টাকা দিলে, পেমেন্ট করলে। উনি বলছেন এবারে এসে আমি নির্ভীক হয়ে গেলাম। এরকম নির্ভীক ডক্টরদের বললেন আমি আর কেমোথেরাপি, ইমিউনোথেরাপি কিচ্ছু নেব না, আমি নিজেই নিজেকে থেরাপি করব। তারপরে মেন্টাল থেরাপি করে ভদ্রমহিলা 6 মাসের মধ্যে সম্পূর্ণ নির্মূল হয়ে গেল তার ক্যান্সার। সেই ইতিহাস লিখেছেন, এটা ইংরেজি, হিন্দিতে টক আছে ওখানে। আরেকজন বলছেন ওর হয়ে, বলছেন ভয় থেকে রোগ, ডায়াবেটিস থাকবে, রুগীদের বোঝাতে হবে যে তো আপনারা ভয় পাবেন না, আমরা আপনাদের সাথে আছি, রোগ নিশ্চয়ই সেরে যাবে। অনেকে ভয় পেয়ে যায়, চোখ খারাপ হয়েছে, ত্রিপুরা থেকে একটি ছেলেকে পাঠানো হবে শঙ্কর নেত্রালয়ে। সেই সময় ও ভাবতে শুরু করেছে নানা রকম। ওর বাবাকে বলছে একটা অল্টারনেটিভ হয় না। বাবা জিবি হসপিটালের কাছে থাকতেন, তিনি পালোয়ান চৌহান বলে নাম ভদ্রলোকের, লেবারে কাজ করতেন। গ্যাস ও ফ্লেম একটা কোম্পানি, ওই সিলিন্ডার স্টকিস্ট এবং বিক্রি করেন, সেই ওদের লেবার ছিলেন। উনি তখন অন্নপূর্ণা পুজো হবে বা বাসন্তী পূজা, সেখানে মানত করলেন বলি দেবেন বলে। বলির সময় পূজারীরা করে কি, খড়গের পুজো করে। ওর বাবাকে বলল খড়গটা ধরুন, এটা ছাগল আনা হয়েছে যুপকাষ্টে। তারপরেই হুংফট খড়গায় নম বলে এতে গন্ধপুষ্পে ফুল দিলেন। তারপরে কি হলো, অদ্ভুত একটা কাণ্ড হলো, খড়গের প্রাণ প্রতিষ্ঠার মতো। ওই গণেশ চৌহানের বাবা, না গণেশ চৌহানকে ধরতে দিয়েছিল, যে আমাদের কর্মী ছিল ত্রিপুরায়, বিবেকনগরের একটা বিখ্যাত স্কুল এখন সিবিএসইর। তো সেখানে গণেশ 10 বছরের বেশি চাকরি করেছিল। গণেশের হাতে যেন ওটা জীবন্ত হয়ে গেল, গণেশের গলায় চলে এলো খড়গটা, আসলে নিজেই সুইসাইড করে ফেললো বেচারি ভয় থেকে। চেন্নাই যেতে হবে, আমি আর চোখে বোধহয় একবারই দেখতে পাবো না, এই সব দুশ্চিন্তা করে সে সুইসাইড করলো। সুইসাইড না করে সাহস করে যদিও যেত, চিকিৎসা করত, তাহলে নিশ্চয়ই সুস্থ হয়ে যেত। আজকে এখনো ভারতবর্ষে এই সাপে কাটে, অনেকেই চন্দ্রবোড়া কেটেছে, তারপরেও ওঝাদের কাছে যাচ্ছে কিংবা মন্দিরে গিয়ে মানত করছে। আমি বলি আগে তোমরা ডাক্তারের কাছে যাও, এনআরএসে যাও, যদি গরিব মানুষ হও, পিজিতে যাও, গিয়ে ডায়ালিসিস করো, নিশ্চয়ই সুস্থ হয়ে যাবে। যারা দেরি করেছে 12-14 ঘন্টা ওঝাদের পেছনে, তারা কিন্তু বাঁচেনি। আমার চোখে এরকম অনেকগুলো কেস স্টাডি করেছি। তো তোমাদের যারা এসেছেন আজকে, বা তোমরা আপনারা সবাইকে বলি, আপনারা এই BDCON 2026-এর দ্বারা লাভবান হন, সমৃদ্ধ হন এবং মানব সেবার কাজে ব্রতী যেমন হয়ে আছেন সেই কাজটি করে যান যতদিন জীবিত থাকবেন, যাবৎ জীবেত। এটুকু বলে শেষ করি। শ্রী ভগবান আপনাদের সকলকে আশীর্বাদ করুন। এখানে ছবি আছে অমৃতানন্দময়ী মায়ের, ওরা অনেক ভালো কাজ করেন। ওদের নামে যে হাসপাতাল আছে কেরালায়, দেখার মতো। আমাদের একজন সন্ন্যাসী মহারাজ এক সময় অ্যাটেম্পট অফ মার্ডার হয়েছিল, ওর উপরে খুনের চেষ্টা করেছিল, রাস্তায় পড়েছিলেন। মানুষরা ওই হসপিটালে নিয়ে যায় কেরালায় এবং তিনি দ্রুত আরোগ্য লাভ করেন। এখন একবারে ফুল স্ট্রেংথ নিয়ে কাজ করেন। উত্তরকাশীতে থাকেন উনি, জ্যোতির্ময় মহারাজ, বাঙালি সন্ন্যাসী, কিন্তু সুন্দর চিকিৎসা হয় সেখানে। লিম্ব ট্রান্সপ্ল্যান্টেশন হয়, হাত পা এইসবগুলো নতুন করে ট্রান্সপ্ল্যান্টেশন হয়, খুব ভালো কাজ হয়। এই কাজকেও, ওর কাজকেও আমি খুব সাধুবাদ দিই। ওই রকমের কাজ গিয়ে দেখতে হয় ওই হসপিটালে, সত্যি ভালো কীরকম কাজ হচ্ছে। আজকে পৃথিবীতে অনেক ভালো কাজ হচ্ছে, অনেক মন্দ ঘটনা ঘটে, কিন্তু এই গাছের পচা ফলগুলি দেখে গাছের দোষ দিলে হবে না। মানুষ নষ্ট হয়ে গেছে, 5টা মানুষ খুন করছে বলে 95টা মানুষ তো খুন করে না। সেই ভালো মানুষগুলো ভালো কাজ করছে, সেটা দেখে একটু অ্যাপ্রিসিয়েট করা দরকার। এই অ্যাপ্রিসিয়েশন নেই বলি অনেক সময় আমরা ভালো কাজ অনেক সময় করতে পারি না। আমার কাছে অনেকে বলে মন্দ কাজ করে তো মানুষ কাটিয়ে দিচ্ছে, মন্দ কাজ করে তো অনেক টাকা রোজগার হচ্ছে। হ্যাঁ হয়, কিন্তু বেশি দিন হয় না, বেশি দিন হয় না। সেই জন্যেই ভালো কাজ করে যেতেই হবে। টু ডু গুড অ্যান্ড টু বি গুড ইজ দি হোল অফ রিলিজিয়ন, স্বামী বিবেকানন্দের কথা। সকলকে আবার নমস্কার, শুভেচ্ছা, শ্রদ্ধা জানাই।
Thank you, sir, for your warm and inspiring words. Your thoughts remind us of the purpose that brings us here today. Thank you all to our distinguished guests. There is a simple thought that captures the spirit of medical conference. Behind every number is a patient, behind every patient is a person, and behind every clinical decision is a responsibility. May BDCON 2026 help us convert better science into better decisions and better decisions into better lives.
Every memorable occasions deserve to be preserved, not only in our hearts but also in the pages of time. A souvenir is more than a collection of pages. It is reflection of our shared journey, our achievements, our memories, and the spirit of this gathering. It is now time to unveil this cherished memento of our event. May I request our esteemed dignitaries and our respected guests to kindly join us on the stage for the release of the souvenir. Ladies and gentlemen, let us mark this special moment with a warm round of applause. Please give a warm round of applause once again. A lifetime of dedication cannot be captured in a single moment, nor can a legacy be measured by words alone. Today, we celebrate a journey of excellence, commitment, and countless contributions that have inspired generations and generations. To honor a lifetime of excellence and dedication, may I now invite Dr. Taraknath Chattopadhyay sir to kindly come forward and present the Lifetime Achievement Award.
Good evening to everyone. স্বামীজির কথাবার্তা শুনে মানে মন একদমই শান্ত। সকাল থেকে যে উদ্বেগ ছিল, আমরা এতক্ষণ ধরে যেভাবে দুদিন ধরে আমরা যেভাবে পরিশ্রম করে সব কিছু করেছিলাম, তার মধ্যে মধ্যে একটা উদ্বেগ ছিল, সব কিছু ঠিক করতে পারবো তো, সব কিছু ঠিক হবে তো। ওনার কথা শুনে মনে একটা অদ্ভুত প্রশান্তি এলো। না, আমরাই পারবো, আমরা পারবই, দুটোই। এই ধারণা মাথায় নিয়ে এর পরের যে সবথেকে ইম্পর্টেন্ট জিনিসটা আমরা করতে চলেছি সেটা হচ্ছে লাইফ টাইম অ্যাচিভমেন্ট অ্যাওয়ার্ড। A lifetime achievement award is given to the person whose life inspires many young generations. For this year, we are honored to present this lifetime achievement award to Dr. Bidyut Boron Senapati, former physician, West Bengal Health Service. Dr. Senapati, ekdom, he deserves that. Dr. Bidyut Boron Senapati is a distinguished physician whose illustrious career has been marked by dedication, compassion, clinical excellence, and selfless service to the people of West Bengal. He completed his MBBS from Calcutta Medical College, followed by Diploma in Pediatrics from Calcutta and MD Medicine from Calcutta Medical College, reflecting his strong commitment to academic and professional excellence. Dr. Senapati joined the West Bengal Health Service in 1982 and began his service at our own Durgapur Subdivisional Hospital. Over the course of his long and distinguished career, he devoted himself to patient care, medical service, and the advancement of healthcare, earning the respect and the affection of generations of patients and colleagues. His unwavering commitment to the medical profession, human approach to the patient care, and decades of dedicated service made him an inspiring figure in the medical community. In recognition of his outstanding contribution to healthcare, exemplary professional service, and lifelong dedication to this medical profession, we are deeply honored to confer upon the Lifetime Achievement Award. I will now sincerely request, sir, to please come on the dais, and I will request our BDF chairman, Dr. Amitabh Bishwas, to kindly felicitate him. Swami Dibbanandaji Maharaj, please give our blessings to Dr. Senapati and all through your blessings. May I request Dr. Senapati to please say a few words to us.
Lifetime Achievement Award has been given to me. I am glad to receive it. I feel honored too. But I don't know what extraordinary job I have done and why I have been selected for the award. Thanks to BDCON Society, thanks to Dr. Amitabh Bishas, thanks to Dr. Shubham Das, thanks to Dr. Taraknath Chakraborty. I want to say a few words which I want to share with the doctors. Here are many doctors. I completed, after completing my academic career, I started my professional career in the year 1982 and 83. Most of the young doctors were not born then. And in the 80s, what was the status of medical practice, I have seen, and I want to share with you. In those days, the common illness, like the common acid peptic disorder, only the liquid antacid was there. There was no H2 blocker, no PPI, nothing. And simply in case of bronchial asthma, we have this inhaler, only this Decadron, Derifylline, Solvitamol. For the diabetic patients, there are few diabetic patients and few diabetic medicines. For the treatment of hypertension, only the centrally acting antihypertensive drugs were there. And of the beta blockers, only atenolol was there. And that was the picture in the 1980s. Now, this is 2026. Here a lot of change and in the medical practice. Now that it is seen that the knife has been taken away from the hand of the surgeon and it has gone to the hand of the robot. Now, ultimately, the stethoscope will be taken away from the physicians. It will go to the hands of AI. Few days before, I got a phone from a Bangalore engineer. He is a computer engineer. He stays in Durgapur. He told me that I am getting chest pain. So I told him that you go and consult with a doctor, better cardiologist. He told me that no, I have consulted with the AI and AI has told me that this pain is not due to heart. I was like, okay. Then he asked me what to do. I did not tell him that you ask your AI what will be the medicines. I gave him some suggestions that you take some antacid tablets and all these things. He was telling so confidently that AI cannot make any mistake. I was astonished. And ultimately, these days may come, I am afraid. Suppose a patient gets pain abdomen, he will go to the AI and AI will say you have got a stone in the gallbladder, then he will go to the robot and get the surgery done. Then where will be the need of the doctors? And ultimately, the doctors will be called the bioengineers. And these days may come after 10, 15 years like that. And there are so many medical colleges are coming up, so many medical students, seats are there. Will those seats be remain vacant like the engineering seats? I'm afraid. But I think, my opinion, the clinical medicine will remain, and let us see what happens in the next future, 10 years, 15 years, 20 years, like that. Thank you very much. This is my personal opinion.
Thank you, sir. A successful gathering is made possible by collective efforts of many. To acknowledge and thank all those who have contributed to this memorable occasion, may I now invite our organizing secretary, Dr. Taraknath Chattopadhyay, sir, to deliver the vote of thanks.
শুভম দা পাশে থাকো, কাকে কাকে থ্যাঙ্কস জানাতে ভুলে যাব। So, now it's my honors to give the vote of thanks of this inaugural ceremony. Respected Swami Divyanandaji Maharaj, Vice President of Ramakrishna Mission, our organizing chairperson, Nilanjan sir, our Secretary General, Shomik sir, Chairman of the BDF, Dr. Amitabh Bishwas sir, all the distinguished guests, delegates, and friends. Good evening to all of you. It's my privilege to rise and offer a few words of gratitude as we conclude the inaugural session of this Bengal Diabetes Conference 2026. At the very outset, I express my deepest gratitude to Swami Divyananda Maharaj, Vice President of Ramakrishna Mission, for gracing this occasion with his presence and blessing us with his inspiring words. His presence has added a spiritual depth to this scientific gathering, reminding us that the pursuit of knowledge and the service of humanity go hand in hand. I'm equally grateful to our organizing chairperson, Nilanjan sir, whose vision and tireless guidance have been the driving force behind the conference. Sir, your leadership has shaped this event from concept to reality. I thank our Secretary General, Shomik sir, for his continued guidance and for the lending his strength of the parent organization to this conference. I thank the Chairman of BDF, Amitabh sir, for his valuable support and association with this initiative and for his commitment to the cause of diabetes care in West Bengal, specifically in Durgapur. I also thank all the sponsors of our event and all the persons who are working behind the scenes to make this inaugural program a successful event. No scientific conference can achieve its purpose without the generous support of our industry partners who share our vision of advancing diabetes care and education. I take this opportunity to thank all of them from the deepest core of my heart. I also take this moment to award in recognition of their outstanding support to some of the pharmacological companies. I cannot list all of them. To all our delegates, faculty, volunteers, thank you for being there and making this inauguration a success. I now request everyone to join us for the scientific sessions ahead. Thank you. I will now request Shomik sir to felicitate Dr. Senapati sir.
May I kindly request all our esteemed dignitaries and honored guests on the dais to please take their seats and make themselves comfortable as we proceed with the another sessions. We are delighted to have shared these memorable moments together And now it is time to turn our attention back to the heart of this gathering, the exchange of knowledge and ideas. Let us now resume our academic session. I request everyone to kindly take their seats and join us for the next academic session. Our next session is on mental health assessment in obesity. I would like to call Dr. Imon Pal on the stage for the session.
Good evening, everyone. At the very onset, I would like to thank to the organizers for this meticulously organized academic extravaganza. It has been a privilege and an honor to be here. So a heartfelt thank you to them. I think I'll keep it brief. We have just had the inaugural session, so let us focus on something which is a bit different. Mental health assessment in obesity. So in the previous sessions, session, we have already discussed about obesity. So slides progress kochana. So obesity is a chronic relapsing multifactorial disease which is characterized by excess adiposity impairing health. This has been discussed in our previous presentations, but the point to note is that it is being increasingly conceptualized as a chronic disease which requires long-term management, not simply as a risk factor or a lifestyle choice. So the relationship between obesity and mental illness is bidirectional. So obesity causes inflammation, it causes stigma and discrimination, it increases the chronic disease burden, it causes sleep disruption, and it reduces physical activity, which in turn leads to or predisposes to mental illness such as mood and anxiety disorders, eating disorders, and even psychotic disorders. On the other hand, if we have mental illness, then psychotropic induced weight gain, hyperphagia or binge eating, reduced activity from anhedonia, sedentary illness, course, all of these again work by increasing a predisposition for obesity. So it is a bidirectional relationship. If we look at the neurobiology, the shared mechanisms are the HPA axis dysregulation, inflammatory cytokines, dopaminergic reward pathway dysfunction, and there is a genetic and epigenetic overlap. So the relationship is not only cyclical, it is also self-reinforcing. So this is, in a very simplified form, obesity. This causes the psychological effects will be low self-esteem, social isolation, bullying, negative perception of self, lower school performances, which in turn will worsen the mental health. It is not only a problem of adults. Obesity is increasingly seen, as Pujaniya Maharaj Ji was saying, in young children also. So, and it harms children and young people. There are emotional and behavioral consequences like bullying in school, low self-esteem, stigmatization. They start refusing, so there is school refusal. It predisposes to a lot of physical illnesses and increases risk of becoming overweight as an adult and premature mortality. So in a nutshell, this is the brain pathways involved in overeating. If we look at the brain, the reward center is the nucleus accumbens, which is mediated by the dopamine. So dopamine and VTA in the ventral tegmental area is the reward pathway. What happens in obesity when there is overeating, the prefrontal cortex and the cingulate gyrus, this is supposed to act as inhibitory mechanisms, but this stops acting. So there is a reduced ability to regulate the compulsive drive to eat, and then this behavior is driven by relationship between noradrenaline and the memory areas of brain. So these are some of the psychiatric disorders associated with obesity, with major depressive disorder, anxiety disorders, ADHD, psychosis, substance use disorders, eating disorders, as well as sleep disorders. So a comprehensive health assessment, which is the topic for today, should focus in what is the presenting complaint, what is the weight history, what is the eating behavior, then the psychiatric disorders per se. You should take a detailed history for that. Other than that, a cognitive assessment, personality traits, the social supports, suicidality assessment, functional assessment, these are also very important. So we come to the presenting complaint and the weight history. So the reason for coming to a psychiatrist may be manifold. It may be before a bariatric surgery evaluation because it is mandated. It may be a primary psychiatric complaint or a weight-related distress. So it is necessary to assess the patient's own understanding of and goals for the consultation and the onset and course of current symptoms in relation to the weight change. For the weight history, what was the age of onset? Whether it was a childhood onset or adult onset obesity, what has been the trajectory of weight over time, if there have been any prior weight loss attempts, what is the pattern of weight cycling, if it is coinciding with any life events like pregnancy or trauma or any kind of job loss. So it is important to assess these things. Then the eating behavior. So what is the meal pattern, number, timing, regularity, portion sizes, any snacking or grazing behavior, whether the person gets up at night to snack or not, whether it is triggered by any kind of emotions like stress, boredom or negative affect, and distinguish between overeating versus loss of control eating. So there can be various screening tools which can be used for these. So but these are the points that should be kept in mind while taking history. With mood disorders, particularly depression, the relationship of obesity is well established and it is bidirectional. It is also important to remember that generally we think that depression, the appetite is reduced, but it might not be so. In atypical depression, rather there is hyperphagia and weight gain and there is latent paralysis. So having an increased appetite does not rule out depression. And it is important to screen for the temporal relationships, that did the mood symptoms precede or follow the weight gain. Among anxiety disorders, generalized anxiety disorder has a clear relationship. In social anxiety, the anxiety is often related to weight-based social avoidance, and there is health anxiety can be there around obesity-related medical complications. So again, this is a vicious cycle in depression mediated by inflammatory cytokines and cortisol. Whereas in social anxiety, there is an excessive body weight, then there is an HP axis dysfunction, oxidative stress, insulin resistance, the gut-brain axis gets disrupted, sleep disturbance, maladaptive eating behaviors, all of which can predispose to anxiety disorders. This is the one condition which has the clearest association with obesity and mental health, binge eating disorder. So binge eating disorder is characterized by eating unusually large amounts of food in a specific and short period of time, even when you are full. You keep on eating, and there is a subjective sense of loss of control, that I know that I cannot stop and I go on eating. So it is differentiated from bulimia because there is no purging. It is differentiated from anorexia, there is no restriction. So this is the one condition which is most closely related with obesity. And there is marked distress regarding the binge episodes. It is regular in occurrence and it is associated with higher psychiatric comorbidity. In sleep disorders, obstructive sleep apnea, it has become very common. So one of the questionnaires which can be routinely done in clinical practice is the stop bang questionnaire. S is for like, have you ever, it's a very simple questionnaire that, do you snore? Have you ever, like, have others observed you choking or gasping during sleep? Do you have hypertension? Do you, is your BMI greater than 35? Is your neck circumference more than 16 inches? Do you belong to the male gender? So these are questions that can be assessed because these predispose the person to obesity as well as psychiatric concerns. So this is the neurobiology of OSA, which causes intermittent hypoxia and sleep fragmentation, leading to obesity, leading to changes in the molecular level and causing metabolic syndrome. Among substance use, alcohol use is important to remember because it causes significant caloric contribution and disinhibition of eating behavior. For nicotine, weight gain concerns are a common barrier to smoking cessation. People will often say that cigarette bondo korle khide bere jaye, so I will not stop smoking. And there is stimulant misuse for appetite suppression. Cannabis has an appetite stimulating effect. So substance use must be screened. It is also important to assess the cognitive assessment and personality traits. Cognitive assessment because the ability to plan, to exercise informed decision making might be impaired in cases with obesity. There might be impulsivity and food-related attentional bias. People who are more impulsive and who have emotional dysregulation, who are of avoidant or dependent types, and who focus on coping in an emotional way are more likely to overeat and hence become obese. Body image and weight stigma is another issue because the degree of body dissatisfaction and its impact on mood and self-esteem has to be assessed. This can persist even after significant weight loss. Even after weight loss, you might still feel, because in your mind you are still fat, and that causes a significant amount of distress. So this is weight stigma, which is a silent thing, but it is encountered in all phases. In healthcare, from family members, from social groups, from media, schools, workplace, there is a certain pressure to look a certain way, and if you do not conform that, there is a stigma. So even when patients come to us, there is a clinician weight bias also, because you tend, for an obese patient, you tend to have negative stereotypes, use insensitive language and banal weight loss advice, and the patient reacts by feeling disrespected, feeling blamed and judged, and having lower trust in healthcare professionals, which in turn affects the patient care by having a poorer patient-clinician communication and a reduced quality of care. Suicide risk assessment is extremely important, particularly after bariatric surgery, because elevated suicidal risk has been reported in quite a few studies, and the risk factors are pre-existing psychiatric illness, unrealistic expectations, and post-op alcohol misuse. So this requires a longitudinal monitoring. It is important to assess the functional status and social support, how the person is functioning occupationally, are there any major limitations, what is the caregiver burden, the quality of family and relationship support, or whether the patient is isolated. When we talk about medications, there's a common misperception that psychiatric medications cause weight gain. That is true for certain medications. Some of the high-risk medications which can cause weight gain are clozapine, olanzapine, mirtazapine, lithium, valproate, and TCAs. Drugs with a moderate risk of causing obesity are quetiapine, risperidone, paroxetine, and gabapentin. Whereas if you want something weight neutral, it is better to go for aripiprazole, ziprasidone, lurasidone, bupropion, or fluoxetine among SSRIs. So, before bariatric surgery, this is another thing where psychiatric assessment is mandated. So the domains which should be assessed are current psychiatric status and stability, the eating pathology, substance use history, cognitive capacity to understand risks and benefits and to provide informed consent, the ability to adhere to the demanding post-op regimen, and the social support. The contraindications are active untreated substance use, unstable psychosis, active suicidality, or severe untreated eating disorder. If we look at, this was in brief the assessment part. If we look at the management approach, there should be a multidisciplinary team. Psychotherapy is one of the mainstays. Pharmacotherapy, we should choose weight neutral or weight loss promoting psychotropics. Address the stigma, lifestyle integration is important, and ongoing monitoring is also needed. So I thought I'll just share about the behavioral treatment of obesity, because this is what we all can do in routine clinical practice. The principles are, these are based on classical conditioning. For example, if we are eating while watching TV repeatedly, this behavior comes associated with watching TV. So even when you are not hungry, over time, one cue will trigger the other. So when you are sitting in front of watching a match, you will crave something, a chips or something salty or something like that. Then there is reinforcement. Obviously, behaviors which are followed by pleasant consequences will be repeated, and negative consequences like exercising will cause exhaustion. So you will avoid that. Cognition, once you start having these thoughts that I have blown my diet, so I'd better eat anything that I can. So this will, again, it is like a vicious cycle. So the ABC model is the antecedents, the behaviors, and the consequences. So what happened, what led to this behavior, and how can you identify this? So for example, it is a chain of events. You buy cookies, you keep it on the kitchen, then you are home on a Saturday evening, you are tired and bored, you have the urge to eat, you go to the kitchen, you take cookies to your living room, you eat while watching TV, you eat rapidly while you are full, then you feel guilty and a failure, then you feel that anyways my restraint is always weakened, and you go on eating more. So one of the things to break that is self-monitoring. So maintain a food diary, the caloric content, which will help you identify what are the previously unrecognized patterns, the hidden calories. And frequent self-monitoring correlates with a greater long-term weight loss. Secondly, it is cognitive restructuring, where the thoughts are taught to be changed by methods like CBT. So this is the behavioral modification approach. So finally, the take-home message will be obesity and mental illness share a bidirectional and self-reinforcing relationship, so it is important to screen in both directions. A comprehensive psychiatric assessment must be multidimensional. Mood, eating behavior, sleep, cognition, and social context all matter. Routinely screen for depression, binge eating disorders, sleep disorders, and suicide risk in every patient with OCD. Medication choice matters. Weigh metabolic risk when selecting psychotropics. For bariatric surgery, a pre-surgical psychiatric evaluation is essential to optimize the outcomes and safety. Thank you. That was it.
Thank you, ma'am. Now I would request Tarok sir to felicitate ma'am at the side desk. Everyone, please give her a warm round of applause.
I'd like to call the photographer.
The impact of obesity extends well beyond the weighing scale, affecting almost every organ system. Identifying and assessing its associated comorbidities is essential for accurate risk stratification and optimal management. For this session, I invite Dr. Arindam Kumar Hajra sir, Consultant of Critical Care Medicine of Healthford Hospital, and Professor Shamul Kundu sir, the HOD of Bakura Samminali Medical College, as the chairperson for the next session.
Our speaker, Dr.
to pre-hypertension, borderline hypertension, and you can see an increase in sympathetic nervous system activity when hypertension sets in, mild to moderate, complicated, severe, and when it is difficult to treat hypertension or resistant hypertension, you can see the sympathetic nervous system is the maximum. So all this, I mean, if you have sympathetic nervous system activity along with any level of hypertension, we have vascular, cardiac, renal and metabolic target organ damage. Now, what is the hypertension metabolic nexus? So 60 to 80% of patients with diabetes also have hypertension. And traditional beta blockers are associated with worsening glycemic control, dyslipidemia, new onset diabetes and weight gain. And that is a major reason why, because of this metabolic penalty, it led to the progressive demotion of beta blockers in hypertension in guidelines over the last 2 decades. So you can see with JNC 7 in 2003, beta blockers were still the first line along with diuretics. But what happened with the next set of guidelines which came in AHA ACC 2017, they were no longer the first line. They somehow recovered their position somewhat in European Society of Hypertension Guidelines 2023 because they were reinstated as the 5th class, thereby leaving it to the physician in question to choose it whenever he or she would think that the patient has a raised heart rate, so beta blockers can be added. But again, ESC, another segment of ESC, European Society of Cardiology, very next year, again went back and restricted beta blocker use to only compelling indications. And finally, in 2025, ACC, AHA again relegated beta blockers to the second line. Of course, they left it open to the physicians, but mainly they were, after CCBs, RAS blockers and diuretics, beta blockers were placed as the second line. So, progressive demotion based primarily on derived data from live ASCOT BPLA trials. So, what have been the concerns with beta blockers? Beta blockers remain essential in diabetes when indicated, as you know, in post-MI, heart failure, rate control, hypertension with CV risk, and their CV benefit in this category of patient often outweighs metabolic concerns. So what have been the metabolic concerns? Beta blockers can mask adrenergic symptoms of hypoglycemia, namely tremor and tachycardia, while sweating often remains intact. Some beta blockers, especially the older ones like atenolol and metoprolol, have adverse metabolic effects, reduce insulin sensitivity or increase oxidative stress. And observational data suggests beta blocker use in diabetes is associated with higher risk of severe hypoglycemia and CV events in certain contexts. So the major point of objection is that extrapolation of atenolol or metoprolol data to the entire beta blocker class is basically scientifically flawed. Because beta blockers are not a monolithic class. There is a profound difference that exists across the class in terms of receptor selectivity, beta 1, beta 2, alpha 1, and now of course beta 3 profiles which vary dramatically. Vasodilator capacity from none to alpha 1 blockade to nitric oxide mediated vasodilatation, metabolic effects which can be harmful with the older set of beta blockers to neutral to ultimately, as I am going to show with the newer beta blockers, they can be favorable, and clinical outcomes cannot be assumed to be uniform with all beta blockers. So here is the timeline of evolution of beta blockers. You all know it. So the latest of the beta blockers is a selective vasodilating beta blocker, that is nebivolol. Of course, carvedilol and labetalol, they also vasodilate, especially carvedilol, but that is by way of alpha 1 blockade. But nebivolol per se, by beta 3 stimulation, is a selective vasodilating beta blocker. So I would like to reiterate that not all beta blockers are same, and nebivolol exists in 2 types of isomers, the levo and the dextro isomers. So nebivolol has a unique pharmacological profile. So nebivolol, as I said, through beta-1 stimulation, they decrease heart rate, and contrary to the older generation beta blockers, they can increase cardiac output and stroke volume. They improve diastolic function and reduce vascular resistance. This is by way of promoting endothelial nitric oxide synthesis, which converts L-arginine to nitric oxide. And the end result is that there is reduced oxidative stress, increased nitric oxide bioavailability, that translates into decreased apoptosis, improved protection against ischemia, and increased mechanical efficiency of contraction. Now the effect is also on the blood vessels, again improved endothelial availability of nitric oxide that results in decreased peripheral vascular resistance, increased vasodilatation, and improved endothelial function. It is the dextroisomer which acts more on the heart and the levoisomer that acts more on the blood vessels. So receptor selectivity and blockade you can see amongst all the beta blockers in terms of beta-1 to beta-2 selectivity ratio, nebivolol has the highest selectivity. And if you give propranolol 1 as the standard, then betaxolol, bisoprolol and nebivolol has the highest beta-1 selectivity, that is 10 times more than propranolol. And this is a pattern of nitric oxide release from endothelium studied from the human umbilical vein endothelial cells. You can see there is a boost in nitric oxide concentration with use of nebivolol from the endothelium. And if you compare with placebo and bisoprolol, nebivolol has a significant nitric oxide mediated vasodilatation through nitric oxide synthesis boosting. Compared to older generation and non-selective beta blockers, nebivolol improved endothelial function through nitric oxide mediated vasodilatation by acting on specific beta-3 receptors. Now, as I said, carvedilol also vasodilates, but that is through alpha-1 adrenergic receptor blockade, and it is largely endothelium independent. On the other hand, nebivolol does it through beta-3 receptor agonism, through stimulation of the endothelial nitric oxide synthase, and so it is the endothelium dependent vasodilatation. Does it have a significance? Very much. Endothelial dependent vasodilatation is important for endothelial function, reduction of oxidative stress, and very importantly, which pertains to the basic goal of this conference itself, metabolic outcomes. How? So high beta-1 selectivity, nitric oxide mediated vasodilatation, beta-3 receptor agonism. I have spoken about all this. Look at the right hand side. Antioxidant and endothelial protective effects. Reduced oxidative stress by lowering reactive oxygen species in the vascular tissues. It enhances eNOS expression or activity, thereby improving endothelial function. And very importantly, for all diabetologists here, in models of insulin resistance or obesity, nebivolol improves insulin signaling in endothelial cells, reducing endoplasmic reticulum stress and restoring all these pathways, IRS1, P13K, AKT, eNOS pathway, and all this activation of these pathways ultimately leads to reversal or reduction of insulin resistance, the key primary pathology in both hypertension and diabetes. So nebivolol has levo and dextroisomers. I have already told you, levo mainly acts on the blood vessels, decreasing PVR and blood pressure. On the other hand, the dextro acts on the heart, decreasing heart rate and improving stroke volume and cardiac output, thereby improving organ and peripheral perfusion. So this becomes very effective in terms of treatment of hypertension, heart failure, coronary artery disease, and very importantly, in the perspective of this conference, diabetes and metabolic abnormalities. It is safe in COPD, and it does not also cause erectile dysfunction because of its ANO-mediated vasodilatation. So, in patients who require dialysis, again nebivolol has an advantage. It is the only beta blocker which is non-dialysable. As you know, metoprolol and atenolol are highly dialysable. Bisoprolol is moderately so, and carvedilol is least, but nebivolol is not dialysable at all. So it is the only non-dialysable beta blocker which can be preferred in CKD patients who need dialysis. So as I told you, beta blockers are not a monolithic class. In terms of PVR, nebivolol decreases it, atenolol and metoprolol increase it. Stroke volume increased with nebivolol, decreased with atenolol and metoprolol. Ejection fraction increased with nebivolol, decreased or unchanged with older beta blockers. Cardiac output maintained with nebivolol, decreased with atenolol. So you have PVR decrease on one hand and increase in stroke volume on the other hand. So the action, despite being a beta blocker, action of nebivolol is something akin to RAS blockers, that is ACE inhibitors and ARBs. So it is beta blocker plus RAS blocker action put into one when you use nebivolol in a given patient. Nebivolol hemodynamic signature resembles ACE inhibitors or CCBs more than traditional beta blockers. So here is a side-by-side comparison. Much has been said, so I will not waste time again on this. What about the clinical evidence? Here is the comparative effectiveness and outcomes of nebivolol versus other beta blockers in patients with hypertension. A very, very recently published trial in Journal of American Heart Association, 2026. So this is a very large multi-center retrospective cohort from Taiwan. Look at the number of patients, close to 1 lakh patients, follow-up of mean 4.5 years, nebivolol versus carvedilol versus other beta blockers. Primary outcome was a change in systolic and diastolic blood pressure and heart rate, and secondary outcomes were all-cause mortality and major adverse cardiovascular events. So one of the largest real-world beta blocker comparative data sets, as I told you, 1 lakh patients nearly. So look at the systolic blood pressure, highest with nebivolol -11, carvedilol and other beta blockers -6.8, very significant p-value. Diastolic again -8.1 with nebivolol, -5.4 with carvedilol, other beta blockers -5.8, again a very significant p-value. And heart rate -7.3 with nebivolol, -2 with carvedilol and -3.6 with other beta blockers, again very significant p-value. And so greater BP and heart rate reduction versus comparators sustained over 4.5 years and all statistically significant changes. What about the secondary endpoints? Very, very importantly, the hardest of all endpoints, all-cause mortality was found to be lower with nebivolol, -27%. And in terms of MACE, decreased by 19%. Though this is very, very significant indeed, although this is a retrospective data, but seeing it over 4.5 years among 1 lakh patients is very, very significant indeed. No significant difference in the individual endpoints of MI, stroke and heart failure hospitalization, but never mind, the hardest of endpoints, all-cause mortality, was still reduced. And this effect was maintained across diabetes status, CKD status and CAD subgroups. So the key takeaways from this large retrospective cohort was nebivolol is a strong candidate for hypertension without heart failure, patients needing better heart rate control, and those where vascular function matters. So why it may be different? It is just not a beta blocker, it is an endothelial modulator with a potential vascular protective effect. And these are the practical considerations where we see not only superior reduction in blood pressure and heart rate, but are trained towards decrease in all-cause mortality and decrease in MACE. And when talking about beta blockers, because one of the reasons of relegating beta blocker to the second line was an increase in stroke, because beta blockers was said to not decrease central aortic pressure or somehow increase it. But look at a comparison with atenolol, because much of the disrepute that beta blockers were associated with came from atenolol. Both nebivolol and atenolol reduced pulse wave velocity to the same extent. But look at the augmentation index. Augmentation index with nebivolol, it came down from 35 plus minus 5 to 28.2, significant p-value, and that is the reason that central aortic pressure is lowered with use of nebivolol, but not so with atenolol. So in terms of arterial stiffness and vascular remodeling, it is superior to atenolol because it improves small artery distensibility and better oxidative stress. Superior to metoprolol in terms of central systolic, diastolic blood pressure and pulse pressure, and reduced LV wall thickness in a 12-month trial. And obviously, if central aortic pressure was reduced, there would be a regression of left ventricular hypertrophy. This is the use of nebivolol in younger subset of patients where it was found to be very effective, both double-digit reduction in systolic and diastolic blood pressure in younger patients less than 55 years of age with primarily diastolic hypertension. And this is a replication of the same data from Benefit Korea study from South Korea, where higher SBP and DBP reduction was observed in the younger population with use of nebivolol. Why clinicians generally avoid beta blockers is because of the potential of metabolic harm, because there is a decrease in cardiac output, increase in PVR, decrease in skeletal muscle blood flow, and ultimately decreased glucose uptake. And there is associated consequences of worsened insulin sensitivity, dyslipidemia, weight gain, and new onset diabetes. This metabolic penalty does not apply to vasodilatory beta blockers, especially nebivolol. It is a Yestono study in patients of hypertensive patients with type 2 diabetes. You look at the metabolic parameters, there was a decrease in fasting glucose, decrease in HbA1c, decrease in total cholesterol, decrease in LDL cholesterol, improvement in HDL cholesterol, and decrease in triglycerides. So nebivolol is not only metabolically neutral, but it is metabolically better compared to other beta blockers. There can be some favorable effect on metabolism which comes out of nebivolol use. And when it comes to greater exercise capacity also, because of its vasodilatory potential, there is an improvement in exercise capacity in terms of all these parameters. As you can see, after 3 months, there was a boost in exercise or sporting capacity with the use of nebivolol. Versus metoprolol, you see in terms of insulin sensitivity, nebivolol in contrast to metoprolol improved oxidative stress, insulin sensitivity, decreased plasma soluble P-selectin and increased adiponectin levels in hypertensive patients. These beneficial effects of nebivolol may contribute to a reduction in CV risk in hypertensive patients. Now versus carvedilol in non-diabetic heart failure patients, in terms of HOMA-IR, it was decreased by 11.67% with nebivolol, increased 4.58% with carvedilol. So even versus so-called metabolically favorable carvedilol, nebivolol is superior. Glucose neutrality in prediabetes, you can see that it is safe add-on therapy in patients at risk for diabetes progression versus hydrochlorothiazide. So in terms of blood sugar, lipid profile and triglycerides, nebivolol has no adverse effects as compared to atenolol, which has an adverse profile. So again, a repetition of all the facts that I have mentioned. So unlike other beta blockers, nebivolol doesn't lead to new onset diabetes but improves glycemic control, improves endothelial function compared to bisoprolol, and there is no new risk of new onset diabetes with the use of nebivolol. That is a major important point whenever one is using nebivolol or any beta blocker in a young obese hypertensive. And of course there is the improvement in endothelial function, which I have mentioned again and again. So this is an effect on obesity, no adverse effect on weight, lipids and carbohydrate metabolism in patients with obesity as compared to traditional beta blockers. and enhanced nitric oxide bioavailability in corpus cavernosum, so there is no effect on erectile function as well.
Dr. Kumar, please wind up.
So I have told you the position of beta blockers already. So when to choose nebivolol? In hypertension plus diabetes or prediabetes or metabolic syndrome, hypertension plus obesity, hypertension plus erectile dysfunction, hypertension plus elevated heart rate, hypertension plus endothelial dysfunction, and heart failure more than equal to 70 years of age as per the Senior's trial evidence. I did not touch upon this trial because my talk was dedicated to hypertension with or without diabetes, but that is another very important trial in favor of nebivolol. So the key takeaways, ladies and gentlemen, beta blockers are not all the same. Class heterogeneity is clinically meaningful. Negative reputation derived from the old beta blockers data should not be extrapolated to newer vasodilating beta blockers like nebivolol. It offers highest beta-1 selectivity because of its NO-mediated vasodilatation, metabolically neutral to favorable. In the recent big retrospective data, it was shown to have a mortality benefit signal, and Senior's trial only beta blocker with CV outcome evidence in elderly, significant p-value as you can see, and it prevents erectile function, so can be used very conveniently in younger hypertensives. So nebivolol is a preferred beta blocker across the hypertension spectrum, from metabolically vulnerable to vascular phenotypes which have endothelial dysfunction. So just an invitation for this conference, ICAR Conclave 2027, in its second version. The first version was hugely successful. It is a unique platform for cardiologists, researchers, academicians and healthcare professionals to share India-centric research, explore innovations, enhance knowledge and shape the future of cardiovascular care. Please block your dates, 8th to 10th of January 2027 at Hotel Hyatt Regency, Kolkata. Thank you very much.
Thank you, Professor. Thank you, Dr. Kumar, for an excellent discussion on nebivolol, highlighting the different merits of nebivolol, which was often we are quite unaware. So, because of this shortage of time, we may not be able to take questions. Let us conclude this session.
Thank you, sir, for this wonderful session. Please, sir, kindly remain on the stage for the photograph. I would like to call Dr. Shomi Goswami, sir, on the side stage for the felicitations. Ladies and gentlemen, we now move to one of the distinguished academic highlights of BDCON 2026, the Dr. APJ Abdul Kalam oration. It's our privilege to welcome today's moderator, Dr. Nilanjan Sengupta sir and Dr. Taraknath Chattopadhyay sir.
At the outset, I thank Dr. Amitabh Vishwas for bestowing me the honor of chairing the prestigious APJ Abdul Kalam Memorial Oration, which will be delivered by none other than Professor Sanjay Vadada. May I request Professor Vadada to join me in the stage, and Taruk also, please join. He doesn't need any introduction, but still for the sake of formality, he is a professor and head Department of Endocrinology at PGI MER Chandigarh. Before he delivers his oration, may I request Dr. Taraknath Chattopadhyay, my co-chairperson, to read the citation and a brief intro about Professor Vadada first.
it's my honor to be able to come to this podium and be able to read the citation of one of the most prestigious faculty of this country. That's why this is the most prestigious honor we can offer on behalf of BDCON 2026, Dr. APJ Abdul Kalam oration. Dr. APJ Abdul Kalam oration is our homage to Bharat Ratna Dr. APJ Abdul Kalam, the inspiring Indian aerospace scientist who ignited numerous minds and served as the 11th President of India. Bengal Diabetes Federation is privileged and proud to confer Dr. APJ Abdul Kalam oration for 2026 to Professor Sanjay Kumar Badada, Professor and Head of the Department of Endocrinology at PGIMER, Chandigarh. A towering figure in Indian endocrinology, his areas of interest span metabolic bone disease and diabetes in the young, and he has led landmark work in primary hyperparathyroidism, osteoporosis, and rare metabolic bone disorders through Indian PHPT registry and the Rare Metabolic Bone Disease Registry as well, both pioneering self-sustained national initiatives that he conceived and continues to steward. His research contributions are prolific and wide-ranging, spanning over 250 publications in national and international journals, alongside authorship of key chapters in globally recognized textbooks, including William Textbook of Endocrinology. His work on novel therapeutic approaches from growth hormone therapy in fibrogenesis imperfecta osseum to total parathyroidectomy in tumor-induced osteomalacia reflects a rare blend of clinical acumen and translational insight that has advanced the understanding and management of metabolic bone disease in India and beyond. A dedicated mentor and institution builder, Professor Badada has led leadership positions across major professional bodies, including Indian Society of Bone and Mineral Research, the Endocrine Society of India, and the Association of Physicians of India, and has trained a generation of endocrinologists who now carry his legacy forward. His body of work embodies the very spirit Dr. Kalam oration seeks to honor: relentless inquiry, service to patient, and shaping of future minds. Now it's my privilege to announce the felicitation of Dr. Badada by none other than Professor Nilanjan Sengupta sir.
So, very good evening, and at the outset I would like to thank Bengal Diabetes Conference and Dr. Sengupta as well as Dr. Chattopadhyay, Dr. Somik and Dr. organizing committee for this opportunity to speak on a topic which is very close to my heart in the city of the steel city of Bengal. Maybe I am talking more about the steel of body related to the bone and diabetes. So, bone health in diabetes, generally we talk about the triopathy, that is microvascular complications, neuropathy, nephropathy and retinopathy. Maybe high time to call diabetic retinopathy in form of involvement of diabetes and bone health, because bone is another microvascular organ as per criteria on the basis of we call triopathy. So next 15 or 20 minutes what I am going to do is that I will try to answer these following questions. Does diabetes affect bone health? Why is the bone health poor in diabetes if at all? What is the pathogenesis? What anti-osteoporotic medication is preferred? And how do anti-diabetic agents affect the bone health? So look at this meta-analysis, and this meta-analysis clearly telling that individuals with type 2 diabetes with hip fracture, the risk is almost 1.2 times or 1.7 times. The situation in type 1 diabetes is really very, very bad, and that is approximately 6 times as compared to the normal individuals. So this particular meta-analysis clearly telling that bone health in diabetes is really very poor. This is one of the famous study initiated by the ICMR, that is ICMR INDIAB study. And this ICMR INDIAB study again shows that these are the self-reported fracture in the patients of diabetes, and you can see that the risk of diabetes and without diabetes the fracture risk is high. Here in non-diabetes 2.5% versus in diabetes 4%. Though this difference was not significant in the male individual, but it was clearly significant in the females about the risk of fracture is higher in the diabetic individuals compared to non-diabetic individuals. So now how hyperglycemia harms the bone. So this is a cartoon which is showing that healthy bone versus type 2 diabetic bone. So healthy bone is in all compartments much better than the type 2 diabetes individuals. You start with the adipocytes, so the much more bone fat is there in the bone marrow. There is number of osteoblasts is much better in the healthy bone as compared to type 2 bone. And then number of osteocytes, which is actually pituitary of the bone. So connectivity among osteocytes is much better in the healthy bone as compared to individuals with the type 2 diabetes. Then advanced glycation end product deposition is much higher as expected in type 2 diabetes. Risk of fall is much higher because of multiple reasons, drugs, hypotension and other. And the cortical porosity is much higher in patients of the type 2 diabetes as compared to the healthy bone. So basically, and this is the reason probably fracture risk is higher in the type 2 diabetes, but bone mineral density when we measure by the DEXA scan, it is not that high. It is higher or the normal as compared to the normal individuals in the diabetes versus diabetic individuals. So diabetes basically degrades every compartment of the bone, whether it is the cellular compartment, whether it is the collagen compartment, whether it is the bone marrow, etc. So look at the other direct studies from the hip fragility fracture. So this is a study which was conducted in PGI Chandigarh. 264 hip fragility fracture patients were followed up, and what we found is that at the end of 3 months there is mortality was much higher. There is 12% at the 3 months of follow-up of these hip fragility fracture patients. At the end of 12 months there is mortality is 21%, and this was directly diabetes was an independent predictor of the mortality. So fracture, not only the high risk of fracture in diabetes, but in addition to that, mortality is also much higher in patients of type 2 diabetes. So why this risk of diabetes is higher maybe in Indians as compared to the Western population? And this particular publication from our group is showing that Diabetes onset in India is younger age of onset. We have central obesity because of and higher insulin resistance and higher inflammatory markers. Ultimately, all these predisposes for the diabetic bone disease in Indians, which is much more as compared to the Western population. So, to understand that, if this is the problem, what is the mechanism? So, we did help of our colleagues from the IIT Ropar, and what we did in this particular study is that we collected the hip fragility fracture patients' hip, which is usually neck of femur, which is usually thrown after the hip replacement. So we collected all these neck of femur of these patients with hip fragility fracture. And you can see there's two groups. One is a non-diabetic group, other is a diabetic group. Diabetic group patients and non-diabetic group patients, at the baseline data, if you see, all are comparable with relation to gender, age, except HbA1c is expected to be high in the diabetic group, then serum phosphate, PTH, and even the bone mineral density was also comparable between the diabetic and the non-diabetic individuals. So when we did this microstructure analysis of these patients, and you can clearly see that non-diabetic bone is much better as compared to the diabetic bone. So that is direct evidence that microstructure analysis is much more poor in the diabetic individuals. Further, bone volume fraction, which was much lower in the diabetic individuals. Trabecular thickness, again much lower. Trabecular separation was high. That indicates that bone microarchitecture is poor in the diabetic individuals. Then trabecular number was much lower in the patient of diabetic individuals. So basically, microarchitecture is much poor in the patients of diabetes as compared to the non-diabetic bone, and that is predisposing for the fractures. Further, we analyze the bone composition, and you can see the non-diabetic individuals versus the diabetic. There is mineral to matrix ratio was much better in the non-diabetic as compared to the diabetic individuals. Another important factor is that bone which is dehydrated in patients of diabetic as compared to non-diabetic, the water content was much less in the individuals of the diabetic. So that further predisposes for the fracture. Further, we did this nano indentation. So nano indentation is nothing but that is a procedure where you just insert a needle, will go into the bone and come back, and how much time it is taking inside to go and then come back. So that is called nano indentation. And nano indentation is assessed by the modulus as well as the hardness. So you look at this modulus. So modulus is nothing but elasticity. So you see the elasticity of diabetic bone is less as compared to the non-diabetic bone, and hardness, which is we say usually that diabetic bone has a better bone mineral density, but at the nano indentation level it is shown that the non-diabetic individuals are having the better hardness as compared to the diabetic bone, and that is probably responsible for the more fractures in the diabetic, because if you throw a piece of glass versus throw a piece of wood, wood will not fracture but the glass will fracture. So the bone in the diabetic individuals is like a glass, and that's the more fractures are there. And this was the analysis of the trabecular bone, and this is the analysis of the cortical bone, and it is again showing clearly that cortical bone is also more cortical porosity in the diabetic individuals as compared to the non-diabetic individuals. And further, the cortical porosity, which is you can see here, that is much higher in the diabetic individuals as compared to the non-diabetic individuals, as well as mean canal diameter, which is also again higher in the diabetic individuals as compared to the non-diabetic, further predispose the cortical bone also, poor microarchitecture in the cortical bone. So we know that it is very difficult to take a bone biopsy because these are the individuals who underwent hip fragility fracture, so we are able to collect the bone. But otherwise, we want to take a bone biopsy, it was difficult. So what we did is that, in this particular study is that, we collected the nail of these diabetic individuals and non-diabetic individuals, and you see that three groups were there. One is the healthy individuals, the HbA1c of less than 5.9%, diabetes with controlled diabetes, so HbA1c between 5.9, more than 5.9, but less than 7.5, and uncontrolled more than 7.5. when we assess these fingernail quality with these all parameters, so we look at the porosity. So the porosity in healthy bone is looking like that, in diabetes with controlled is like that, and uncontrolled is like that. So porosity is much more higher in the individuals with uncontrolled diabetes. Then we look at the surface property of surface roughness, and that you can see the healthy individuals, diabetes with control and uncontrolled diabetes, and probably this is we see in our clinical practice also, that individuals with type 2 diabetes often complain they are having the brittle nails. Then we did that nano indentation of this nail, and we can see that healthy individuals have the better modulus as compared to the uncontrolled diabetes, and that is probably a mechanism that bone in the type 2 diabetes is having the predisposed for the more fractures. And the reason selecting the nail is that nail cycle is of the 3 months, and that is very simple explanation. When we treat the fungal infection for the nails, we give the antifungal treatment for 3 months, and the bone cycle is of the 3 months. So that is going hand in hand. Further, when we collected these patients' nail as well as the fragility fracture patients' bones, and that goes hand in hand with the sugar to matrix ratio in bone, that is going straight line, as well as relative CML content in bone and the nail, that is also going in a straight line. So you can use nail as a surrogate marker instead of bone for the assessment of the bone health in patients with the diabetes as well as the healthy individuals. Now next question comes is that if an individual with type 2 diabetes having osteoporosis, what to treat, how to choose a drug. So we did a study where we compared the efficacy of zoledronate, denosumab and teriparatide in postmenopausal women with type 2 diabetes. So this was a prospective randomized open label blinded endpoint trial, single center pilot study, and what we found is that we randomized these patients to the 4 groups. One group teriparatide, another zoledronate, next denosumab and the control. So each group has 33 patients, and we analyzed their data, safety analysis, 72-week efficacy analysis, as well as the baseline comparison. So at baseline, all parameters were comparable. And then you look at the teriparatide, effect of teriparatide. So that is showing this anabolic window is maintained and is still open, and more bone formation is there with the teriparatide. Looking at the primary endpoint, change in the lumbar spine and femoral neck, aerial bone mineral density 72 weeks, and it is clearly showing that teriparatide bone mineral density gain is much better in the lumbar spine as compared to other 2 groups. Of course, in the control group, that is decline in bone mineral density as it was expected. In the femoral neck, zoledronate fared better as compared to the teriparatide. So when we see a patient of type 2 diabetes with osteoporosis, and if we see that bone mineral density is lower at the spine, then maybe teriparatide is the best choice. If it is poor at the hip, then zoledronate or denosumab may be a better choice. But otherwise, type 2 diabetes is a state of reduced mobility, and in that case, you can use teriparatide. It is an anabolic agent rather than an anti-resorptive agent. So looking at the fractures, so obviously clinical major osteoporotic fracture, that was in control group, there was 2 fractures in 72 weeks of follow-up. In treatment group, none of the patients had their fractures, and the common site was the distal radius actually. So when we look at the their microarchitecture analysis of these patients with the high resolution peripheral QCT, and what we found is again that patients with the teriparatide is showing better total volumetric bone mineral density as compared to the denosumab and the control group. Then bone volume is comparable in these 2 groups, teriparatide and zoledronate compared to the control and the denosumab. Trabecular number was much better in the teriparatide, probably because teriparatide is an anabolic agent, as well as cortical porosity was much higher in the control but less in the patients of teriparatide and other these 2 groups. So it is again, this study is clearly showing that microarchitecture improvement is there with the anti-osteoporotic treatment, and maybe teriparatide is one of the best ones. And then radial HRPQCT, that parameters for the tibia, and the radial parameters again showing the teriparatide is better as compared to the zoledronate and the denosumab in the patients of the at the radius. And the cortical porosity is much lower in the teriparatide group, treated group as compared to the control. So that is again favoring that teriparatide may be a good choice to treat patients with type 2 diabetes for the osteoporosis. And when we assessed these patients for the falls, and we found that any anti-osteoporoid treatment will reduce the fall. The mechanism is not very clear, but maybe patient is more aware that they are on some treatment and there is less fall because of their awareness. Now coming to the next part, that is that lot of anti-diabetic agents might cause the poor bone health. And the two common drugs, those are known that might reduce the bone mineral density or increase the risk of fractures. The first drug is that GLP-1 receptor agonist. So GLP-1 receptor agonist is protecting almost every organ, but the results on the bone and what happen is not known. So what we did is that we analyzed the effect of the GLP-1 receptor agonist, that is your semaglutide oral tablets, and we followed these patients, and what we found is that in this prospective study, 14 milligram of semaglutide at the end of 52 weeks, that there is no significant alteration in the microarchitecture from baseline to at the end of the 52 weeks, meaning by that GLP-1 receptor agonists are safe to treat this patient of type 2 diabetes. So these were the key findings, that is mild increase in the tibial volumetric bone mineral density, the HRPQCT from 370 to 332 milligram per centimeter cube, and males there is a significant improvement in this value, but then female there is no significant change. So you can conclude that GLP-1 RAs are safe to treat in patients of type 2 diabetes. There is no harm to the bone health. Further, another drug which is notorious, and maybe Canvas study showed that there is increase in the risk of the diabetic foot amputation and might be affecting the bone health. So we studied again SGLT2 inhibitor in a prospective study, and where we compared the dapagliflozin with the standard therapy for management of type 2 diabetes and a randomized control trial. And what we found is that again this SGLT2 inhibitors at the end of 12 months of assessment, DEXA, HRPQCT in bone turnover markers, there is no significant at 26 secondly higher trabecular and cortical thickness, but also increased cortical porosity at radius dapagliflozin at 26 weeks, but at the 52 weeks this difference was not significant. So this again at the microarchitecture level we can say that there is no significant harmful effect of the SGLT2 inhibitor on the bone health with the treatment with the SGLT2 inhibitors. So these are the more information that type 1 diabetes individuals are predisposed for the poor bone health. So at the end of presentation, I'll conclude that diabetes is associated with increased fracture risk more in type 1 diabetes compared to type 2. Bone quality is compromised in diabetes of all compartments, whether it is a cellular compartment, whether it is collagen compartment, or whether it is bone marrow compartment, and it is equally affect the cortical and trabecular bone. Further, fracture outcome is poor in diabetes, and drug of choice for osteoporosis diabetes, I can say maybe this older slide, so teriparatide is preferred or the other drugs. And I would like to thank my faculty colleagues and the students for helping me to make this presentation. Thank you very much for your patience.
Profusely thank you, Professor Sanjay Kumar Vadada. Your talk was a fountain of information. As this is an oration, there would be no questions, but I am sure Dr. Vadada would be available for a couple of few minutes more before he proceeds to Kolkata to answer in any of your queries off stage. I once again thank Dr. Vadada for taking the time to travel all the way from Chandigarh to Durgapur and to enlighten us. We felt encouraged by your gracious presence. Thank you.
Thank you, sir, for your enriching session. I would like to, sir, please stay on the stage for a group photo. I will request our audiences to give a warm round of applause for our dignitaries, sir. Thank you, sir. So for our next session, I would like to welcome Dr. Rajan Pali, sir, as a speaker, and Dr. Orijit Kundu, sir, as a chairperson. Please welcome them with a round of applause.
Good evening. So I would like to request our most renowned endocrinologist, Dr. Rajan Palu sir, to please start the next session. Thank you.
Thank you. So after this enigmatic oration talk by Professor Vadada sir, this is a sponsored talk, and just a disclaimer, this slides has been provided by CIPLA, and topic has been given by CIPLA. So basically the topic given to me is URLI action for physiologic glycemic management, and those who are like me was thinking what is URLI. It is nothing but ultra rapid acting insulin. Like we already have ultra rapid acting insulin in Aspart in the brand name of Fias. So this is their ultra rapid acting Lispro. This is the disclaimer that this is a sponsored CME, and it was sponsored by CIPLA. So basically my talk I will grossly can divide in three groups. First is why postprandial glucose excursion is important in our day-to-day practice, and what is the problems statement that we have with our whatever rapid acting insulin we have, and what are the benefit now this new ultra rapid acting insulin can give to our patients. So I will not go in very deep in how this postprandial hyperglycemia is related to the HbA1c. Only thing is that in South Asian population in India we have seen that it is not like the lower part of the HbA1c, the postprandial glucose is more related, rather than the in all spectrum of HbA1c, higher postprandial glucose excursion related to the high amount of HbA1c, and that's why it is directly correlated with both micro and macrovascular complication in the form of diabetic retinopathy, CV event, all-cause mortality, cognitive dysfunction. And if you see all recommendation wise, specifically in South Asian, where our diet is more carbohydrate loaded, our patients suffer more from the postprandial excursion rather than the impaired fasting glucose. And this is the physiological point of view. This is for all the basic for the PG student. Like when we eat, there are two insulin secretagogues that tells the beta cells to secrete insulin. One is directly by glucose, another is glucose or the food material which stimulate the gut hormones that we now talk about, the incretin hormones GLP and GIP, which ultimately lead to stimulation of the beta cell, and where the insulin got released after a meal. And this release of insulin occurs in two phases. Initially a first burst of insulin that we know as first phase of insulin, that is for the first 0 to 10 minutes, then followed by a steady and longer lasting phase of insulin secretion which covers the later part of the meal and post meal glycemic excursion. And whenever we try to find a good insulin for our patient, mainly for the bolus part, we try in a such pharmacokinetic model so that that model mimics our physiological insulin as close as possible. And if you see the healthy individual during the climb studies, mostly the postprandial peak occurs not at 2 hours, but somewhere in between 1 hour to 1 hour 15 minutes with a range of around 70 to 100, and largely in normal population, glucose goes beyond 140. Now, what should be the ideal gap between the mealtime insulin and the postprandial glucose control? So this is what we see. This is our, whatever in this graph, this is, this is the normal glucose excursion following a meal, and the rapid acting insulin bolus ideally should be like this, which can cover each meal glucose excursion in just superimposing like this graph, like their peak and peak action should simulate the way the glucose is getting absorbed and coming into the body, and their action will be of that particular period till the glucose excursion remains in our body. But in reality, it is very difficult to achieve. So that's why there is asynchrony in between the injection meal interval for the postprandial insulin dosing. The injection meal interval, that means when you are giving injection and when you are starting the meal. Normally for the regular insulin or the earlier insulin, it should be around 30 minutes gap. Then it came the rapid acting insulin, where the normally we use the mainly three, the Lispro, Aspart and Glulicin. Here the gap recommended is around 15 minutes. However, what happens in real life, that though we advise the patient with the rapid acting insulin with this meal gap, but majority of the patient, not only the patient, the physician, they are not comfortable with this gap. And this is a very interesting study which I found, like this was done in 26 years of age, less than age, with type 1 diabetes patient, around 5,000 in a type 1 DM clinic registry, where everybody though was on some rapid acting insulin and all of them was advised to take 15 to 20 minutes before their meal. But in reality what happened, only 21% of the patient take it before the meal, 44% takes just before the meal, 10% during the meal, and 24% even forget and take after the meal. So that's why there is the gap between, there is asynchrony between the peak of the insulin action and the peak of the glucose excursion. And if you see from this study, only 20% of our, approximate 20% of the patient maintains the meal injection interval properly, and 80% of the patient doesn't follow it. That may be that may be the reason there is a chance of postprandial excursion followed by late post-meal hypoglycemia. So this is the area that this particular newer insulin will try to bridge. And so what is the gap? The gap is that onset of action does not match the carbohydrate absorption, and the PKPD of an insulin does not mimic the physiological post-meal glucose excursion. And that's why the prandial insulin for PPG control, usually we now prefer the rapid acting insulin over the regular insulin, and ultra fast acting insulin definitely are more closer in mimicking the physiological insulin. So what do we expect? What is the problem, or what is we need from a new insulin? That it will provide a good postprandial glucose reduction for the entire period, but it will not be so long that it causes hypoglycemia before the next meal. It should be as closest as physiological glucose control, and it can ease the patient burden by allowing dosing as per the most convenient to the patient, just during the meal or just before the meal, so that the patient doesn't have to wait before taking any meal after taking the insulin. And it will definitely ultimately increase the patient time in range if you do a CGMS. So here comes the role of this innovation by this company, that is an ultra rapid Lispro, that is URLI. And what they have added two excipient to this, our common Lispro, whatever we use, that is, one is citrate and one is a prostacyclin analog, that is treprostinil. And this citrate increases the local vascular permeability, so that's why there is increased absorption from the subcutaneous tissue to the vascular tissue, and treprostinil causes the vasodilatation, so that capillaries dilate and the insulin get absorbed and come to the main circulation. So in the left-hand cartoon, you can see the hexamers of the Lispro, and it is breaking into the monomers and getting absorbed through the subcutaneous tissue, through the capillaries to the blood. And if we add these two molecules, one will increase the local vascular permeability, so that the goes to the circulation easily, and also local vasodilatation for the increased blood flow and increased absorption and rapid absorption. And if you see there this ultra rapid acting Lispro, so the peak concentration from the injection time it reaches within an hour, that is around 57 minutes. And the onset of action is 20 minutes post dose, which is 11 minutes faster than the normal conventional Lispro. And there is, for this advantage of early onset, they have a threefold greater chance of reducing blood glucose. And if you see the CLAMP study, whatever done in the type 1 DM patient, 40 patient, it have a faster early insulin action and reduced late insulin action, mimicking the normal physiological action. And this is the PD study of this ultra rapid acting Lispro in comparison with the whatever we available now, that is normal Lispro, normal aspart, and ultra fast acting aspart. And if you compare the 50% of the T max, that is the 50% the time to reach the 50% of the concentration of the maximum, it is even 6 minutes faster than the ultra fast acting aspart, and around 13 to 15 minutes faster than the normal rapid acting insulin. It is either Lispro or aspart. And what is the advantage? Like if you see the mean postprandial glucose excursion profile in comparison to the other rapid acting insulin in the healthy subject, both for the aspart, Lispro or ultra fast aspart, that the profile for overall excursion almost remains same. However, the mean glucose excursion was lowest when you are using the ultra rapid acting Lispro in comparison to ultra rapid aspart or normal Lispro or aspart. There are some few phase 3 studies also done in type 1 as well as type 2 diabetes to know the safety and efficacy of this newer molecule. So this is Pronto type T2D study, which was done to compare the role of ERLI versus normal Lispro in a basal bolus regimen in a type 2 DM patient. This was a double-blind treat to target trial for 26 weeks of duration. Half of the patient randomized and received mealtime URLI, and half of the patient received the standardized Lispro. Now if you see the HbA1c reduction, both the graphs remains almost overlapping, so there is no gross difference. That proves that this newer molecule is non-inferior to standard Lispro for change in HbA1c. And what happens in the postprandial excursion, if you see the mixed meal challenge test, and if you see starting from the early part, from 15 to 30 minutes onwards, these two graphs separates and it remains till the 4 hours of follow-up. So the postprandial glucose excursion was definitely better controlled with this ultra fast acting Lispro rather than the standard Lispro. And if with a better control and good control, it is not increasing the risk of hypoglycemia, and it is a comparable side effect or adverse event profile with respect to Lispro and ultra fast acting Lispro. So the key takeaway is that in type 2 diabetic patient in this particular study, there was no non-inferiority to the overall HbA1c control at 6-month follow-up. However, it had shown better control in postprandial glucose excursion in the 30 minute to 4 hour following a mixed meal test. Now another study that was done in type 1 DM patient, and this is known as Pronto T1D study, and here it is a triple arm study, and here they have added another arm where they have given this ultra fast acting Lispro up to 20 minutes following a meal. So there are 3 groups. One group getting Lispro that is 15 minutes before meal, another group which is giving this ELRI just before the meal, another group that is 20 minutes post meal. This is for those patients who has forgotten to take the insulin and they have taken following meals. Now, if you see the HbA1c, the primary endpoint at the end of 26 weeks of study, if you compare the three groups together, so there is no statistically significant difference. But if you see the graph, so we can say that definitely those group which has taken post-meal Lispro, they are performing less and the glycemic control is little bit inferior. However, the during meal ultra fast acting Lispro and the standard Lispro is almost similar. Similarly, if you see the PPG excursion from 15 minutes to 4 hours following the mixed meal test, the early part of the graph, there is a lesser control in postprandial glucose excursion, that is for the post-meal ultra rapid acting. However, like we see in type 2 diabetic patient, the ultra rapid acting Lispro works better than the standard Lispro in the whole of the post-meal test if it is given just before the meal. Similarly, the risk of hypoglycemia is nothing different in between 3 meals, so there is no increased risk of adverse effect. So the major advantage with this molecule is the meal time flexibility, and it is recommended that it should be taken 0 to 2 minutes before the start of the meal. The advantage is that patient can immediately take the injection and start the meal, and even though it is not as effective, but it can be taken safely up to 20 minutes following a meal. And regarding this also, like how the patient satisfaction increases when they are using this ultra rapid acting insulin, because they do not have to wait for some duration before starting the meal. It was the study done in Japan where they have seen that overall treatment satisfaction was much higher when we are using that ultra fast rapid insulin in this group of patients. However, the quality of life, there is no gross difference. So what does this new insulin offer to us for our patient? So this is a 10-minute faster onset of action with a 3-fold greater action in the early part. Duration of action is shorter by 44 minutes than the standard Lispro. So the chance of hypoglycemia before the next meal is less. It matches as closest as possible in whatever available rapid acting insulin we have with the physiological insulin secretion, increasing the fast pace. It provided better PPG excursion control with similar HbA1c control without increasing the risk of hypoglycemia. And this is their product information. It is available as an 100 unit Lispro, and like the common quick pen we can use. Practically speaking, what in our day-to-day practice, many specific areas where it can be more useful, like in those patients who are having an irregular lifestyle and they cannot predict their meal time. In those patients, we do not know how much meal the patient is going to take. Like sometime in critically ill patient, in CKD patient with a risk of vomiting, we do not know how much meal this going, how much amount of calorie the patient is going to take. In this group of patient, we can see the patient how much the consumption level, and then accordingly we can decide sometime the insulin dose. So these are some practical advantage of using this insulin. So thank you for your patient hearing. Yes, sir. Depending upon the regimen, whatever you are using, what is basal plus or basal correction, the number of prick will remain the same. Only advantage is that the gap between the meal and the injection time can be reduced, and it can be taken even after meal also. Much more physiological.
Thank you, sir, for your wonderful discussion. So just one question, sir. Sir, what is your recommendation that it should be taken just 1 or 2 minutes before or 15 or 20 minutes? Or what is the practical recommendation?
If you see that whatever the minimum data they also have, the recommendation is to take 0 to 2 minutes before the meal. So it gives the best result in the form of similar HbA1c reduction and also better control of the postprandial glucose excursion in mixed meal test. However, it can be taken up to 20 minutes after the meal, up to this duration. However, the best effect is seen if it has been taken 0 to 2 minutes before the meal.
What about the hypoglycemia chances?
The risk of hypoglycemia is similar when it's compared with the standard Lispro, and even after taking up to 20 minutes later of the meal, the hypoglycemia doesn't increase with respect to like the normal Lispro. So that is the advantage. But recommendation is 0 to 2 minutes before the meal only.
Thank you, sir.
Suppose there is variations of meal amount, then can there be any changes of doses of this ultrasonic?
Sir, I didn't get the question.
Suppose there is variation of meal amount, that what you are talking about the CCU. So can there be changes in the doses?
Yes, sir. Because we can give the insulin after completion of the meal. So that time the attending physician can decide how much insulin this patient need, depending upon the carbohydrate count or seeing the patient's overall values.
And will not it cause the roller coaster effect?
No, sir, it will not cause roller coaster effect because there is no increased risk of hypoglycemia and the duration of the insulin is less. Normally what happens if we give the regular insulin, why we do not now advocate the use of sliding scale of insulin, because the roller coaster effect, but here the action will prolong even after the blood glucose goes down. But as the duration of action is low, it will not cause the post-meal hypoglycemia.
Thank you, sir. So
Thank
if
you.
there are no other questions, we can move to the next session.
Thank you, sir. Sir, I would request you, both of you to stay on a stage for a photograph. I would also request Arindam sir to felicitate Dr. Orijit Kundu and Shamal Kundu sir on the side dais. So we are slowly coming to the final session of today's academic session. The science of metabolism lies at the heart of modern medicine. Understanding metabolic disorders is essential for improving patient outcomes and preventing long-term complications. I request Devi Prasad Ghatak sir for moderating today's final session and introducing to us to our speaker and our chairpersons.
Hello, good evening. I am starting the concluding portion of today's program. Nuances in metabolic disorders. I am inviting chairpersons Dr. Pradeep Ganguly, Dr. Boidhayan Dasmunshi, and Dr. Shomi Goswami. Please come on the stage to take their chairs. The topics are little bit atypical, I think. একটু মজারও বলা যেতে পারে, because your brain cells are already tired. সকাল 9টার থেকে এত পড়াশোনা হচ্ছে, your brain cells have been super saturated. So in that way, first topic is metabolically healthy obesity, whether it is a myth or reality. There is lot of dimensions of the obesity. Metabolically healthy, metabolically unhealthy, metabolically lean obesity, so on and so forth. So speaker on this topic, Dr. Kollani Sridharan, you please come to deliver your oration on metabolically healthy obesity, myth or reality. That is the first item.
Hello, good evening all. I thank the BDCON for giving me this opportunity for this talk. So today I'll be talking about metabolically healthy obesity. So this is a very controversial sort of a topic, and this debate has been going on for decades now. So let me take you through this interesting topic. So I'll talk what is MHO, what are the risks of metabolically healthy obesity. I'll discuss a few slides on pathogenesis, and then what is the clinical relevance and clinical implications of this concept. So let's begin with what exactly is the term metabolically healthy obesity. So where did the concept arise? So first in the 1940s, a scientist named Weig described the adipose tissue distribution in obesity. So he discussed that in obesity, it's not just the amount of fat, it is also the way fat is distributed that matters. Then somewhere close to 1980s, then Ruderman et al. Introduced the term metabolically obese normal weight. So this is a group of people who are not obese, but they are metabolically obese in the sense that they are metabolically unhealthy but normal weight. And he showed that this group of individuals have a greater risk of greater insulin resistance and greater risk than metabolically healthy normal weight people. So this concept of metabolic health came around in 1980s. Later in 2001, Sims et al. Was the first person who introduced this term, metabolically normal obese or metabolically healthy obese. So he described a kind of an opposite spectrum, that is metabolically obese persons who have a normal metabolic health. So this concept first came around in 2001, and then in 2008, two groups of scientists working on this characterized people with obesity into subgroups depending on the insulin sensitivity and using a stricter definition of metabolic syndrome, which was in vogue by then. So after 2008, around 2009, a lot of publications are there about this concept and about the clinical implications and a lot of controversies as well. So what exactly is metabolically healthy obesity? So this is one of the few definitions. So the term is used to classify people with obesity into a subgroup in whom cardiometabolic risk factors other than a high BMI are largely absent. So basically these persons are obese defined by the BMI cutoffs, but they are otherwise metabolically in good shape. That is what the term generally means. But the problem starts now. So if you characterize people on two grounds, that is metabolic health and body weight, so you get four groups of people. One is metabolically healthy, normal weight, that is they are metabolically healthy and the weight is also normal. Another is metabolically unhealthy but normal weight. So they are not obese but they are metabolically unhealthy. The third is people are obese but they are in normal metabolic health, that is the metabolically healthy obesity. The fourth is they are metabolically unhealthy and they are obese. So this is the way, these are the four subgroups when you categorize people based on metabolic health and obesity. So what is the definition? So now there are two concepts in the name itself. One is metabolic health, another is the obesity part. So the obesity definition is, although there is a lot of controversy in this, the controversy for MHO doesn't start in the obesity definition. So the obesity definition is as per the BMI cutoffs. So most commonly there are the Caucasian cutoffs, there is the Asian cutoffs. So we would go with the Asian cutoff, so you define obesity based on that. Now, how do you define metabolic health? So all the problem starts now. How do you define metabolic health to call these people metabolically healthy obesity? So if I take you back, so what happened when the concept of metabolic syndrome first came around 1960s, 1970s, was that we were looking for what exactly causes increased cardiovascular risk. And then there were scientists who suggested that it is insulin resistance which is behind or which drives the cardiometabolic risk. So this concept of metabolic syndrome then came as a surrogate of cardiovascular risk. So this metabolic syndrome again was defined by three typical definitions. One is the NCEP ATP3, one is the IDF definition, that's the International Diabetes Foundation definition, another is the Harmonized International Definition of Metabolic Syndrome. So many defined metabolic health as a surrogate, for defining metabolic health, they used metabolic syndrome as a surrogate. And for this, again, you have three different definitions. So let me take you through one definition, that is the NCEP ATP3, which is one of the most commonly used. So here we have 5 factors. One is the abdominal obesity, which is defined based on waist circumference. These are the Asian cutoffs 90 and 80. You have triglycerides, you have HDL cholesterol, you have blood pressure, you have fasting glucose. And typically the metabolic syndrome definition is 3 or more. Will give you a definition of metabolic syndrome. So now the problem is when you define metabolically healthy obesity, several teams have used several definitions. Some have said people without metabolic syndrome, which means anyone with less than 3 criteria, which means 0, 1, 2, up to 2 criteria. They have called that metabolically healthy. Now if you just come back here and see, if suppose we take a person has diabetes and a person has blood pressure, but the person is not obese, does not have dyslipidemia, and so that will still give you, put this person in metabolically healthy obesity. So there is a problem in the way you define metabolic syndrome. So one of the most commonly used definitions for MHO is obesity, because that's there in the name, there is obesity, plus you have 0 to 1 of the 4 metabolic syndrome criteria. So if you go back again, so this they will already fulfill because there is obesity, plus if they have none of this, then one of the ways you define metabolically healthy obesity is that, and that is your harmonized international definition of metabolic syndrome, where you have none of the features except waist circumference, except obesity. But not all groups have defined it this way. Many groups have used ranging from 0 to up to 2, which means that even if a person has diabetes or blood pressure, they are still calling them metabolically healthy obesity. So the problem is in the way you define metabolic health. Then, now some studies have replaced metabolic syndrome itself with absence of insulin resistance as a definition of metabolic health. So for which they have used HOMA-IR as a surrogate. So there are several studies which have used different cutoffs of HOMA-IR. Now again, what cutoff of HOMA-IR constitutes absence of insulin resistance? Now that is again, there are several cutoffs for different ethnicities, males, females. So the cutoffs have varied. So based on how they define the cutoffs, the again definitions and the criteria has varied. Some other studies have used some other components. They have said no metabolic syndrome plus elevated not elevated HSCRP or not elevated liver fat content. So they kept adding or changing the definition. So at present there is no consensus on what we define as metabolically healthy obesity. And why this is a problem? The problem is your entire the way the patient characteristic, the prevalence and the clinical implications depends on how we define metabolic health. If we don't have a consensus on that, it is going to be very difficult how we take the relevance of this topic at all. So there is a new novel definition. This has come up in 2021. This was published in JAMA. This novel definition have used systolic blood pressure, waist to hip ratio and no diabetes as the definition of metabolic health. So they have defined metabolic healthy obesity as people who fulfill all of this. So the problem, like I said, starts with the name, and probably it also ends with the name. Like I'll just take you through this. No, so let's keep the name aside and then talk about, is this a risk or is this not a risk? So many consider metabolically healthy obesity to be an intermediate risk state. They say it is not very low risk as metabolically healthy normal weight, or it is not very high risk as metabolically unhealthy obesity. So it is somewhere in between. So again, there is a controversy to this because many say that is because of the way we have defined. If we take 2 criteria of metabolic syndrome, then definitely it's an intermediate risk. But if you take 0 criteria of metabolic syndrome, then it becomes low risk. So it is in the way you define that you end up calling it a risk or not. So we go back and circle to the name. So most agree in the present, whatever agreement exists, that it is somewhere a state between metabolically healthy normal weight and metabolically unhealthy obesity. So if there is a risk, what is the main risk we are concerned about? It is the cardiovascular risk we are talking about. So most of the studies, there was a systematic review meta-analysis on this as well, which gave a CVD risk estimate around 1.4 to 1.5 times as compared to metabolically healthy normal weight. All agree on one point, that is, it is definitely metabolically unhealthy obesity has at least 10 times greater CVD risk. So MHO is definitely a low risk state as compared to MUO. But whether it is the greater risk or equal risk to metabolically healthy normal weight is a question. Now interestingly, there are studies which have compared metabolically unhealthy normal weight to metabolically healthy obesity, and most have concluded that metabolically unhealthy normal weight has a greater CVD risk. So which means that if you define metabolic health, that is more important than probably BMI definitions. So it is not the weight, it is more about the way we define metabolic health that gives you the risk. Again, now what CVD risk is exactly increased also matters. Some studies have said that there is an increased risk of heart failure but not MI. So it is not universally the same risks we are talking about. So we need to be clear what risk is increased. Obesity independent of metabolic health increases risk of atrial fibrillation and therefore affects cardiac function. So the individual CVD risks differ as well. Again, is it only the CVD risk we are bothered about? Are there any other risks of MHO beyond CVD risk? Yes, there are again, various studies have showed increased risks for CKD, increased risk of cancers, increased risk of future hypertension and type 2 diabetes. Now this is interesting because if we go back to the definition, if you define MHO based on zero metabolic syndrome criteria and you are saying that in the future these people have an increased risk of hypertension and type 2 diabetes, this means that they are going to become metabolically unhealthy in some time, in the future time, which means that brings us to the question of stability of metabolic health over time. So we'll come discuss this. I'll just share with you a couple of other things. Now, in addition to all this risk about CVD we are talking about, there are a couple of things which modify the CVD risk in MHO. One of the most important factors which many of these studies probably have not taken into consideration is physical activity, diet quality and the sedentary time. So physical activity affects metabolic health, and in fact some studies have shown that patients with MHO have this low risk because they are more physically active as compared to patients with metabolically unhealthy normal weight. So correcting for or adjusting for physical activity, diet quality probably also brings down this risk. So the risk should take into consideration the physical fitness of the patient as well. So now, taking back to this novel definition which I said, that they have come up with waist hip ratio, BP and diabetes, the normal definition of metabolic health now said that the risk with this normal definition is same as metabolically healthy normal weight individuals. So they argue that with this normal definition we can say that metabolically healthy obesity is not a high risk state. So again there is no consensus on the risk as well. It again depends on how you define the MHO. So like I said before, now because it carries an increased risk of future hypertension, diabetes, definitely it's not stable. It is a transient state. Around 1/3 to half of the people convert to MUO over time. And, but again, you have a group of people who undergo this conversion, you have a group of people who don't undergo this conversion. So what we are probably clinically interested is in the group which does not convert. Now how do we know what are the factors which predict this non-conversion or which predicts this conversion? So this was a good review I found, in whom they say they give you this transition of this is a metabolically healthy normal weight individual. So over time this person can transition into metabolically unhealthy normal weight, that is he can acquire risk factors or he can stay metabolically healthy. Same thing happens with persons with obesity as well. So over time they can stay metabolically unhealthy or they can transition and acquire metabolic health or decrease the risk factors and go into a state of metabolically healthy obesity. So this transition is quite common, not uncommon at all. So MHO is probably only a transient state and we are looking at it in a spectrum between normal weight to high risk state. So what is the pathogenesis? Like I was discussing, why is it that some people are metabolically healthy and some people are metabolically unhealthy? So several studies looked at drivers of this metabolic health, and many agree that it is the adipose tissue distribution, the genetics and hormonal factors. So these underlying, there are some SNPs which have been detected which probably drive the adipose tissue distribution. And what they have found is metabolically healthy obesity people have greater gluteofemoral white adipose tissue deposits as compared to visceral adipose tissue deposition. and they have less amount of inflammation in the adipose tissue as compared to those with metabolically unhealthy obesity, where these individuals have greater visceral adipose tissue deposition, greater inflammation of adipose tissue, and that probably drives the metabolic ill health. So what are the clinical implications? Having talked so much, does it mean anything at all? So there are certain things which still can be taken home. One is metabolic health can be used in risk stratification. So when a patient comes with obesity, it is important to know what state of metabolic health is the person in. It will help in one, risk stratification, because we have shown that however you define, it is definitely a low risk state as compared to metabolically unhealthy obesity. Second, weight or BMI need not be the only target of obesity treatment. Metabolic health can be an ideal target. In fact, one review called it a low-hanging fruit in obesity management. Even if the person cannot lose weight to become normal weight, he can still bring down risk factors to gain metabolic health. So metabolic health could become one of the treatment targets in patients with obesity. So like I said, so what we are looking to is a stable phenotype, someone who is, what is it that allows some people to remain stably in a MHO state. So one study found this, a baseline higher BMI and a baseline lower lipid fat content, higher lipid fat content were the strongest independent predictors of a failed conversion from MU, metabolically unhealthy obesity, to metabolic health. So the more liver fat the person has, the higher the BMI the person has, the lesser is going to be the transition towards metabolic health. So when we look at patients with obesity, these are some of the factors which we could keep in mind and which we can then direct our weight loss strategies and make treatment targets as per that. So this is one study again which suggested that in a patients with obesity, if you make a classification based on metabolic health, we advise lifestyle, and then based on the weight loss achievement, you could have metabolic health as a target, as a downstream target, rather than body weight alone. So to summarize, metabolically healthy obesity reflects a heterogeneity of cardiovascular risk in patients with obesity. MHO have lesser CVD risk as compared to MUO and possibly greater risk as compared to metabolically healthy normal weight. But it is a transient state and transition on either side can occur. People can become metabolically unhealthy or they can go back to become metabolically healthy normal weight. Genetics and hormonal drivers drive this transition, and other factors like physical activity modulate the final CVD. This is important because even if a person cannot actually become obese to normal weight, physical activity can actually decrease the CVD risk. So phenotyping obesity by metabolic health is useful in initial risk stratification and can be one of the treatment targets. But the biggest problem of MHO is still in the name, because unless we know what it is difficult. All this is dependent on how we define metabolically healthy obesity. So thank you.
Thank you, Dr. Sridharan, for very lucid presentation. Any question from the audience?
So thank you, Dr. Kalyani. If there are no questions or comments, can we have a big round of applause for that very difficult topic that she covered? Thank you. You can have your seat there. So we move over to the next topic, and for this I invite Dr. KVS Harikumar. So if you have looked at the topic, it appears a bit different. And there's an English saying which says that if you hear hoofbeats outside, think of horses, do not think of zebras, and definitely do not think of unicorns. Which means that look for a simple explanation. This gives rise to the concept of diagnostic parsimony, where we try to find a single disease for a given patient. But can the opposite happen? Can two different types of diabetes exist in the same individual? So to take us through this interesting topic, we have none other than Dr. KVS Harikumar, who is a consultant endocrinologist and also the secretary of the Endocrine Society of India. Over to Dr. Hari to take us through the topic.
Thank you, Dr. Soumik, for the kind words, and good evening, everybody. Thanks to BDF for the invite. As has been rightly said, diabetes looks very simple to treat, but sometimes it gives you such challenging situations that you don't actually know what you're treating.
And mind you, my presentation is completely two-way. So I request all audience to participate because whatever is are the question answer session what I will be speaking on. Okay. So I'll cover under the following headings. Why when to think beyond typical diabetes. Some of the clinical cases what we have seen and what we have published I'll show you. Some of the classical features I'll tell you subsequently. Okay. Diabetes is simple definition, metabolic disorder, hyperglycemia, there is no doubt about it. But important thing to know, the diagnosis is important because all your complications, all your follow-up, all your prognosis is based on what you define, how you label a particular patient. Second important thing, type 2 DM is actually a diagnosis of exclusion. If you have antibodies, it's a type 1. If you have pregnancy, it is GDM. If you have pancreatitis or other known secondary causes, it is secondary diabetes. You don't have any of those, then you call it type 2. That you have to rule out so many secondaries is the question mark. And most of the times, patient may come only with diabetes, with some other thing lurking inside, and you label and treat them as a diabetes for a long time. Okay. So you have different spectrum of diabetes. I'm sure all of you would have seen in the practice. Somebody using Dianyl for 30 years, somebody using metformin only for 40 years with good control, but somebody you fail OADs in next 3 years and you may have to give higher dose of insulin. So a spectrum of diabetes exists, the so-called type 2 DM, and somebody has actually given some different composites, different forms of it, and then said that they behave differently. Okay. So this is a background with which we have understood. Now I'll go with the questions. 42-year-old lady, diabetes and hypertension for 3 years and 8 years, headache, menses irregular, difficulty in climbing stairs, weight gain despite efforts to lose, BMI of 33, easy bruisability and striae with cervical hump. What is the diabetes? Please speak loudly. Very good. So I don't have to give this clue. So it is understood that it is Cushing's. Okay. So all of you are aware about this. Different mechanisms how Cushing's can cause hyperglycemia that you can read out, but not much relevant because they present with only diabetes and hypertension. They don't come with the florid picture as what you want to see in a textbook. Okay. But most of them would have been treated as a diabetic for some time. We'll go to second one. 36-year-old lady, diabetes and hypertension, lot of aches and pains in the body, dyspepsia, past history of kidney disease, BMI of 23. Examination normal. Anybody? Before I give a clue. There is enough clues already here. Okay, I'll give a clue. Spell out, this is not an exam, and organizer will give you a good chocolate if you answer before a clue. Okay, I have given a clue. Can you see something on the chest X-ray? Anything you can make out here? Very good. It is hyperparathyroidism. Okay. Most of the hormonal excess conditions lead to diabetes. Be very clear. Okay. Most of the hormonal excess conditions. And these things have a gestation or possibly a latent period of 5 to 10 years before they actually come up with the underlying endocrine diagnosis. Okay. So this was one of our patients who had primary hyperparathyroidism. And these are the different presentations. So if somebody has a diabetes, has a recurrent kidney stones, you cannot just label them as type 2 DM and keep treating or keep advising about water intake. You have to probe further. Okay. These are the mechanisms how it is caused diabetes. Okay. Third patient, 48-year-old lady, diabetes for 1 year along with hypothyroidism, irregular menses, consulted couple of gynecologists for it who attributed it to perimenopausal age group, poor glycemic control, darkening of skin, generalized, BMI 22. Addison's disease is the biggest kuwa which everybody enters. Please understand, whenever you have a glucocorticoid insufficiency, your diabetes improves. It doesn't worsen. I have said diabetes is worsening. Any other condition? Okay, I'll give you the clue here. You can see the patient's photograph 5 years before and after, and bottom image is her daughter and the patient's hand. You can see the change in the color. Yeah, absolutely. It is something known as bronze diabetes. Okay, so people will have different spectrum. They will have worsening of control. Okay, so again they are labeled as diabetes only. Different mechanisms how iron deposition can cause diabetes. You need to understand that. Okay. Okay. 35-year-old male, diabetes for 2 years, hypertension for 6 years, aches and pains and arthralgia, acne, oily skin, headache, coarse faces. Do you have to read further? Okay, fair enough. So this is the easier ones. Okay, so these are some of the things which can come up so early, and then you can make out that the patient has got something which is acromegaly. Okay, and different mechanisms how your GH excess can cause hyperglycemia in a given patient. You will have reduced uptake, kidney, liver, everywhere it is involved. Okay. Okay, this will be interesting. 18-year-old lady, girl rather, primary amenorrhea, known diabetes at 14 years of age, on a basal bolus regime, not well controlled, requiring about 80 to 100 units of insulin per day, BMI of 17, muscular features, eruptive xanthoma. Any diagnosis? Do you want the photo? So this is eruptive xanthoma, acanthosis, very severe hypertriglyceridemia. Okay, you can see the features, muscular features. This is lipodystrophy. They will have severe insulin resistance. Whatever number of units you may have to use, they will still be requiring higher dosages. You may have to use pioglitazones, metformins and all other things whenever you deal with such patients. Why different? Lipodystrophy is a severe insulin resistant state. So you require a very high doses of insulin. Okay. So different comorbidities, commonly they have hepatosplenomegaly, acanthosis, all those things. It can affect every organ. Partial, generalized, different variants exist. Okay. 62-year-old lady, diabetes for 1 year, hypertension for 15 years, multiple subcutaneous nodules, inadequate BP control. This is the clinical image of the patient. Diagnosis. In the inset, I have given you what is the diagnosis. But what is in the outset? What are the arrows and other things marking? She was diagnosed for the first time with that endocrine condition at 62 years. All 15 years she was taking as a plain and simple hypertensive patient with so many lesions floating around in her face, body. Very good. FIO along with? So NF1. It's a neurofibromatosis, axial refracting, macules. You have everything there. Okay. But everybody labeled her as only a hypertension type 2 DM. Okay. So these are important things. You need to keep your eyes, ears, everything open to pick up these things. Different mechanisms as to how a diabetes can be due to a catecholamine excess. These are only for exam purposes or resident purposes, not much for the practicing people. Okay. 13-year-old male, osmotic symptoms for 3 months, white patches, no candidiasis, vitiligo, A1C 10%, ketones negative. 13-year-old boy. Diagnosis? Type 1, one of the hallmarks is ketones positive, or I have not given the GAD data here purposefully, but either the ketones are generally positive at presentation and GAD should be positive. Any other? Okay, I'll give you the images here. Can you see the clinical photograph? Acrofacial vitiligo, and the diagnosis is given with an arrow in an abdominal CT. Diagnosis? There is a huge cyst lying there. It is a pancreatogenic diabetes. Okay. This we were 100% sure about type 1, but when we looked at GAD being negative, ketones being negative, we thought it's an early presentation. And when we looked at the imaging, he had a past history of unexplained pain abdomen, which turned out to be a pancreatogenic diabetes, chronic cyst in the pancreas. We all have heard about the type 5. There are some differences between the so-called pancreatogenic diabetes and the malnutrition related diabetes. By and large, you will have a persisting undernutrition in the type 5 diabetes, mostly seen in the young adults, whereas pancreatic can happen at any age. Here you will require insulin and pancreatic enzymes. There you will require insulin plus nutritional support. Most of them are ketosis resistant, antibody negative. Okay. This is the last case. 18-year-old female, incidental hyperglycemia, which was detected when she was actually at 18 years of age. A1C 8.6, GAD positive, ketones negative. Diagnosis? Very good. She was given metformin initially because of asymptomatic nature. Continued for about few months with metformin alone, not improved. Gradually other OADs were added with sitagliptin, pioglitazone, and including empagliflozin. This was over a period of 4 years, from 22 to 25. And her brother had a protein-losing enteropathy. She has a strong family history, both parents diabetic, maternal uncles diabetic. Diagnosis? At presentation, ketones negative, antibody positive. And I have given you the whole exome sequencing finding as well. 18 years. Initially at metformin, but subsequently 4 drugs. Mitochondrial could be a possibility, but generally they present in 3rd decade or so. This is a case of lady. The LADA is the term which is used when it is above 30 years. Any autoimmune disease which is slowly progressive in younger age group is known as lady, and we have a whole exome sequencing which suggests that it's a MODY as well. Okay. The carboxyl ester lipase is a MODY 8 phenotype, and you have an unusual combination. This we published just few months back. So diagnostic criteria, if you look at of different LADA versus MODY, generally LADA is above 30 years, at least 6 months of defining period of non-insulin requiring is required, and MODY you will have strong family history, early presentation, all those things. Okay. So because she was asymptomatic, only 8.6, it was an incidental hyperglycemia. So incidental hyperglycemia, 8.6, single drug, which is a time-tested drug, no other drugs. Age is not factored. Metformin can be given at any age. So, as Chase has rightly said, what are the clues to suspect against Occam's razor is important. Okay. So, in history, if you have very early onset diabetes, hypertension preceding diabetes, usually diabetes precedes hypertension in a conventional type 2 DM. If hypertension precedes, you have any stones, arthralgia, myopathy, all those things. Deafness, skin changes, strong family history, all those things you need to look beyond a conventional type 2 DM. Examination, you should look at striae, acanthosis, warts, non-obese requiring very high doses of insulin, deafness, all those things, bony lesions, fractures, stones, these are all important. In the investigations, you will have to look at unusually high triglycerides. Somebody may have non-obese triglycerides of 700 or 800. You may have to think beyond, okay? Persisting C-peptide, it is not the conventional type 1 what you are looking at, okay? So all those things are important. Failure of metformin, increased sensitivity to sulfonylureas, unusual requirement of insulin, all those things will give you a clues to suspect something beyond what you actually treat. Bengal is known for culture and tradition, so I'll end up with one of this classical phenotype. This is photograph of, very good, okay. So this is a classical Mona Lisa photograph which everybody sees and identifies. What we look at as a type 2 DM so-called, okay. But there are some variations which can happen. An Indianized version of Mona Lisa also can come, masking the same one. You can have a masked version also of the particular one. You can have a Americanized version or a Africanized version of Mona Lisa, okay. So important that everything is the same, but they're all type 2 in different spectrum what you exit. But what is your job is to identify the odd one amongst the whole spectrum. That is to identify a Mona Lisa, not the Mona Lisa, okay. So that is the most important thing. I have finished here. Any questions or comments? I shall be happy.
So any questions or comments from the audience? Yes, Devaditya, please.
Sir, just a comment on the last case. The CEL variant was positive, so I'm taking that it is a like pathogenic variant was there. So in that case, it's MODY8 or the pancreatic lipomatosis variant. So there has been reported cases of pancreatitis, post-pancreatitis GAT65 being positive. And in MODY8, somewhat similar thing might happen, like deposition of fat and destruction of the pancreas leading to some spillover of the GAT65 antigen. Could that be the reason for GAT65 positivity? May it be only MODY8 and not lady plus MODY?
See, actually, initially we have never worked up for the exocrine deficiency. Initial workup was only the GAD positivity and only OAD being continued, okay. The whole exome sequencing subsequently we have done, initially they couldn't do. Because of the protein losing enteropathy, we thought 100% it was a MODY. And it did not, the brother did not have anything, but this girl had a cellate. She still has a mild pancreatic exocrine deficiency, which is off late, 4 years into the spectrum of diabetes. So very unlikely that this could be a spillover of pancreatitis causing, because if 4 years of untreated pancreatitis, she would have been significantly progressing well, which is not the case. I have added insulin only at the 4th year. If it is a secondary diabetes of pancreatitis, she would have required insulin very early in the course. Being non-obese, early stage, I would put it as more or less a coexisting unexplained diabetes, a variant presenting there.
Thank you, Do you have more questions? No.
No,
okay. So thank you, Dr. Hedy.
Thank
Can we have a big round of applause again?
Thank you, sir, for your wonderful session. Now, I would like to call Dr. Budhan Dashmunshi, sir, to chair next session, and Dr. Raviranjan Shomondol, just for as a speaker. Sir, please take stage. Dr. Budhan Dashmunshi, sir, is from Kollani AIMS, and we all know Dr. Raviranjan, so please. Is yours.
Good evening, respected chairpersons and all dignitaries. So this is the second time today I am on the dais again because my teacher, Dr. Pratik Das sir, is absent. He was supposed to deliver this talk. On behalf of him, let's see how I can justify to the topic. So today's evening we have a topic of non-diabetic kidney disease in diabetic patients. So we'll be going through all these things like clinical paradigm and epidemiology, clinical red flags, pathological deep dive and etiologies, clinical case, comprehensive treatment protocol, multidisciplinary action plan, conclusion, and take-home message. So learning objective is we have to differentiate between diabetic kidney disease and non-diabetic kidney disease using definite red flag signs. And we should recognize the histopathological spectrum of both the entities. Specifically, the non-diabetic kidney disease differs from that of diabetic kidney disease that they can involve a particular part of the glomerulus. It can be of the nephron. It can involve the glomerulus. It can involve the tubulointerstitial system or the vascular system. And we have to apply certain diagnostic protocols or tools. We have to identify those specific patients who might have a non-diabetic kidney disease rather than a diabetic one. And then we have to perform renal biopsy in most of the cases. And based on the present evidence-based treatment protocol, we have to apply quadruple pillar therapy for the diabetic kidney disease and other disease-specific immunomodulations and immunosuppressions for non-diabetic kidney diseases. And we should apply multidisciplinary approach to diagnose these cases. So the clinical paradigm. So how a diabetic kidney disease typically presents to us? A long-term diabetic patients, maybe 10 years or more, who has established diabetic retinopathy, gradual stepwise progression from micro to macroalbuminuria. Nowadays they are being coined as moderately increased albuminuria and severely increased albuminuria. The term has been changed because this is not associated with the size of the protein, it's the quantification of the protein. There is slow, steady GFR decline of around 12 ml per minute per year, so it's around 1 ml per minute per month. I don't consider it as slow progression. I myself consider it a very fast progression of diabetic kidney disease. And the kidneys are usually symmetrical and they are not shrunken or small in size. They maintain their normal size. How the non-diabetic kidney disease patients presents to us, similarly they can have a long duration of diabetes, but they have pristine fundus. There was no diabetic retinopathy. Abrupt onset of nephrotic syndrome, rapid GFR loss within weeks, and presence of active sediments. On the its left-hand side, we can see that on the top of the pictures, it's isomorphic RBC, which is always present, which can be present, but the presence of dysmorphic RBC or RBC cast or a WBC and WBC casts, they are known to be as active urinary sediments. When they present in the urine microscopic examinations, they point towards non-diabetic kidney disease rather than a diabetic one. So we have to know what is actually a diabetic kidney disease, what is a diabetic nephropathy, and what is non-diabetic kidney disease. So we all know the definition of diabetic kidney disease is progressive loss of GFR, maybe around less than 60, persistent for 3 months or more, associated with some amount of proteinuria. How it is different from diabetic nephropathy? If it is histopathologically proven, then it is known as diabetic nephropathy. What is non-diabetic kidney disease? Are patients who has similar picture of loss of GFR or proteinuria or a combination of them, but this is not pathologically fitted with the diabetic nephropathy. So we can have some other etiologies or entities which may or may not be presenting with diabetes. So diabetes is not, diabetic kidney disease is not synonymous with diabetic nephropathy, and again non-diabetic kidney disease is different from all of them. So we have, what therapy we have for this kind of patients? For diabetic kidney disease we have supportive therapies, RAS inhibitions, SGLT2 inhibitors, non-steroidal MRAs and GLP-1 receptor agonists. On the other hand, for the patients who are suffering from non-diabetic kidney disease, we have targeted immunosuppression, disease-modifying biological agents, and these therapies, we can delay the progression of the chronic kidney disease towards end-stage renal disease if we can identify them early and treat them early. So around 40% of the diabetic patients are having some kind of diabetic nephropathy in their life, and this is the most common cause of kidney disease in India and all over the world. Out of these diabetic kidney disease, which we are supposing that this is probably a diabetic kidney disease, around 30 to 50% in different studies, they are actually because of the non-diabetic kidney disease rather than the diabetic kidney disease itself. And if we can identify them early, more than 80% of these patients can achieve their remission if they are being treated with disease-specifying agents. So what are the histopathological features of diabetic kidney disease or diabetic nephropathy? They are thickening of glomerular basement membrane, mesangial expansion, KW lesions or nodular glomerulosclerosis, which is pathognomonic, and arteriolar hyalinosis. From top to bottom, we can see the first picture showing thickening of the glomerular basement membrane and mesangial expansion. Second is showing the KW lesion, and the third is showing vascular hyalinosis. So this type of kidney disease usually happens when the duration of diabetes is around 10 years or more, and in type 1 diabetes it can be after 5 years of diagnosis. And retinopathy concordance in type 1 diabetes, around 95% of these patients will have diabetic retinopathy, whereas 65 to 75% of these patients in type 2 diabetes will be having diabetic retinopathy. And this kind of diabetic kidney disease actually follows the Mogensen staging criteria, where there will be in the very beginning hyperfiltration leading to increased GFR, like your GFR will be around 150 or so, and this will finally lead to renal hypertrophy. The second stage is the silent stage, where the GFR will be normal, but the structural changes of histopathology will already start. The stage 3 is incipient nephropathy, where we can find microalbuminuria. The stage 4 is overt macropathy or macroalbuminuria. This is the stage where the GFR starts to lose or go down. And the last stage is stage 5 or end stage renal disease. So the stage 3 and stage 4 both usually persists around 5 to 10 years. So by the time we have a loss of GFR or increased creatinine, we already are having a patient who is suffering from diabetic kidney disease for at least 10 years or so. So on one hand, we can have patients who are suffering from typical diabetic nephropathy or diabetic kidney disease alone, where we have to apply standard metabolic and cardioprotective management, expected and steady progression of around 1 ml, loss of GFR of around 1 ml per minute per month. On another side, we can have a non-diabetic kidney disease patient, kidney disease in a diabetic patient who have high potential for complete remission with targeted therapy if diagnosed early. And in the midway between them, we have some patients on histopathology, we can find both the features of both diabetic nephropathy and non-diabetic kidney disease. They have the worst prognosis. Highly time sensitive, requiring aggressive dual management is required for them. So what are the bedside clinical flags, red flag signs by which we can identify a patient or suspect a patient to have a non-diabetic kidney disease on the background of diabetes? They are rapid loss of GFR, absence of diabetic retinopathy, presence of active urinary sediment, as I was telling, that RBC cast, WBC casts, sudden nephrotic range proteinuria, systemic or extrarenal signs that we can find that vasculitic rashes or patients presenting with hemoptysis. In the radiologically, we can find the diffuse alveolar hemorrhage, recurrent sinusitis, saddle nose, Raynaud's phenomenon, and the picture is showing the red the RBC cast. Short duration of diabetes is also one of the most important red flag sign. However, the diagnosis of type 2 diabetes is delayed, often delayed. So we often find patients who have come to our clinic with stage 3, 4 or 5 diabetic kidney disease, and that they have been first time diagnosed to have diabetes as well as diabetic kidney disease. Nephrotoxin exposures and asymmetrical kidneys or shrunken kidneys always points towards a non-diabetic etiology rather than a diabetic kidney disease. So rapid fall of GFR is in diabetic kidney disease, the fall is gradual, slowly progressive, and itself is a diagnostic criteria. It's usually more than 12 per year. But if there are acute kidney injury or rapid loss of GFR within weeks and without a clear hemodynamic cause like overt hypoalbuminemia or recent initiation of RAS blockade, we should think of a non-diabetic kidney disease. Absence of retinopathy, as I have already mentioned, that 95% concordance with the type 1 and 75% with the type 2 diabetes. If they are not present, then this points towards a non-diabetic kidney disease rather than a diabetic kidney disease. Many a times by doing biopsy in histopathology, we find diabetic nephropathy in these kind of patients, but we have to perform a diabetic kidney biopsy for these patients who are not having retinopathy. So whenever a patient of diabetes with renal dysfunction comes to my OPD, I always ask to come up with a retina checkup. Presence of active sediments like dysmorphic RBCs, more than 50% of the total RBCs, acanthocytes, more than 5% of the total RBCs, indicating a glomerular bleeding or glomerular origin of the hematuria. RBC casts are pathognomonic of glomerulonephritis. WBC cast strong in absence of infection strongly points towards acute interstitial nephritis or use of any offending agent or drugs in recent past. Sudden onset of nephrotic range proteinuria of more than 3.5 gram with nephrotic syndrome like edema, hypoalbuminemia, dyslipidemia, etc. Most often the diagnoses are minimal change disease, FSGS, and membranous. Vasculitic rashes along with fever of unknown origin, arthralgia, hemoptysis, and hypocomplementemia points towards diseases like pulmonary renal syndrome. Short duration of diabetes, nephrotoxin exposure. This is the most important thing because many a time we fail to diagnose this kind of acute interstitial nephritis because of the polypharmacy. We cannot identify the offending agent. Recent initiation of NSAIDs or antibiotics, including simple antibiotics like beta-lactams or fluoroquinolones, long-term use of PPI and alternative and herbal medications, they can lead to acute interstitial nephritis. On long-term use, they can lead to chronic interstitial nephritis, which can mimic diabetic kidney disease. Exposure of these offending agents right before the deterioration of renal functions strongly points towards AIN. If they are being treated, we can preserve the renal function for long. Asymmetric kidneys or small kidneys obviously points towards a non-diabetic etiology. The etiology may be because of the atherosclerotic renovascular disease, or this can be chronic pyelonephritis leading to chronic scarring of the cortical cortex and leading to chronic interstitial nephritis. So bringing it together, if we bring these red flag signs together, we can identify that the diagnosis like dysmorphic RBCs and RBC casts point towards IgA nephropathy, ANCA vasculitis, and infection-related glomerulonephritis. Biopsy is urgently needed. We have to send serology for ANCA and complements. Sudden onset heavy proteinuria points towards MCD, FSGS, membranous. We have to do biopsy. If we want to avoid biopsy, we can ask for anti-PLA2 or antibody in recent times because that by that we can identify that disease entity is probably membranous nephropathy. We are dealing with primary membranous nephropathy and the treatment is immunosuppression, and we can straightforward go to treating that patient without doing a biopsy. Serum-free light chain assays to identify the underlying monoclonal gammopathies. Unexpected AKI along with sterile pyuria points towards acute interstitial nephritis. Identify the drug, stop the drug, do the biopsy, start steroid. Hemoptysis and rapid GFR loss points towards ANCA vasculitis or pulmonary renal syndrome. Emergency biopsy is needed along with starting of immunosuppressants including pulse, steroids and cyclophosphamide. Low BP and nephrotic range proteinuria. So this is the condition which is associated with renal amyloidosis most of the time, which we should do a biopsy and identify them by doing a Congo red staining. So pathologically, these are the entities. If we do biopsy for a diabetic patient to identify some kind of underlying non-diabetic kidney disease etiology, what we find mostly are IgA nephropathy, where we can find mesangial expansion and infiltration along with IgA deposition in the IF study. They often coexist with DKD. Membranous nephropathy, again identified by histopathology and in recent times anti-PLA2R antibody. 70 to 80% of the primary cases are anti-PLA2R positive, and they carries a high risk of thromboembolic event. These patients can present to us loin pain and hematuria, which is often pointing towards a condition known as renal vein thrombosis. We can find histopathologically subepithelial spikes by silver stain and on electron microscopy subepithelial immune complex deposition. FSGS, which can be primary because of the immunological disease entity, or it can be secondary to hyperfiltration of diabetes. So histopathologically, we have to identify the presence of sclerosis in the glomerulus, and then we have to do an electron microscopy to differentiate between a primary and a secondary FSGS. Had it been a primary FSGS, we have to treat them with immunosuppression like steroids and others, and they respond very well most of the time, around 60 to 70% of the time. But if it is secondary to diabetes, hyperfiltration, then they should not be treated with immunosuppression. Rather, the diabetic kidney disease has to be taken care of. Minimal change disease, the glomerulus remains good looking or pristine. They are normal, no immune depositions in IF, and diffuse and extensive food process effacement on electron microscopy. Very well response to steroids. Acute interstitial nephritis, where we have a history of offending drugs. Histopathologically, there are interstitial inflammation infiltrates with eosinophils. They present as unexpected AKI with sterile pyuria. We can find tubular involvement like ATN, where we can histopathologically they can identify by ischemic or toxic injury and exacerbated by diabetic autonomic neuropathy also. Muddy brown casts are the casts by which we can often identify acute tubular necrosis in the background of diabetic kidney disease. So, uncommon but potentially life-threatening, missed by diabetic kidney disease becomes actually a default explanation. This is a condition which is known as renal papillary necrosis. The papilla is the triangular part at the bottom of the triangular pyramid. And here, this is the last sieving part of the filtration of and formation of urine. Whenever there are obstruction to the system of the kidney and urinary system, and there are superadded infection, these patients can have acute pyelonephritis and papillary necrosis. They can in turn lead to chronic involvement of the kidneys, glomerulus, tubules, leading to CKDs. Likewise, light chain nephropathy is superimposed multiple myeloma and unexplained severe AKI in patients of older diabetic patients. And confirmation for them requires a light chain assay. ANCA vasculitis, they usually pathologically we can find no immune deposition in IF study. Histopathologically, they have crescentic glomerulonephritis. Requires immediate intervention like urgent pulse steroids with other immunosuppression like rituximab or cyclophosphamide. One of the most important do not miss diagnosis in this entire differentials. Other diseases like atheroembolic or renovascular diseases, where we can, this situation arises frequently after post-angioplasty or after major blood vessel intervention like CABG or stenting. We can find birefringent cholesterol clefts lodged in the interlobular arteries. And renal artery stenosis we can suspect in patients who are having a resistant hypertension, as well as after initiation of ARB, if
Robbie,
these patients can...
Robbie, can you quickly wind up, because I think your time is over.
So they can have this kind of atheroembolic or renal artery stenosis, and we should confirm it by doing renal Doppler or angiography. So we can skip the cases. These are probably... One case I'd like to say that this 68-year-old male who is having a well-controlled diabetes, and he developed sudden acute kidney injury, and his creatinine went up to 3.4 from 1.1. Patient was recently started on high-dose NSAIDs for severe osteoarthritis, and urine analysis shows sterile pyuria, WBC cast without any bacteria. Histopathologically, these patients had acute interstitial nephritis, which is they have dense eosinophilic infiltrates. This patient was treated with high-dose steroids, and eventually the creatinine came down to be around 1.2, which is normal. So on one hand, we have RAS inhibition, SGLT2 inhibitors, non-steroidal MRA, GLP-1 receptor agonists for DKD, treatment of DKD, but for non-diabetic kidney disease, they should be treated with disease-specific therapies like corticosteroids, biologics, targeted immunosuppressions. So the red flag signs has to be identified by the primary clinicians or physicians, and they should be referred to the nephrologist for kidney biopsy, or identify the exact etiology of non-diabetic kidney disease, and so that they can be treated early. So thank you for patient hearing.
Thank you, Dr. Robbie, because you very graciously accepted to do it just less than, I think, 24 hours ago, and it's a huge topic. We can speak for hours at an end. Any quick questions or comments before we wind up for this day and look forward to another day of academics tomorrow? Yes, Professor Shen Gupta, I think, has something to say.
Preparing it in so short a time. As a non-nephrologist, I would like to tell others who are non-nephrologists here, for a nephrologist it's easy to pick up non-diabetic kidney disease, but it's good that you have showed the Mogensen's classification, the etiopathological pathway of diabetic kidney disease, or diabetic nephropathy as it was called when Mogensen's is described. Nobody does project this slide these days, but I think that is very important for understanding the pathophysiological course. And as you have rightly pointed out, and this should be the take-home message, as non-nephrologists, if there are tendencies towards deviation from that pathway, one should suspect non-diabetic kidney disease. Thank you.
Thank you. Thank you, Professor Shen Gupta. Thank you, Dr. Robbie. So we'll now break for dinner, and I request all of you... Okay, we also have, the organizers say I'm a part also, that we have a musical program. So as you have your dinner, you can enjoy your drinks and you can listen to the musical program as well. So I would request all of you to come here tomorrow again at 8:30 a.m. if possible, because we have our young doctors presenting their research in the morning tomorrow, followed by the regular academic sessions. So I would request all of you to join us for this musical program, for the dinner, and be here tomorrow morning at 8:30 a.m. if possible. Thank you.
Thank you. Sir, just for a group photograph, I would like to call Dr. Kollani Siddharan Madam and Dr. KVS Harikumar Sir. Please come on the stage for the group photograph.